we all get to know those partners. But we have those screens, the buttons in the sides are running the various partners. At this juncture, I want to invite the moderator for the first session. And that's Dr. Alan. Dr. Alan is one of the most brilliant district health officers that I've known. With a very powerful track record in health system strengthening, the public health specialist, but with an incredible passion in maternal and newborn health. And he has really made significant impact.
The 5th National Safe Motherhood Conference, Awards and Expo.
The National Safe Motherhood Conference is an annual scientific conference organized by the Ministry of Health and its partners. It was launched in 2021 and has since been held annually.
Happening from the 22nd to the 24th of October 2024.
We've reduced the institutional maternal mortality by 6 points, from 90 to 83 per 100,000 institutional maternal mortality.
And we've really helped to grow the Save the Mothers program as an effective movement for strengthening community engagement.
At Speak Resort Convention Center in London.
We have made progress in reducing maternal mortality ratio. Progress of 44% reduction in 5 years is remarkable. But we need more effort and investment to sustain our gains and also achieve new targets. We've developed a curriculum around the Quality Newborn Maternal Health Framework. The curriculum is to expand this around Uganda and help bring this model to anywhere and any community that wants it.
Under the theme Strengthening Multisectoral Collaboration and Mutual Accountability for Safe Motherhood.
We also need to embrace more of predictive analytics. Can we predict that this mother is likely to have a preterm birth?
So we've been working in 24 facilities, and we've seen women who are able to receive a complete risk assessment at ANC rise from about 50% and now being sustained at 100% in all these facilities.
Convened by the Ministry of Health together with its partners. Don't miss this 3-day power-packed event full of great speakers, intriguing plenary sessions, scientific presentations, policy dialogues, and interactive engagements, providing a space for learning, networking, and collective action.
And I think family planning as a development issue will deliver Uganda to the middle income sector.
We've also agreed that all our IMO facilities must establish functional high-risk clinics.
Passion in this room, if translated into actual work, I want to believe we shall end unnecessary maternal death in our facilities.
The 5th National Safe Motherhood Conference Awards and Expo 2025.
Yes, thank you very much indeed, our scientific team, for really shedding some light on how 2024 went. It was quite a very successful conference as well. And remember, we discussed phenomenal achievements. And allow me to introduce the moderator for this very first session, Dr. Alan Katamba, the District Health Officer of Buyukwe. Dr. Alan is currently involved in a number of development projects as a mentor or advisor in both rural and urban settings, with the main aim being improvement of health delivery and accessibility to all Ugandans. HIV, AIDS, sexual and reproductive health from a core the core of his main emphasis in public health paradigm. He has been instrumental in organizing conferences and meetings of this kind, and maternal and child health have always been his strong points. And for colleagues who worked with USAID, Uganda Health Activity, Dr. Alan is not a new person to a number of us. He has been instrumental in drafting a number of national guidelines and policies, and including the integrated HIV guidelines and the current HTC policy. Allow me, ladies and gentlemen, let's put our hands together for Dr. Alan as he takes the podium. Dr. Alan, please.
Thank you very much, Dr. JP, for the humble introduction. Good morning, ladies and gentlemen, and welcome to all of us. Can we all put our hands together for all of us? A very special welcome to all the implementing partners in the house today, the government officials in all your capacities, the donors, the private sector, philanthropists, leaders, and most importantly, the health workers that have managed to make it today. Thank you so much for coming to this National Safe Motherhood Conference, where we are saying, let's strengthen multisectoral collaboration and mutual accountability for safe motherhood. I know we are out of time, so allow me call upon the people that are going to be leading us in this session today. Colleagues, join me in welcoming Professor Nnabagereka Josephat. Professor Nnabagereka Josephat is the Chair Governing Board of the NSMC Institute. He is a distinguished academic and researcher specializing in women's health with a particular focus on reproductive health issues in Uganda. He's affiliated with Maternal University College of Health Sciences, where he contributes significantly to both teaching and research. His recent publications reflect his extensive research on various aspects of women's health, including pelvic organ prolapse, female genital fistula, menstrual disorders, and maternal health. Dr. Nnabagereka's research is not only academically rigorous, but has also practical implications for improving women's health outcomes in Uganda and beyond. His work on the efficacy of midwife-led orientation of birth companions and the impact of maternal support systems has been instrumental in shaping policies and practices in maternal health care. Ladies and gentlemen, join me in welcoming Professor Josephat. So the next speaker for today, colleagues, join me in welcoming Dr. Joseph Nnabagereka. Dr. Joseph Nnabagereka is the Chief Operations Officer for the NSMC Institute. Dr. Joseph Nnabagereka is the Chair of the Finance Committee for this conference that we are attending today. He has provided leadership in strategic planning and oversight for the conference. He is a medical officer with experience in maternal and child health and holds a bachelor's degree in medicine and surgery from Maternal University and a certificate in obstetrics, gynecology, and surgery from Uppsala University, Sweden. Colleagues, join me in welcoming Dr. Joseph Nnabagereka. So we are going to start with Professor Josephat. Over to you, Professor.
Thank you very much for the kind introduction. Distinguished guests, ladies and gentlemen, good morning. I am trying to observe all protocol, and good enough the moderator has gone through some of this. Let me take the opportunity also to welcome you to this very important conference on safe motherhood, and I will go through a few things of where we have come from, some of the developments that have taken place over the years, and where we should be going. I had asked these people to put one or two slides about some of the things that used to be done. I will start by saying that the Safe Motherhood Initiative, some of you may have heard about the Safe Motherhood Initiative. It was a global effort which was launched in Nairobi, Kenya, in 1987.
And this was the Safe Motherhood Initiative. And since then, it has been brought to the fore. The purpose was mainly to curb the very high maternal mortality and morbidity that was being experienced at that particular time. I should say that by that time, the maternal deaths globally were about 500,000 deaths per year. It has markedly reduced over the years, but you could see that there was a big issue that needed to be sorted. And I will even start from here by saying that it is very vivid in my mind, because when we came to for postgraduate training, one of the professors who had attended that conference, that initiative launched in Nairobi, had gotten questions to ask. So one of the essays he gave out was, write an essay about safe motherhood. And we were told that the people who were there really had to struggle with it, because most of the people had not heard about it. If we could have the slide which has some of the things that used to be done at that time. But as they do that, I mentioned some of these things that were being done in 1987. Some of the people may not even know that some of these were happening. One of them, patients who had eclampsia used to be managed in dark rooms. So labor wards would have dark rooms whereby if somebody had fits, they would be put there. So you can imagine how that would be, including how they would be monitored. We were using entirely what is called the midline Nnabagereka season. Some people call it the up and down season. That time we didn't have the finance steel season. So you can imagine, and we struggle a lot with it. So this finance steel is quite new. All the anesthesia for mothers who are going for delivery was the general anesthesia. So mothers would not even know when their babies are being born. They would be told later on that your baby is fine. So you can see where we are coming from. Cattegat was the only suture being used for episiotomy. And as you know, it is associated with dyspareunia. Mothers used to be kept on the ward for 1 week after surgery. And actually, if a mother wanted to go home like after 4 days, the health workers would struggle with her, and there would always be some form of fight. So then we had this issue of non-absorbable sutures for suturing wounds. I was managing a lot of patients. One time I visited one of the patients on the ward. She was very, very anxious. She said she had not slept for 3 nights. The reason for that is that they had told her that removing the suture was very, very problematic. That at that time we were beginning to get the absorber ones. She only calmed down when we told her that actually the suture you are having is not going to be pulled out. The nylon was being used and was it's very, very painful. It is good that some of these things have actually changed. Mothers with multiple pregnancy would be admitted. If a mother was diagnosed with multiple pregnancy after 28 weeks, that would mean automatic admission until delivery. They were thinking that bed rest would actually prevent premature labor. So I have just picked out some few. There are very many other examples that we could really look at. But the reason we are bringing this is that from the Safe Motherhood Initiative and what we are seeing today, what are some of the things that have been done and what can we improve? A slide with the indicators. So in that line, I would want to share some of the few slides, some few that I have picked out that are of use or that we could use to track some of the developments that have taken place since. And as like one of the slides that was moving around, most of the information is from Uganda Demographic and Health Survey. It is also very, very important to realize that Demographic and Health Survey, we started doing them in 1988-89. So it is not like they were being done very many years before. And as you know, they are supposed to be done every 5 years. So there have been lots and lots of developments, and we'll pick on some few. Maternal mortality ratio at that stage was about 524. And you can see how it has moved over the years. We actually also used to have mothers who would tell us, but mothers used to deliver so much in the villages, but they were surviving. So we would say bring the figures, and that's where the use of data become very, very important, because you could see that these people who are saying that the mothers were actually surviving were not right, because at that time the deaths were very high, and you see it has been coming down, 506, 505, 435, then went up slightly, 438. Some people here say it is because of the methodology that was used to calculate, went down, and now we are at 189 per 100,000 live birth. Please note that it is a live birth, and that live birth has got an issue also because the mothers who have IFDs are likely to have even maternal death, but they are not usually included in that calculation. The other one we could pick out that is of interest, supervised deliveries. You could see that for a long time it was at 38, and now it is at 91%. All of these have got very clinical, very important significance on how we can leverage on these to make sure that we save more and more mothers. In fact, one of the arguments here, some people had decided to support traditional birth attendants. And the reason was that, after all, many of the mothers were not coming to the health facilities. And you can see that was the basis. But as you know, we have reached a level where those had to go completely as more and more data was coming in. So this gives us quite a lot of having an idea of where we were coming from. Now, there is another big advantage we can see in those figures, the use of antenatal care by a skilled provider. We are aware that almost 98% of our mothers attend antenatal care at least once. And that is very, very important, because if we are to save more mothers, I could say it at this stage that we should utilize that single visit. We should actually not know that this mother will come back and we can do more tests. If we could focus on that particular single visit that has happened and we utilize it maximally, do the tests, do the history taking, that would really push us a lot. Of course, there are people who are interested in things like fertility rate. You see that it is going down, and this goes down together with the increasing contraceptive use. So it's important when we have this, then we can be able to continue moving and progressing. Now, research was at a lower level. What has happened is that over the years, we can now refer to research that has been done by authors from Uganda or from the region. And this is in terms of articles published in international journals, in terms of books. You realize that the writing has increased. And for example, Magpie was one of the trials that he brought to the fore the use of magnesium sulfate. And some of our people like Nnabagereka were involved. And it changed this issue of having people in dark rooms. There was also something called the elephant mixture. If somebody got eclampsia, they would sedate them so much that they would almost go into coma. So all these, you can see where we are coming from. Our women trial, tranexamic acid with Christian Vidyabale, manevirapine. This, you remember, was a global thing. Professor Miro, emergency contraception, initially was an issue. The speaker was one of those who participated significantly in bringing it. There are areas also which we can talk about, but which have remained only in our countries. And one of these is obstructed labor. Obstructed labor, now the only people who are writing about it are people who are in the low to middle income countries. Because for the high income countries, or what we used to call the developed countries, this is no longer an issue. In fact, even when you want funding, you find that it doesn't really come up. We are also having people who are being recognized globally. And we have had people like Nnabagereka being recognized at FIGO, Florence Mirembe, and the other week there was a FIGO meeting at Cape Town, and we had one of ours recognized, that is Professor Nashmli. She was speaking at the start of the video. FIGO is Fédération Internationale Gynécologique et d'Obstétrique. And it brings together all the obstetricians. So the reason why this is important is that having started from those indicators, having all of these people with us, is it possible that now we can actually target, continue to save more mothers as much as is possible? As a country, we have a number of figures that are so much to the fore. And the documents, we have got the issue of NDP4, which is geared towards accelerating Uganda's transition from a largely subsistent economy to a modern and prosperous society by 2040. And that also means a lot. People can only move in this way if they are healthy. And we need to see how to continue to embrace this. We have got and are part of the Sustainable Development Goals. Remember, there are 17 of them. But we have focused a lot on SDG number 3, which is aimed at reducing the global maternal mortality ratio to less than 70 per 100,000 live birth. Now, that is, to be specific, that is 3.1. On this one, I want to bring out another big part that we have to consider as we try to embark and develop and improve maternal health and newborn health. That some people, even when they are talking about reducing the maternal death to less than 70 by 2030, you will hear somebody saying that, but Uganda won't be able to achieve this. I am bringing this up because I want to bring the aspect of positive deviance, positivism, that we need to remove this aspect of some people being negative, that we want to do it. We need to move to where we can say we can do it, because we have already shown that we can do a lot by the figures that we are looking at, the indicators. And the people who have positive deviance, you can find that a society, all the people in a village don't have food, but you'll find one home in that village which has got food, and you wonder how they are getting it, and yet they are living in the same area. So that what we are talking about is that if we have these good practices, let's keep them, and let's see how we can share the good practices, best practices with other members in the group and in the country and in the society. So you can see that we have a number of figures that we are looking at: 2030, 2040, and we should have positivism, and then we shall be able to move faster. However, as far as the SDGs are concerned, we want to emphasize that we should not focus on SDG number 3, because even the others are contributory. Safe motherhood. Aspects like SDG 4, which talks about quality education, are key. Clean water and sanitation, number 6. Issues like number 2, which talks about zero hunger. Some people say, how does zero hunger contribute to safe motherhood? In very many ways. But the simplest we have is that if nutrition, childhood nutrition is poor, it would mean that a mother is this person will grow up but will have a contracted pelvis. A contracted pelvis will lead to obstructed labor, which could lead to death. So what basically this means is that for us to succeed, we have to work with many other groups, like the theme of this conference is talking about. Multisectoral. If somebody is supporting education, we should support it as well, because it will contribute to health. And if somebody is talking about nutrition, we should really do that as well. We have an aspect about Agenda 2063, but how we are bringing this in is that the maternal death that occur. I usually teach a topic where we are talking about maternal death, and I have reached a level where very many questions have come up, because we say that most of the causes of maternal death are preventable. Then when they add on the next sentence, they say most of these deaths are occurring in sub-Saharan Africa. So when you keep saying this year in and year out, you kind of get challenged. You say, what is so strange in sub-Saharan Africa? This geographical location. You can see that now we have all these people who are writing books, who are publishing, they are doing PhDs. We need to reach a level where we can get annoyed and say that some of these statements need to change. Because remember, Uganda is part of the countries in sub-Saharan Africa, and it is being counted all the time. All the deaths are there. These deaths are preventable. So all efforts should be put in place to make sure that we can prevent these maternal deaths, and also change the literature that keeps coming up from and talking about sub-Saharan Africa, which even has a lot of resources, as you know, members. It has lots of resources, including minerals that are very, very rare. So you find that we just need timely skilled care, essential medicines and equipment, functioning referral systems, and financial access is very, very important. Our partners in development, but also the country itself must generate funds. So strengthening the whole continuum basically from preconception care, antenatal care, skilled birth, emergency obstetric care, and postpartum care. We also want to urge our partners in development and all the members who are here that we need to put more funds. We need to put funds in the neighborhoods. There is an observation that most of the funds tend to be put in things which are easier to achieve. Things like immunization, which is good, yes, but if you handle these mothers who are in neighborhood with the many different parts that are needed, that making sure that all the people who are there can deliver the mothers very well, they are skilled, adequate human resources, it would be very, very important. We have to embrace digital health politically, artificial intelligence, machine reading, and see how they can come in to help us achieve all aspects to do with safe motherhood. We have also, yesterday, a new guidelines were launched for research in Uganda by Uganda National Council for Science and Technology. And one of the things being emphasized is community engagement. And there is also this big concept that has come up that we must embrace. That is nothing for us without us. And basically what that means is that if we talk to the communities, the mothers in the communities, the men, they know what they want. And we need to see how we can embrace this, consult them. They know how they can reduce maternal deaths, but most of the time, we tend not to have them on board, and at times have the health workers on board and researchers. But let's get to the nothing for us without us. I will now talk about a few things about NSMC, and basically that's how it comes in. It was observed that there was like a gap. We have the Ministry of Health, we have the professional organizations, we have universities, but when you talk to our people, it's like they need a lot more information. And so NSMC, which is now National Safe Motherhood Expert Committee, as it started, had a number of thematic areas: research and development, medical education and training, policy and leadership, quality of care improvement, advocacy and engagement, and monitoring and impact evaluation. In the interest of time, I mentioned that it has achieved a few very important things. One of the critical ones which had not come up was the essential maternal and newborn guidelines, and they took a lead in this. The local maternal and neonatal system has contributed tremendously to what is currently happening, and in terms of reducing the deaths. In fact, before the DHS figures came out, we had observed already through this LMNS that the deaths were reducing. So it was not like by surprise. What the LMNS has done, and I want to emphasize this, it has encouraged interprofessionalism. Obstetricians, pediatricians, anesthesiologists, but also people who are not directly in the health sector, like CAOs, the partners in development. You find they are on the same forum and they can quickly share. But also institutions used to run separately. Like Kisenyi is referring patients to Kawempe National Referral Hospital, and I can see the director here, Dr. Manuel Biaruhanga. And they don't communicate. So mothers just land there, the labor ward is full. So this has helped a lot in terms of warning, and also some of, for example, Kisenyi attending meetings at Kawempe National Referral Hospital. We have, the other big thing it has done is interinstitutionalism, making sure that these institutions work together, apart from the professions, but the institutions as well. And I can see Professor Pius had started the aspect of interinstitutionalism, but never moved it to very fast, so it has been taken up. Then there has been improvement in the MPDSR. And then advocacy groups for PPH, sepsis, prevention and treatment, safe birth, preeclampsia and eclampsia and PAC. And all this. So when these professional engagements would take place, you would find that there are about, initially it was 500 people, the cap. Then you realize that the need was so big that it would go up to about 1,000. And people want information, and we need to keep seeing how we can share information and have it delivered to everyone, so that we are equipped to save the mothers. We need to put ourselves in the picture that these mothers whom we see having complications, dying, they are like us, and we are assigned the duty to save each of these mothers, each of these babies you see gasping for air. What can we do to save these babies? As we are in this Safe Motherhood conference, we need to be sure that we can really handle that. And so these very many activities needed to be streamlined, to be more organized. And what has happened now is that we are, the NSMC Institute has been formed to try and streamline all these activities so that there is more coordination from that angle. And what each one of us can do in our different capacities, let's make sure that we contribute and save more mothers and save more babies. It is basically our duty to do so. Within the short time that we have, I think we have to stop at that, but I want to challenge and say that each one of us, we are starting on this part, each one of us, each one of you here, seated here, and the people you represent, challenge them. What can we contribute to save this mother who has come in with complication with eclampsia? How can we prevent it? How can we save the babies that people see having challenges in our hands? If we did that, we can be able to improve those indicators, and also we shall be able to reduce all the deaths that we have talked about. What that was demonstrating the silos. We want these silos to break. Let institutions work together. Let everyone who can contribute to maternal health have an addition, and we'll be able to achieve a lot. Thank you very much.
Thank you so much, Professor. Ladies and gentlemen, let's give Professor a very big hand clap. Very, very big hand clap. Now, you realize I did let Professor speak for some time because he was doing the ice breaking, but also giving us the preamble for this conference. The history for this conference has been laid out by him. Those of you who have lived longer than longer like some of us, you know that whatever he has been talking about is very true. So we've come a long way, and I want you to thank yourselves for being able to achieve what we have achieved as a country. As Professor was speaking, I saw a number of dignitaries moving. So many other people have joined us, and I know there will be a time for them to be welcomed. But allow me to say welcome to this Safe Motherhood Conference. Now, colleagues, again, join me in welcoming Dr. Joseph Byamgisha. Dr. Joseph Byamgisha will be taking us through the EMROC Facility Network optimization process, and I am pretty sure he will do this in less than 15 minutes. Dr. Joseph, over to you.
Yeah, thank you so much, Dr. Alan. I request that my presentation is projected. My name is Dr. Joseph Byamgisha. I'm going to present to us an EMOC facility network optimization process that we did as Ministry of Health with support from UNFPA and other partners, as you can see from the screen. So just to save you from a lot of background, in 2023, the country conducted its first EMOC facility network EMOC facility assessment in Uganda, and then from there we identified quite a number of gaps. And so from those gaps, one of the recommendations was that we should be able to prioritize on the process of upgrading and functionizing the EMOC facilities that we have in order to have services available, but also have improvement in quality. So we did this work in December 2024. Next slide. So the outline of my presentation will take us through the EMOC situation in developing countries, and then we shall look at background, which look at the country profile, then the Uganda healthcare system, which we're well versed with, then the maternal and newborn care landscape, the objectives of the optimization, then the approach that we used, methods, and then the profiles of the regions that we did, and then the key results. Finally, with the recommendations. Next. Yeah, so when data from 15 developing countries was analyzed by a team, the MDD team in Columbia University, they found out that most of these developing countries set very ambitious goals in terms of the numbers of facilities that should be functional. But then this ambition is actually way higher than what the international standards recommend. And probably I can't point, but that's the orange bar. And then the green bar is what actually that is ideal, where you find most of the countries operating from. Below the international standard, and when you include in a component of quality of care, it is even worse. So the role of the optimization process was how, instead of focusing or being too ambitious, as you can see in that first bar, we would rather have very few facilities that are functional, but then accessible by most of the population. And this is what I'm going to talk about mostly. Next. Yeah, so we can move next. We can skip this. Yeah, so this is the structure of our healthcare system. We are well versed with it. Next. Yeah, so the maternal and newborn landscape in Uganda, you'll notice that we have been making quite some progress, if you can see from those trends. From the late 90s to early 2000, our maternal mortality ratio was in 500. But as of the UDHS 2022, we have really improved, and we are at around 189. And so if you look at the under 5 mortality, and you disaggregate it into the infant mortality, but also the neonatal mortality, you can see that there has been some remarkable progress in the under 5 as an aggregate. But then when you look at the trends, for instance, for neonatal mortality, it hasn't improved as much or in the same manner. However, in terms of the opportunities that we have, institutional delivery rates, the mothers who are delivering in institutions have been increasing. So we have, according to UDHS, 86% of our mothers being able to deliver in facilities. And this is a huge opportunity. And so that would mean reflexively that those who are delivering from home are reducing. That is in the last graph. Next. Yeah, you can go next. I've already talked about that. And even the next one is just a repetition to show it just in a bigger picture. And so we can go to the EMOC facility network optimization and how we approached it. The objectives of the EMOC network optimization, the main objective was to optimize the emergency obstetrical newborn care facilities as a network. And here we considered 4 regions. That is Kampala Metropolitan in terms of the LMNSs. Then Karamoja region, Acholi, LMNS, and then West Nile. West Nile has now been divided into Yumbe LMNS and Arua LMNS, but for purposes of this presentation, they are combined. The process involved a situation analysis, and we basically benchmarked the EMOC assessment of 2023, which was mostly facilitated by UNFPA. From where we identified those different gaps, and then we're able to convene teams from the different local maternity and neonatal systems in order to plan this optimization network. That was in December 2024. And then the next phase, which we are currently doing, is monitoring and quality improvement, where we're collecting data and tracking the progress in as far as functionalizing these facilities is concerned. So in the methods, it is basically what I've talked about. We selected 4 regions, and then we support from different technical teams, that is WHO, UNFPA, Ministry of Health, University of Geneva, Mackay University. We're able to use access mode and GIS, which do geospatial mapping to map facilities and how far they are from where people stay in terms of population access. And so when we did that, we were able to come up with a network of facilities so that if we prioritize those facilities, then most of our people are able to access functional facilities. And I told you the issue here is We have so many facilities. They are very accessible, but they do not have all the services. So instead of spreading the thin resources, we'd rather focus on fewer facilities, make them functional, but they are covering most of the population. And you'll see in the results. Next. The profiles of these regions, we used, we merged data from different sources. So actually it has 8 districts, and its population size as of the 2024 media population from the National Population Housing Census was about 1.97. And so if we use the international standards of the number of EMOC facilities per 500,000 population, where we have, or we should have 5 functional facilities, of which one should be a CMOC, then we would require 20 facilities. However, from the assessment, we had only 5 functional facilities, and the gap was 15. And the picture is not different from the rest of the regions, as you can see. We can go next slide. So when we aggregated the 4 regions, the total number of facilities which were aggregated were 133. And this was from 248. And that meant that if we concentrate on 133 facilities from the 248, we can be able to achieve optimum coverage, as you can see in the percentages I'm going to talk about. The first one being, when you look at access to these facilities within 1 hour before you consider whether they're functional or not, it is high and is expected because we are ambitious. But then when you look at access to the fully functional facilities, say in 1 hour, it is 71% of the population, which leaves around 29% of our population not able to access these facilities. And after optimization, this is the aggregate for all the regions combined, you can see that access to these facilities within 1 hour is 91%, which is quite some good improvement. And if I go to the individual regions, that is starting with Acholi region, we can move to the next slide. If you look at Acholi region, the total number of facilities are 80. Those that are designated EMOC are 60. However, the fully functional, those that are able to perform all the signal functions, the EMOC signal functions, the 9 signal functions, were only 5. And so when you look at access to these facilities before you consider their functionality, you find that 1 hour coverage, excellent, 98.8%. 2 hour coverage, 99.8%. But then if you look at access to functional facilities, the fully functional facilities, you can see that we have 74.8% in 1 hour. That means about 25.2% of our mothers are not able to access these facilities within one hour. And you can imagine if someone has an emergency, how much golden time that you have in order to save this mother. And so when we optimized, you'd find that the total number of facilities included in this network for Acholi were 22. You can also, the number has gone down. The BMOC are 7, with CMOC 13, and IEMOC, which is intensive EMOC, a new classification, 2. The 1 hour coverage, 97.7. So we can bring these resources together in order to have these facilities functional and accessible within the shortest time. And so, next slide, if you look at, that's just a pictorial presentation of the same, you can go next. The picture for Kampala is not so different. The difference is that Kampala is mostly reliant on private sector, and so the facilities are so many. The access is very good. However, you can see the gaps. And you can go to the next slide, which brings out the picture, and you can look at the color codes in terms of access. And for Kampala, because facilities are too close, we're able to do 30 minutes and 1 hour intervals. The picture in Karamoja, which is the next slide, in terms of access to fully functional facilities, if you start with access to all facilities, it is obviously good before you consider functionality. But then when you consider access to fully functional facilities, you can see that in Karamoja, we didn't have a facility which was performing all the signal functions, and the other issue was assisted vaginal delivery. However, we had some part of Karamoja being able to access some facilities in Acholi at the border, that's why we have 3%. And so after optimization, we moved from 0 to 45%, which is a huge leap within 1 hour. Still wanting, but at least a good improvement. And so West Nile, the picture is not different. I'll just comment about the human resource gaps, because the optimization also looks at human resource gaps and also the referrals. Those color codes, I will not talk about the specific figures, but you can gauge the relative size of those bars. Blue is the gap for midwives. Orange is the gap we have for nurses. And then the gray is for doctors, and then the yellow is for anesthetists. This is from the 2023, we compared the situation that is in these facilities and the public service staffing norms of 2023, and those were the gaps. And then on the referral gaps for the EMOC facilities, next slide, we looked at quality of these referral linkages, that is referral from the basic emergency obstetric and newborn care facilities to the CMOC facilities. And you can see that in Karamoja, we don't have facilities that can refer, that is from PMOC to CMOC, within 2 hours. However, between 2 hours, we have about 66%, and then more than 4 hours, about 17%. And this shows you how hard it is to refer mothers from PMOC facilities to CMOC facilities in these respective regions. And you can see the picture in Acholi, which has slightly improved if you compare with Karamoja, then for Kampala, and then West Nile, where we are slightly doing well with most of our facilities being able to refer between 2 and 4 hours. And you can see that if you need 2 and 4 hours to reach or to move from a BMOC to a CMOC, then there is slightly a problem. Yeah. Then we can go to the recommendations from this work. From the gaps that we saw based on the public service standards of 2023 and the status which we picked in 2023, then we see that we need to recruit, mentor, train, and retain key cadres, that is midwives, doctors, anesthesiologists, and other essential health workers in these facilities. And then a phased annual infrastructure upgrade and equipment upgrade, because these were some of the weaknesses we saw in the facilities. Then the referral systems, the ambulance services, and how they move could be remapped to reimagine how the movement should be. Should it be an ambulance at the referral facility or an ambulance at the referring facility to save time, that little time that we have? And lastly, the comprehensive referral protocols that will guide this process. The next steps, which is the last slide, we need to discuss the norms for EMOC to contextualize from the global norms to our local norms, and then for the small and sick newborns, and including the HR and the referrals. Then the role of the LMNSs in this kind of optimization, which is work that is actually currently ongoing with support from UNFPA. And then the quality of care indicators should be monitored, because you saw that although we are too ambitious, when you factor in the quality of care, then the performance might slightly go down. And then we need to contextualize the EMOC signal functions like assisted vaginal delivery. What levels should be performing this, and then how should we assess these facilities? So I'd like to thank again UNFPA, WHO, UNICEF, the NSMC Institute, Macquarie University, and University of Geneva for supporting this work. Thank you.
A bigger hand clap, ladies and gentlemen, for Dr. Joseph Byamugisha. Now, we all accept that there is no way we can save the mothers and the children if the BMOC and the CMOC functions are not strengthened in this country. And he also brings in a very important aspect of how can the LMNSs be empowered to ensure that they take this up. Well done, and thank you so much. So, colleagues, I want you to join me in thanking Professor Byamugisha. Those of you who missed his presentation, very powerful, about the history of where we've come from, but also talking about the objectives of this conference. So thank you so much, Professor Byamugisha, my teacher, and also join me in thanking Dr. Joseph Byamugisha for the high-level presentation on EMOC optimization. Allow me hand over back to Dr. Bagala to to take us to the next session.
Yes, thanks very much indeed, Dr. Alan, for taking us through the first session. Ladies and gentlemen, we're good at time management. We're a little bit short by 30 minutes, but we shall see how to compensate. And the next session a little bit builds to some of the incredible work UNFPA is supporting in Safe Motherhood, because UNFPA was very instrumental in this optimization. So I'm very, very happy that next we are having another very incredible plenary session, and that is going to be led by the UNFPA team. And allow me, without any further ado, introduce the session moderator for this, and that is none other than Miss Priscilla Regina Nnabagereka. And a little bit about Priscilla. Miss Priscilla Regina, thank you very much indeed. Miss Priscilla Regina is a formidable Ugandan journalist and presenter, bringing over a decade of dedication from both radio and mainstream television, with a core professional vision to empower audience towards informed decisions. She's a highly valued figure at NTV, a flagship brand of the regional national media group, where she actively anchors current affairs and news bulletin to facilitate public digestion of complex issues spanning politics, economics, and human interest. Thank you. Welcome indeed, Ms. Priscilla.
Asante sana. Good morning to you, ladies and gentlemen. I know the weather this morning was not friendly as we were getting here. Many of you could use a cup of tea. So we're going to get a cup of tea from our neighbors. Turn to your neighbor and greet them in your local language. See, we're already warm. In your local language. Now, if you're seated next to a Muzungu, they also have a local language that may not be English. All right, allow me to greet you in my local language. Mwasuze mutia. Mwasuze Burundi. We wow. Distinguished guests, ladies and gentlemen, it's my pleasure to warmly welcome you to the 5th Safe Motherhood National Conference. We're deeply honored by your presence as we come together to advance health, safety, and dignity, and this is particularly for mothers across Uganda. At this point, allow me to acknowledge the distinguished guests and key stakeholders that are joining us today, observing all appropriate protocols. Government officials are from the Ministry of Health, Ministry of Finance, National Planning Authority, Ministry of Local Government, and other ministries, departments, and agencies. Your leadership and commitment to this agenda is critical to the success of our national safety motherhood agenda. We also want to recognize parliamentarians. I know that today is a unique day for them. Nominations are happening across the country, but those of you that have been able to find this matter very crucial and make it in this room, thank you so much for joining us, particularly members of the Health and Budget Committees, whose oversight as well as legislative support are ensuring that there's translation of policies into real impact. We also want to recognize foreign missions, including high commissions and embassies, whose partnership and international solidarity, it does continue to strengthen our health systems as a country. We also want to give recognition to development partners and UN agencies whose technical support, advocacy, as well as funding remain key enablers of maternal and child health interventions. We also can't forget to recognize representatives from the different professional associations. This is including the doctors in the room, the midwives, and others that are on the front line of championing safe motherhood. This can also not happen by what we heard from our previous speakers, giving us the research and the data that gives us the informed decisions that we have to make. The academia and the economists who are providing us with evidence, providing us with research as well as analysis. And this is intended to guide effective policy and investment decisions. We also want to recognize the private sector leaders whose innovation, your investment, as well as service delivery is complementing government, complementing community efforts that are currently existing. And then, of course, civil society organizations, we do recognize you, religious leaders, cultural leaders, community representatives. Your voice has been part and parcel of ensuring that safe motherhood interventions remain grounded in the lived realities of our mothers across Uganda. That being said, we are grateful for your presence and for your partnership as you each bring to this critical national agenda collective engagement, and trusting that today you're going to help us ensure that safe motherhood, it's not just a health priority, but it is a shared responsibility, and this is across sectors and society. So once again, I welcome you to the 5th Safe Motherhood National Conference, and thank you for your continued support. Now, for a long time, safe motherhood has been seen only as a health problem, one that is addressed only at the health facility or majorly at the health facility, one solved by doctors and nurses. But as a journalist, we see the wider story: the mother who dies on a terrible road, the clinic without water due to a budget delay, and the medicine stockout that is causing a broken supply chain. So today we want to turn the spotlight onto that very same system, because safe motherhood is not just about medicine. Safe motherhood is about planning. Safe motherhood is about financing. And safe motherhood is about coordination and accountability. So as we need planners, financiers, health workers, as well as the community leaders all working together from the same playbook. So our mission here is very simple. In the next 90 minutes, we hope to diagnose the problem that exists within our communities and our health sector. We also hope to prescribe the multisectoral fix that can address these issues at all levels. And at the end of the day, a vote to one of these fixes could actually save the lives of many. Giving you the background of it, Uganda has made progress in improving maternal health outcomes, as my predecessors have spoken of. The Ministry of Health's 2024 Annual Health Sector Report did show a decline in the maternal mortality rate to 189, and this is per the 100,000 live births, being drawn from 336 in 2016. So this is a step in a good direction. Yet at the same time, the realities on ground are different. 1,500 women and girls are still dying every single day, 365 days a year, and this is from preventable pregnancy-related causes. Only 64% of births are attended by skilled health personnel, and 58% of health facilities are offering comprehensive emergency obstetric and newborn care. When we look to this very same issue in the rural and hard-to-reach communities, these are facing even higher risks, especially our adolescent girls. Now, while Uganda has made the strong frameworks, including the Safe Motherhood Action Plan, the Section Reproductive Health and Rights Roadmap 2022 to 2026, as well as the Health Financing Strategy, implementation is still becoming a barrier, hindering the fragmented planning, the unaligned budgets, and of course the limited cross-sector coordination. So in this session particularly, we hope to change exactly that, moving from siloed programs to joint planning, smart financing, and shared accountability that ensures that every investment is delivering measurable impact. And this is not just for mothers, but for our newborns, which is the future of our generation. I have been duly told of you that each one of you is very important in this room. Each one of you is very important to the decisions that have to be made in this room for a multisectorial approach. Once again, my name is Priscilla Regina Nalwoga from NTV Uganda and Nation Media Group by and large. So that being said, allow me to set the stage. Formally, to stage our conversations this morning, it's my honor to invite a distinguished professional whose work is continuing to shape Uganda's approach to sexual as well as reproductive health and rights. She is serving as the program coordinator for sexual and reproductive health and rights and integration. This is at the United Nations Population Fund here in Uganda. Now, in her presentation, we are hoping that she's going to help us underscore a critical message, the safe motherhood that is not merely a health outcome, but ultimately a measure of national development and the very heart of the mandate for which we're all here in this room. She's also going to highlight for us the true and sustainable progress that can be achieved through system alignment and which sectors are planned together, financed together, and reviewed together in pursuit of the shared results. And so, ladies and gentlemen, without further ado, allow me to warmly welcome Ms. Juliana Lunguzi to set the stage for our discussion this morning.
Thank you, Priscilla. And good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Yeah, at least that's better. I'm here to set the stage on before we have the panel, where we are looking at fixing a thorn when it comes to safe motherhood. And it's really a privilege for me to be here and to welcome you all to this Safe Motherhood Conference. I know you've had a session before, which have highlighted the progress that we have made in safe motherhood in Uganda, and also the challenges that we're meeting. So to us at UNFPA and all of us in the Safe Motherhood arena, we agree that safe motherhood really matters. But the issue is, why does it matter when it comes to the national development? One key issue that we can agree is that every maternal death remains an emergency in our midst. That's why every Mondays and Thursdays in Uganda, we all sit together and we discuss why mothers have died. It shows that we are all treating safe motherhood, deaths of mothers as an emergency, and that the survival of the mothers really is important, because not only is it important that we don't see mothers dying, but it's also important when it comes to human survival and development. The other issue we need to highlight is that safe motherhood is not a woman's issue. It's a national development priority and a key enabler for Uganda's national development plan and even as we go to achieve our 2040 vision as Uganda. So Priscilla, in her preamble, she looked at the issues of the system shift, where we need to plan together, finance together, and also review together. So for us, working in the safe motherhood space, why do we need to plan together? It's very important that the planning is not only for Ministry of Health, but every ministry and local government must be enabled to embed safe maternal and newborn health into our plans. You can agree with me, when a mother dies, we hear that mothers die because they couldn't pass the road. The mother died because there was no clean water. The mother died because there was no electricity. So you can see that it's really, very important. And another component, yesterday we had the youth conference. It's also very important that we keep the girls in school. Every time you have a girl getting pregnant at 13, at 14, their survival becomes tricky. Not only that, they might survive, but end up with a disability like obstetric fistulas. So for us, planning together works well. As some other people said one day, one of the challenges of the health sector is we inherit the failures of other sectors. If the Ministry of Transport can't fix the roads, if somebody can't put water nearby a health facility, we see the challenges in the health sector. So we must take everybody and plan together so that we can fix things. The financing together, with a shifting in financing landscape and declining external support, Uganda really must expand our domestic health financing. We've been talking about these issues. We've been talking about issues of private sector partnership. We have been looking at issues of insurance. the various levels that we are looking at. I know the issues of insurance, not everybody wants to talk about it, but it's a challenge really, because when you go out there, we need money in the health sector. We can't get money from the usual donors. What do? Let's see how best we can finance. Possibly the Ministry of Health might not be the best people to find a solution, but if we work with the private sector, we'll be able to do it. Yesterday we were meeting with Dr. Richard Mugai, and he was saying, all I need is 10 million for an autoclave in one health center. Well, he's not getting it in the health sector, but maybe if you go to the private sector, you'll be able to get it. I was thinking we're finishing the year. Some banks are looking at bonuses. 10 million is not a lot of money to a bank. Possibly if he goes to 10 banks in Uganda, you'll be able to get 10 autoclaves that will save mothers in the rural area. We need to review together. The mutual accountability will really help us to make sure that we see results. Having one results framework, we have all talked about one plan, one MIT. All those are very important for us to make sure that we partner and we can all be accountable to the things that we do to the survival of the mothers out there. You see in the panels that we have a colleague from the National Planning Authority, because we believe that they must understand what the health sector is doing. They must understand that we need to work together, and that all the other sectors, education, transport, energy, water, governance, they are there because development outcomes can achieve more and harmony. We don't need to work in silos if we need to continue saving the mothers and the babies. And our investment also, we need to look at the health issues of prevention, health promotion, and communities. Issues of family planning, very important. Others say family planning is the vaccine for maternal deaths. We must take this into a reality. And we really need to look at empowering our adolescents so that they have knowledge on how to access services and avoid the early pregnancy. And when all is said and done, let's work with our community. We have the VHTs, we have the midwives, community health workers, to make sure that together we have better ways of saving the mothers. And we know pregnancy must become an emergency because we didn't plan better. The last thing I want to emphasize in our looking at this zone is the power of innovation and collaboration. There are so many AI that we need to make sure they are there within our plan so that we can lessen some of the processes that we have to make sure that we deliver better. We must go to the private sector so that we co-invest and see how best we can deliver to the community. So as we begin with this Fixathon, I want to invite all of us to have an honest and bold and collaborative discussion to diagnose what is the bottlenecks and how to prescribe and commit to make sure that we all reach our goals and save the mothers. Save motherhood is not a health expenditure, it's a national investment. When mother survives, the nation thrives. And let us plan together, finance together, and review together so that our mothers and children will have a better future and we can have a better Uganda. Thank you very much.
Thank you, Ms. Lunguzi, for setting the stage for us. It's loud and clear. Just to share a personal story, and during COVID, my sister was pregnant, and unfortunately, because she's diabetic, she couldn't hold the baby for full term. So baby decided to come a whole 3.5 months late before the maturity date. It was a tough time already by the pandemic. She was in a hospital that was in Chaliwajara. That hospital had to move her in the safest and quickest way to the nearest public hospital. But to do that, they had to ask for money to fuel the ambulance, as if the hospital did not have money to fuel the ambulance or consider the critical health of my sister at the time. So we got the money, fueled the ambulance, and then they said, no, you have to first clear the bills here before we can transfer you. That took a lot of time. Please note, she's diabetic and the baby is due any moment now. That was not critical to them. What was critical to them was financing. Their money should be cleared, then you can move out. We were able to do that. Then we went to the hospital that we were referred to, and upon being received, we had to go through the same cycle. First clear ABCD bills. Okay, fine. By God's grace, we were able to do that. And then when she got to be attended by the medical personnel that were on the floor at that time, the immediate response was for them to have her do a cesarean because of the emergency of the situation, not considering that she has a pre-existing condition, a diabetes, that now you have to make a decision. While we want to cut her, what are going to be the repercussions of cutting her? And yet she now has to take care of a baby that has come 3.5 months early. Luckily, there was a senior medical officer on the floor that day. And so he came in right at the time that decision needed to be made. And they gathered and talked through it. And the decision was made that we'd rather induce her to push the baby rather than cutting her. Then the other issue that we faced was that the nurses on the floor may not have had a good understanding of the already pre-existing medical condition of my sister. So when they were administering the general drugs for mothers who are giving birth, they did factor that in. So the medication that was given to her ended up causing more catastrophe than we needed on our hands. As if that's not enough, now in the neonatal, we're being told we have to also first pay for the baby to be taken there. Then when we do that, then we're being told the drugs, there's that first shot that they give a preterm baby, it is not existing in the hospital precincts. And this is a very big public hospital, by the way. It was not existing. So now we have to figure out, in a pandemic, please not, cars are not, no movement of vehicles or people is allowed. How do we get this medicine from a pharmacy, bring it to save my little nephew? The story is very long, but I'm just trying to show you that it's a multisectoral approach that we need in order to have this concrete discussion on safe motherhood. When we look to how the Ugandan media is perceiving maternal health, beyond tragedy headlines, I know that you have read the headlines sometimes, screaming, mother bleeds to death at district hospital, woman dies after giving birth on the floor. And these are the stories that spark outrage, but they soon fade away, they disappear, and they leave behind a deep question: who is accountable? When you look to striking figures, the UN Women's Media Audit 2024 found that less than 20% of voices quoted in health policy stories are women, yet it's women and midwives and community health workers who live these realities every day. So without access to data from the ministries responsible, all the other organizations that help us with the data, or even the Uganda Demographic and Health Survey, these stories remain emotional rather than evidence-based. This data is blinding, meaning that we're missing opportunities, and also we are not having the demand to real accountability. So we want to have accountability in this session right here. When we look to the group that I work with, Nation Media Group, in 2024, we ran a series called NTV's Mothers of Hope. It was a mini-series celebrating community midwives who were turning scarcity into service. Then just this year, through our Monitor publication, Daily Monitor, we ran a series also on Budget Watch, Women's Health Edition, and was really connecting parliamentarians' fiscal debates to maternal health outcomes. Then we also had an online platform that was running eco stories. So where do we go from these stories that cause emotions to our hearts, and how do we fix the narratives that are the realities on ground, from reporting death to demanding delivery? My panelists are going to do exactly that, finding us the fix that we need for today. Allow me to introduce Ms. Judith Mutabazi. She's the Manager, Population Program Coordination at National Planning Authority. She's a population and social development socialist with considerable research interest in areas of fertility, youth, and gender issues, as well as the social determinants of health. Ms. Mutabazi, you're most welcome to the podium. A round of applause for her. We are also trusting Ms. Hadija Naka today, a midwife at the Department of Reproductive and Child Health, Ministry of Health, to give us a clear picture of what the realities are on ground and what it takes to find these solutions and who's responsible for the solutions. A midwife of that department, she's also a member of the Maternal, Perinatal Death Surveillance and Review Secretariat. She's a member of the PPH Steering Committee Secretariat and also serves as the Secretary of the PPH National Self-Motherhood Experts Subcommittee and a trainer of trainers. You're most welcome. We also want to trust that Ms. Grace Namata Saji, the Program Management Specialist of Foreign Commonwealth and Development Office with the British High Commission, is the right person to help us find yet another fix. As a management specialist with over 17 years of experience in program design, program management, procurement, and financial oversight across development as well as humanitarian sectors, she's currently serving with the British High Commission here in Kampala, and she's leading some health programs, including Empower. Then later on, we'll also have the privilege of sitting down and listening to Dr. Fred Muhumuza, who's an economist and a senior lecturer at Makerere University. And his expertise in drawing us the economics behind this session will be very, very important and foundational to the decision that we have to make in this room. Thank you very much. All right, I'm going to allow my panelists salutations and then we'll get started. I'll start with my extreme left. Saji. Salutations to the room and then we get started.
Sorry, I didn't hear that. I didn't hear that, sorry.
I'm asking you to just greet the room and then we get started.
Hi, good morning. My name is Grace Namata-Saji and I'm a Senior Program Manager at the British High Commission. Glad to be here at the 5th National Self-Motherhood Conference. Good morning, everyone, and thank you for coming for the conference. My name is Hadija Naka, I'm a midwife and a strong advocate for midwives and mothers and their newborns. Thank you.
Good morning, ladies and gentlemen. I'm Judith. I've already been introduced. All protocol observed. Glad to see you here, everyone.
Allow me to start with Ms. Judith Mutabazi from the National Planning Authority. Judith, from a human capital development perspective, we want to find out from you, how is Uganda's national planning framework prioritizing self-motherhood and exactly what mechanisms currently exist to ensure that non-health sectors, for example, transport and education, budget for their roles?
Thank you, Priscilla. The National Development Plan 4 has recently been launched. We are in the first year of the fourth National Development Plan, which is also contributing to our Vision 2040. And this plan has a program and a Human Capital Development Program. One of the key results, we intend to reduce teenage pregnancies. We intend to see reduction in maternal mortalities. Some of these indicators, Professor Josephat highlighted them, ensuring there's a reduction in unmet need for family planning. And all this can be achieved in ensuring there's improved population safety and management. And that's what the Human Capital Development Program is advocating for. But also in the National Development Plan, we have taken the program-based approach, which is also contributing to the multisectoral approach we are discussing today here. In the program approach, we are looking at sectors are not working in silos, and health cannot work alone. We need Ministry of Gender for community empowerment, literacy issues. We need Ministry of Education to ensure girls stay in school longer. And some of these cases that we are seeing at health centers of miscarriages, maternal deaths, preventable pregnancies can be attained if our girls stay longer in school. And in the NDP4, we are looking at girls staying longer to 11 years. And that is approximately every girl should complete senior 4. And there they are able to make informed choices regarding the number of children they have, the spacing, but also get children at the right age. So all these have been stipulated in the National Development Plan, but we also think they cannot be achieved by Ministry of Health. Every stakeholder has a role. And at national level, of course, we work with Ministry of Finance to ensure resources are allocated to some of these priorities and interventions, but also we work with the districts where they develop district development plans that also guide implementation in the lower structures up to community level.
All right, thank you so much. Please listen attentively to my panelists' submissions, because later on, it's from their submissions that we're going to pick solutions that we want. We're going to be running a Fixathon. In this Fixathon, we're going to be asking you in this room to help us find a fix that can be multisectoral across the bar to find the solution to safer motherhood strategies as of today. Ms. Grace Saji, allow me to extend a question to you. External aid has been very important, but when you look at the structural shifts that we're seeing in Uganda today, we see that we need to have sustainability in mobilizing our own resources for maternal health. How can we be able to do that?
Thank you very much for that. So we all know that external financing has been very crucial in addressing maternal health in Uganda. We appreciate the funding that has been done through different donor organizations, including the UK government, where I work, and other development partners like UNFPA, the US government, the World Bank, and others, to mention but a few. However, this external financing sometimes come in to address very critical issues like system strengthening and making sure that services reach to those who are in need. But we all know that it's not predictable. And with the current donor landscape, it is very important that as the country we start thinking about how do we ensure that we have predictable domestic financing to ensure that we can allocate resources where they are needed most. So for me, really, it's something that we need to think about. I'm reading some of the information where the Ministry of Health has been able to secure more funding in this financial year is one of the steps that the country is working towards predictable domestic financing. But my wish or the fix would be for the government to think about allocating a certain percentage, not only in health sector, but also in other sectors that really contribute to maternal health, like we've had education, infrastructure sectors, to ensure that we can actually earmark funding both at national and local government level so that we can deal with the gap that will remain with in terms of predictable domestic financing. Thank you.
All right, thank you so much. I'm glad that you make that comment when we do have the government officials responsible for that in this room, Ministry of Health, Ministry of Finance. All right, looking to Ms. Hadija, you're the midwife here in this equation. We're looking to multisectorial collaboration. You're the one who's on the front line. How does that look like for a mother who is in the labor ward today and now? And what is the single biggest health barrier that you face in helping that mother?
Thank you so very much, Priscilla. for that wonderful question. So when we speak about multisectoral collaboration, as my colleagues have already said, we look at different entities straight from education, finance, health, bringing resources together to make sure that it does reach the last mile. We also need to understand that there are so many policies that have been formulated, and we can only say that safe motherhood is there unless the policies have really reached the last mile of the mother. So now when you look at the midwifery space, ICM specifically did introduce the midwifery models of care. But for as long as the midwifery models of care do not reach the final woman, there is nothing, we cannot guarantee that is really like safe motherhood. So it is important that policies and also the finance does reach the final woman. But also, when you speak about multisectoral collaboration, to the woman who is in labor ward, we are looking at this woman that if it is time for her to be referred, there's a functional ambulance that can take her to the next level of care. The roads are just so clear so that there is easy access to the next level of care. And then there is light. Maybe there is also water that is supposed to be used as they are working on her. But very important from a midwife's perspective is the empowerment of the woman. Because when we speak about the woman, so many times we think that we are speaking about women who are outside this building, but the women are actually us. They are midwives, they are equally, health workers and doctors. So empowering women is very important, as Juliana already spoke about the young girls, that if education does not really do its part, it looks like it is the health system that is going to struggle. For me as a midwife, I've had an opportunity to work in both the education sector and then the health sector, but we noticed that if education does not really equip the health workers with the right skills and the right knowledge, in return, it is going to be the health system that is going to suffer, and then that is going to translate into the woman. So it is very, very important that at the service delivery, we have everything that is supposed to be fixed by health. And also not forgetting that women have a very important role to play in this. So communities, empowering the communities, financing is very important, education is important, the parliamentarians, as you have said, and of course the professional bodies, and then the private sector.
All right, thank you so much, Hadija. Now, we're going to be moving to quick solutions in your different sectors and capacities. You'll be talking to us about the quick fixes that we need right now. But as they do so, we also want to engage you as our friends on the other side, but part of this conversation. We're going to be running a QR code that is going to be projected on the screens. And this QR code is to help us establish our Fixathon challenge today. Fixathon. And we have a very simple question that we want to ask you, if it can be projected on our screens. The question is, if Uganda had just one coordinated budget and 1 year to save 1,000 more mothers' lives, what would we need to fix first? If as a country we had the opportunity to save 1,000 mothers and we had to do this in 1 year, what would we fix first? So think about that, and then you'll be scanning the QR code. Nelson, if you could help me with that code. You'll be scanning that code and you'll be dropping your responses there. 2 to 3 words, maximum 3 words. Now, moving to a quick fix, I'll start with Miss Judith. If you could issue a directive today in your capacity as National Planning Authority to accelerate safe motherhood through planning, what would it be? With all the authority invested in you.
The quick fix would be to ensure increased resources to maternal health units. And of course, this goes on all the way from national level to national referral hospitals up to the community health centers to ensure no mother is giving birth in community, but they should be in a health center.
When you say resources, help us break that down. What resources and from where?
The resources, of course, would come in when we set priorities, we allocate resources to ensure these priorities are implemented. The resources are released to implement the plan, and they also go through the whole structure to local governments, and those are the district development plan and then the annual plans, and ensure we also monitor what has been released and what has been implemented. So it's a chain, and all of us, we have a role. The political leaders are accountable, the communities are accountable, individuals are accountable, but also as planners we're accountable, and everyone has a role to ensure there's no mother who is still dying while giving birth.
Okay, all right. Ms. Grace Saji, if you could implement, as one who's very good at strategizing and coming up with programs, if you could implement one immediate financing intervention to save a mother's life, what would it be?
Thank you very much. I think one of the key challenges we've seen stock out of supplies that could lead to the dangers that mothers face. So we need to fix that. And if I was to be given an opportunity, is to make sure that we invest in a very good digital procurement system and supplies management to ensure that commodities reach where they need to reach on time. So that will remove wastage and inefficiencies. And also to make good use of the digital tools like artificial intelligence that we've all talked about this morning, and ensure that, you know, we use these tools to enable us predict the shortages and make sure that the supply chain can address these shortages for stockouts at different health centers. Thank you.
All right, that could actually work. Most recently, the president was campaigning in northern Uganda, and he said that he's going to recruit his own team that will do ground supervision to ensure that there's no drug stock out in hospitals. That shouldn't be the case in this day and era, when you do have national medical stores also having recently launched a nationwide campaign just to ensure that there's no drug theft and drug stock out in hospitals. So that definitely would be a good fix. All right, then we also want to listen to the midwife on our panel. Dear midwife, when it comes to solutions, what do you believe is the most immediate quick fix that we can adopt now, between now and next year same time, to save 1,000 mothers?
I'm pretty sure many people have predicted what my answer is, but my quick fix would be more midwives, and more midwives. In fact, as the midwives who are here know that ICM is running a campaign for 1 million midwives. So to me, I feel it is a quick fix, because midwives are at the service points, they are at the antenatal spaces, they are next right with the woman. Midwives are actually everywhere. So for me, if I am given the money right now, I would recruit more midwives. But of course, because of multisectoral collaboration, midwives don't work alone. So ensuring 24/7 staffing of also the other critical cadres is very important. But of course, the fix still stands. I would recruit more midwives.
1 million midwives. 1 million midwives. How possible is that? That's a multi-sectorial approach fix. Because the Ministry of Health will want them, then finance will tell them we can't afford to have all of them in 1 year. Then public service will also have to look through that. There's a lot of stakeholders involved in the 1 million midwives, but it is possible, right?
1 million is across the whole entire world.
Yeah. Yes. All right. Okay. All right. Lunguzi, you have been across Africa. You've been able to look at these matters from a different African countries' perspective. What have you found to be the most immediate effective strategy that can be adopted to save 1,000 mothers in 1 year?
I'll go with Khadija, more midwives. Not only midwives, but competent midwives. Competent midwives One who not only look at the clinical side, they know what they are doing, but they should also be able to reach out to the community. A community must know that there's a midwife here. Juliana is a midwife. They can go to her home. Juliana can go to their homes. Juliana can go to the schools as a midwife. So I want not only a midwife, but a midwife who is mobile, a midwife who is competent, a midwife who is known, a midwife who has a loud voice to provide that package of MNCH. Midwives.
All right, so that means that we have to also increase on education when it comes to midwives, extend more schools or allow opening up of more institutions that can train more people to become midwives in order to address that. The mobility issue is also another thing that you have talked about. I remember the Prime Minister, Nnabagereka, when she was in the Buganda region, traversing one of those districts in Nakasongola to be exact. She found out that there are no midwives, and so mothers there are suffering while giving birth, ending up losing children or even their own lives, simply because there is another traditional midwife that is doing the job. But because they don't have the clinical and medicinal approach to it, there's a life or lives that are lost in that line. All right. So, Nelson, can I have my QR code? We're going to have a small fixathon. The ladies here have shared their fixes. Dr. Muhomuza, before you speak to us, you could also be having a fix. Maybe you could just give us a fix that you believe we can adopt that is outside your submission that you're sharing with us this morning. Do you have any?
Well, good morning. I think I'll just make an assessment mapping on who is around the table on these issues and summon whoever is missing. And there are faces that really that should be in this conversation if you talk about multisectoral planning. If you don't see the role of judges in this, the police in this, I'm talking about theft of drugs and theft of monies, these people need to come into the picture and begin to see their contribution to safe motherhood in these conversations. So we still have to summon a lot more people and bring them on the table. Thank you.
All right, thank you so much. Now, with that being said, there's a QR code. Please pull out our smartphones, especially our iPhone 17 Air. Let's see some iPhone 17s. I'm told it's oversold than the 16, just 10 days. All right, so pull out your phone, scan that QR code that is appearing on the screen right behind me. And then from what has been submitted, let us know what you believe can be a multisectorial quick fix if we are going to save 1,000 mothers in approximately 365 days. So if we're speaking government terms in one financial year, which financial year they are looking to budget allocations for the next financial year. And so this is a very good time that we have decided to have this conversation so that it can be included in the next financial year's budget for the different ministries using the same playbook. Okay, you've made your submissions. What would be your quick fix, or of the fixes that have been presented on the floor this morning, which one do you believe is actually an immediate quick fix? All right, train more midwives, increase budget allocation, improve patient to doctor, recruit more midwives, human resource, address absenteeism. That's very true. Education is important. Community VHTs, staffing levels in the hospitals, more health workers, especially midwives, be funded, well-funded, competent equipment, improve maternal antenatal care, recruit more health workers, attitude change. Okay, that's an interesting one. Attitude change for all the stakeholders, not to think that, no, that is a Ministry of Health issue. As of water and transport, as a ministry, David Kwatako. Okay, address absenteeism, integrity, address absenteeism. You're experiencing that. It's a reality, eh? On the ground. Okay. Increase health financing. All right, so I'm going to ask Christina Nelson to help me generate the top 3. Help me generate the top 3 that are coming through so that we can be able to make a decision on that. Which decision then will be having the economist on our panel this morning speaking to and help us see how it can be then addressed across all sectors to ensure that there's safe motherhood in the next 365 days. And we can start counting mother 1, mother 2, mother 3, mother 99, mother 299, mother 999. Boom, 1,000. Okay, Nelson, just keep those responses coming in. In case you've just walked into the room, there's a QR code that is on the screen. Please, let's engage together, because at the end of the day, first of all, I'm seeing more women in this room, meaning that you all have children or want to have children. Personally, I'm in no longer to be, so the decision that is made here in my panel is going to save me and my twins that are coming up. Midwifery-led models of care, more health education in community. All right, Christine Nelson, what does it look like over there? Quality of care, mapping high risk, increased budget allocation, effective performance management. So we're looking to midwives that's having 60 submissions so far, the 1 million midwives. Human resource that is at 24. We're looking at health workers at 22, which really tallies it to the human resource. And so that will be 47. And then we look at health facilities, health competence at 19 and 14 respectively. We're also looking to some of you that have made submissions around community engagements, also having a figure there. All right, people have talked about equipment. So far, 12 of you have talked about equipment. 13 of you have talked about the community. Health as priority care, that's 12 and 12. Improving on our facilities that are already existing, that's another one. Okay, all right, let's go back to the top 3. Let's go back to the top 3 that we have up there, and we see how people are responding. So far, midwives has gotten 68 now. Okay, the campaign is possible, right? Human resource, 26 people believe that we need to have an increase in human resource, which tallies with health workers. So between human resource and health workers, that's about 49 right now. So 49 against 63 midwives for the midwives. All right, then competence is coming in at number 3. So of those 3, let's combine human resource and health workers to be one, and then look at competence as the other one. All right, so the 4 participants typing, hurry up, and we make a decision. So now this decision is going to be how we have it in our parliament, the yeas and the nays. Yeah? So we're going to have a parliamentary session right now. Okay, I believe the 4 have finished typing. Nelson, let's go back to that board and see. All right, one of them was midwives. That was the one that was in the lead. And then we had competence was the other one, human resource. Okay, midwives is now at 77. Can we make midwives 100? Members, let's make midwives 100. Yeah. Let's encourage Hadija and the midwives in the room here. Give me an 80, somebody. Please type. Type midwives and exactly. Give me an 85. Give me an 85. Human resource and health workers equally. All right, 83. We're standing at it. Let's make it 100 for the 1 million to represent the 1 million, right? Okay. Standing at 83. Give me more midwives, competent midwives, All right, 88. I want 100. So, my dear friends on this table, could you help me make that 100? Our dear dignitaries, could you help me make that 100? Okay, 92. Good, we're moving, we're moving. 8 more to go, 8 more to go. Make it 100. Dr. Muhumuza, we have already decided, really. 94, okay, 94, let's go. Human resource and health workers also combined together, and competence being in the 3rd place. 97, 3 more to go. 3 more to go. Where are my 3? 99, 100! Yes! So, Hadija, congratulations to you. Your 100 midwives has been 106. Thank you so much. All right, so it's been the rest between midwives, human resources, it's the same as health workers, as well as competence. And where we sit right now at 106, our Fixathon that can be achieved in the next financial year, hopefully, and trusting our leaders here, is getting us 106 more midwives in Uganda. It is possible and it is doable. So, ladies and gentlemen, thank you so much for participating in our Fixathon. And those are some of the fixes that we're inviting Dr. Muhumuza Fred to speak into and help us then understand how do we get to adopt these and into the broader implications of the solutions that have been voted for here. And of course, as an economist and a senior lecturer at Makerere University Business School, he wants to draw for us the numbers and where they can be moved from and placed where to make this possible. Cindy or Dr. Muhumuza, you're most welcome.
Good morning once again. I was uncomfortable there sitting among all the ladies, beautiful ladies there, so let me take a break and stand here, and from here I'll just escape through this route. I will not take a lot of your time. I've been introduced. Fred Muhumuza is my name. I've been in the research area for quite some time, and they say if you can't monitor it, then don't even attempt to deal with it. So I want to really emphasize that this is a good discussion on multisectoral planning. I had Priscilla's experience, which brings in, as I've said, people that should be with us, but they are not possibly with us. I think what came out from Priscilla's experience, besides what happens in the facility, is the out-of-pocket costs. And that takes us completely out of the realm of possibly our discussion. You get into the livelihoods. Where were they getting the money from that quick? So either you have a mobile money functionality, that somebody you can tap, social networks, say, guys, they need 200,000, and somebody there, you're trusting they have it. You're not looking to sell a goat on a non-market day. So the people who should be in this meeting are as many as anybody you can think of. From agriculture extension service providers, district engineers, all those people need to be in this, because some of the mothers who have lost them, not because the facility was not there, or they couldn't reach it, or they reached it and something was missing. A cannula is just not there. I mean, so many things are missing. Electricity, UEDCL, anybody in the house? And it's not a UEDCL problem, it is a budget problem. They have submitted their budgets, they need to revamp the infrastructure, the distribution network is not working. So I think we really need to get in there, and for me, we need to develop new indicators that are more comprehensive than the traditional indicators we've been using. Because if we're going to monitor multisectoral, we need more indicators. I've been to a country where their decision was everybody should be within 15 minutes of medical care. 15 minutes. Anybody who has tried out Uber? You know, you just try. Before you know it, the nearest guy is coming to you. And the system will be telling you they will be there within 3 minutes, 2 minutes. How do we, apart from the geo-mapping, my friends who did that, thank you very much, we also want to be able to monitor that. If somebody develops for us an app for medical service provision, and I tap there, I need to know how far, how fast. That will help us to plan. That will help us to know who is not in the picture. So joint programming is going to be key. Assessment of impacts is going to be key. The other contributions that I've said, we need to engage out there, the electricity people, the water people, the transport people, the security people, everybody we need to be engaging. I was shocked the other day, not so much shocked, the Commissioner General saying the judiciary has delayed cases of tax defaulters and is losing or holding out their 600 billion. If only the judges could make a decision. I don't know how many people have stolen drugs and those cases are still in the judicial system. And if they came out, it would be a good message to others who are planning to steal drugs or they are actually stealing them. So safe motherhood is going to take everybody. And so for me, from here, we need to make this a campaign for everybody. I want to see people promising that you are going to reach out to somebody who thinks this is not their subject. Or somebody you have never reached, that from this conference, we are going to engage them, identify them, map them, make a strategy of reaching those particular individuals. I think this is going to be key for us going forward. The campaigns are going on. Members of Parliament are being proposed today or nominated. What is our strategy for them? They are going to be making decisions over the next 5 years. Did you say 365 days? These guys are going to be managing us over 5-year period. Can we set targets for them by 2031 of what they should deliver? Now, many of you may not know, we spend 3 billion shillings per day on Parliament. And yesterday they confirmed all of them are coming back in their numbers. So that figure is not about to come down. But can we demand value for that figure related to safe motherhood? What do we want to load on the agenda when the parliamentary session opens next, especially for the new members of Parliament? Priscilla, I promised I will escape through this route. But you have every right to change my decision. Thank you very much, ladies and gentlemen.
Dr. Fred Muhumuza, ladies and gentlemen, a round of applause for him. In a short narration, he has helped us understand that we need to consider approaches that cut across all sectors, all institutions, all departments, all agencies, and also make sure that there's an assessment of the impact over the 5-year commission that you have given our leaders in the Legislative House. So I thank you, Dr. Fred Muhumuza, and I thank you, panelists, for helping us open our eyes to how important it is that everyone has a part to play in this quest of self-motherhood. So we have seen that when it comes to self-motherhood, we can accelerate together. We can fix together with how you have helped us come to the fix of the day, and that is more midwives. We can plan together, we can finance together, and we can review together. So these are the solutions that have been discussed and voted on, and they're not just ideas that we should be putting and leaving on paper, but these are commitments that are needed for action, backed by evidence, backed by the economic rationale that has been shared and the shared responsibility. This is across health, across planning, across finance, across frontline service delivery, to mention but a few. So let's carry this momentum forward as we move into the next sessions of the conference over the course of the next 3 days, ensuring that every mother's life counts, including I, Priscilla, Regina, Nnabagereka, Nalwongo, to be your session chair. I thank you.
Ladies and gentlemen, another round of applause for such a very wonderful panel. Thank you, thank you, thank you, thank you. And colleagues, I can't fail to say that because of your incredible support and of our partners, we have 1,100 delegates for the 5th National Safe Motherhood Conference. It has never happened ever since we started convening the Safe Motherhood Conference. Now, without any further ado, allow me to introduce my co-moderator, and that's none other than Mr. Emmanuel Ainebiona. Mr. Emmanuel is the Ministry of Health spokesperson. He holds a master's in journalism and communication, and also a former health writer. He is also a French speaker, for that matter, with 10 years of experience. Mr. Emmanuel.
Thank you very much. Bonjour tout le monde. That means good morning. My name is Emmanuel Ainebiona, as Aria introduced, and we need to clap for ourselves. We've been a great audience. Yes, allow me recognize a few dignitaries that are with us here today before we break off for the tea break. Allow me recognize the presence of Mr. Kenneth Akiri, the Undersecretary at the Ministry of Health, representing the Permanent Secretary. Allow me also recognize Dr. Henry Mwebesa, the Chairperson of the Health Service Commission. In the same spirit, allow me recognize Ms. Christine Kakuru, the Deputy Chairperson of the Health Service Commission. And I have noted that there are a number of members of the commission, and you've been doing a great job. The health workers are coming in. I hope we're going to reduce on increase the staffing levels. Allow me to recognize Kayla Ko, the Health Systems Coordinator, representing the World Health representative here. Allow me to recognize Dr. Dithan Chiraga, the Executive Director of Beira Foundation, Uganda. Allow me also recognize Professor Pius Okong, the Chairperson of Sorority University Council and former Chairperson Health Service Commission. Allow me also recognize Dr. Richard Kabanda, the Commissioner Health Education, Health Promotion, Education and Communication. Allow me recognize Sister Agnes Chandia Baku, the Commissioner Nursing and Midwifery at the Ministry of Health. And also our host Commissioner, Dr. Richard Mugahi, the Commissioner Reproductive and Child Health. Allow me also recognize John Paul Bagala, who has been speaking earlier, who is the Assistant Commissioner Reproductive and Infant Health in acting capacity. Ladies and gentlemen, we are also joined by Ms. Charlotte Kainerugaba, the Postpartum Hemorrhage Ambassador. The Director General Health Services was here, Dr. Olaro Charles, but I hope he stepped out. Allow me also recognize Dr. Emmanuel Biaruhanga, the Executive Director at Kawempe Hospital. Also allow me recognize Dr. Stephen Aisu, a member of the Health Service Commission. Dr. Nathan Onyachi, also a member of the Health Service Commission. Professor Biamugisha Josephat, Director Health Services, Makerere University, and the Board Chair for NASMEC Institute. Yes, ladies and gentlemen, we are going to have a tea break, and when we return, we'll be going straight to the opening session. Oh, thank you very much. I am being signaled. Allow me to recognize Mr. Daniel Alemu, the UNFP Deputy Representative and the Chair of the Health Development Partners. Allow me also recognize Arnold Kabale, the Health Advisor, British High Commissioner. High Commission. Thank you. Thank you very much. We are going to have a tea break, and when we return, we'll be going straight to the opening ceremony of this 5th Safe Motherhood Conference, and we will be keeping time. So we have 15 minutes for the tea break. The timekeepers, you're put on notice. Thank you.
Yes, thanks very much indeed, Dr. Emmanuel. So colleagues, our break tea is at the exhibition ground. And it's very important as we enjoy the coffee, we appreciate what everyone is doing for safe motherhood. So we will just take that exit and we go to the exhibition ground right there. That's where our tea will happen. Let's make sure everyone to be back here in the next 15 minutes as my co-moderator has highlighted. Thank you very much indeed.
I take this pleasure to thank the Embassy of Iceland that supported us in this particular project. From its inception, we have benefited in infrastructure. We have our 14 facilities. Working in 14 facilities, and you have an opportunity to review some of them where this intervention is going on. 12 of which have been remodeled, offer that quality service, the post-abortion care services, and together with family planning, because most of these are young people, they come with their abortions, they are bleeding, and then you have to give service. To be very unfortunate, young as they are, 14, 16, you leave them walk out without at least a contraceptive. Before you know it, they'll be coming back. It has been equipped, all these remodeled facilities. They have new beds, they have storage space, the equipment, and we have continued receiving some supplies.
To start with, to appreciate our long-term friends, IPAS, as you heard from the views for the gaps affecting service delivery are quite significant, and as government, we cannot say that we can solve them alone. When we get people like you coming in to help us bridge some of these gaps, it makes us move forward. And with our limited resource envelope, we want to see how do we ride on such partnerships. And for me, the exciting thing is that IPAS diversified, and at least I'm seeing that we are really now broadening our scope.
This is Mukuju Health Center 4. I'm called Sister Isuka Jude. We have been with the IPAS for the last 3 years, and they have been supporting us in park services. I'm a provider for park in Mukuju, and we have all the family planning commodities in our facility. So we keep encouraging them. Once they get pregnant, they should come to the facilities. They should not go to do them in a local way. So that is why you see this room is here, renovated by IPAS, and they were able to renovate it. They supplied us some equipment for park, and whatever we have here is under IPAS. So they have equipped us, and we are able to do our work comfortably without any challenges.
My name is Anna Kukundakwe. I work with IPAS Africa Alliance. The Buganda program works and collaborates with the Ministry of Health in the promotion of safe motherhood. We appreciate the leadership and the stewardship of the Ministry of Health that has enabled us to put forward high impact interventions in 132 facilities, and of these, about 48 of them have received infrastructural development and renovations that go a long way in ensuring that women and girls have access to dignified care, but also we eliminate barriers by supporting community organizations to continue to mobilize communities, but also ensure that the myths and misconceptions are corrected within our communities. Thank you.
My name is Eric Okello, Media Innovation Called TDN in Tororo District. Now, in terms of the work we've been doing as TDN, IPAS, with the Embassy of Iceland, has been able to grant us to amazing work in Tororo District, looking at reduction of maternal preventable death due to unsafe abortion, which has been affecting many of the girls and young women in Tororo District. We have mapped community influencers, about 616 of them. We've supported cultural leaders to appreciate the life-saving impact of post-abortion care. We have
used young people themselves as change agents. We've also dealt with stigma beyond just community leaders, beyond religious leaders. So in a nutshell, as TDN and IPAS, we've done so much in trying to normalize conversations around post-abortion care. Thank you so much.
I take this pleasure to
amazina ni Akankiza Elizabeth nintura ruto maseru kandi yino mushiija ubu bari kweta Mr. Alinda Dennis nzire nawe abana babiri kabanza kurira family planning ahirwajo iri bari kweta Diane Kismedi.
The 5th National Safe Motherhood.
My name is Katerega Basilio, founder and team leader at Preterm Infant Parents Network Uganda. Preterm Infant Parents Network is a network that supports parents that have given birth to preterm babies. Preterm, we've been in existence for about 4 years, and we work closely with the Ministry of Health and Kawempe National Referral Hospital. Today, it's kind of tell you about our program that we are running with Kawempe National Referral Hospital, where we are doing community follow-up of preterm babies that have been discharged. We started this program in April this year, and so far we've been in position to follow up about 2,000 mothers and within the communities. But before we go to the communities to follow up these mothers, we ensure that we give support to these mothers in collaboration with Kawempe National Referral Hospital, where mothers, once a mother gives birth to a preterm baby in the NICU, we go in, provide emotional support with the nurses to these mothers, since we are experienced parents of giving birth to preterm babies. Then, once the baby leaves the NICU, then it's discharged to the kangaroo unit. In the kangaroo unit, this is where we educate the mother on what they're supposed to do with their babies, on how they're supposed to take care of their babies when they go back to the community. So, once these mothers are in the NICU, we educate them on infection prevention, hygiene, breastfeeding, educate them on immunization, what they are supposed to eat as parents of preterm babies so that they are in position to get breast milk. For those that don't have breast milk, we work together with the breast milk community that supports us with donated breast milk, and they bring it directly here at Kawempe National Referral Hospital. So once the mother is being discharged from the kangaroo unit, we ensure that they're trained on how to do kangaroo. So then we connect them to the volunteers or the VHTs within their community.
Hello, I'm Brunji Bridget, a volunteer from the Preterm Infant Parents Network Uganda. As a volunteer, once a mother is discharged from the hospital, I always get a notification to go and check them out. Once I get the contact, I reach out to the mother, find out where exactly they are. I reach out to them in their respective homes. When I reach out to the mother, I ensure that the baby is feeding so well, that is every after 2 hours. I ensure that hygiene is maintained, proper good hygiene is maintained. I ensure that the baby is given enough kangaroo, because we are supposed to give a baby kangaroo for up to 20 hours. And once I visit a mother in the community and I notice any danger sign, automatically the baby is always referred back to the hospital.
Good afternoon to you. My name is Dr. Mary Nyanzi. I'm a pediatrician and also the head of department pediatrics at Kawempe National Referral Hospital. I'm here to tell you about the Preterm Parents Network, that is a community support group that is helping mothers and babies for the preterms that were previously admitted at our hospital and are discharged home. So this community support group does a lot of good things for the parents. They do support supervision, I should say, for the mothers. They have expert mothers that usually come to teach these mothers how to care for their newborns, how to look for danger signs, and when to return to hospital in case of any emergency. They also remind, which is quite important, they also remind the parents to return for their hospital appointments. And this has been evidenced by our statistics. Usually, previously when we were just starting, we used to have about 15, 20 preterms coming in for review. But of late, at any one appointment date or clinic date, we have about 60 preterms being brought back for reviews. So I think that is good. It is helping with their survival, as they'll tell you from their statistics, with the follow-up that they do. Of course, there are other things that they do beyond the supporting. They also have some materials that they give these mothers that help them in identifying danger signs, things like thermometers, and they also teach the mothers how to use them. But also supply kangaroo wraps, which the mothers need when they are doing the kangaroo mother care. So I think there is more. I may not be able to say it all, but the executive director of the association will throw more light, as you will see later on. Thank you.
So these PhDs, we developed an app with support of Nnabagereka. We developed an app, and this app is in position to report to us real-time data. Which mother has been seen at what time, which mother has got an issue and needs to be referred immediately back to the hospital. So once the mother is assigned to the volunteer or the VHT within their community, the VHT will receive a notification that there is a mother coming into their village. So once the mother reaches, the VHT makes an appointment with the mother, who visits the mother, educates them on various things, which include kangaroo, hygiene, breastfeeding, but also encourage these mothers to come back for the follow-up, for the clinic follow-ups. In Kawempe, we've seen the numbers increasing from ever since we started the community follow-up to about 60 mothers plus per each visit they come to the hospital. So we also ensure that once these volunteers or the PhDs go to the community, they identify, they check out for the danger signs. Of course, the VHTs, we equip them with the thermometers, pulse oximeters, the weight scale. We give them wraps that they give to these mothers while they're in the communities. And as soon as the VHT or mother champion identifies that a mother has an issue, they immediately refer them to the hospital, to the acute unit, where the mother is immediately given attention. And this, we've seen a lot of babies that have been saved from dying from home, because once these volunteers get there, you find that there are a lot of danger signs that they identify, which some like convulsions, high temperatures, low temperatures, bad breathing, not feeding. So these are some of the danger signs that we look out, and the app will automatically flag once a baby has an issue. We also encourage these mothers to come back for ROP screening. We know very well that one of the leading cause of blindness among the newborn babies is ROP. So we encourage mothers to come back for eye screening, and also we're moving into ear screening, because we have identified that there are some mothers, some babies that go blind as a result of prematurity. We also follow up. We encourage volunteers to follow up on parents that have got permanent disabilities that have come as a result of prematurity. So that's what we do, and together with Kawempe National Referral Hospital, with support of Dimaji, that provides us with the Home Care Connect app that we use to follow up on these babies.
Mama yenali mubela jenali takowa kyonna kyayitamu kyajja kutunya ekiseera kiggwe takowa kubanga bba abaana baffe Mukama yabatuwa nga tebatuuse naye bw'oba tossizza mukono era nga bwe bakugamba okukola obikola nga baba babikugambye okwagala okungi omwana aba ajja okukola ki ajja kukula bulungi.
Amazina ni Akankiza Elizabeth, nintura Ruto Maseru, kandi nyina omushaija ou barikweta Mr. Alinda Dennis. Nzire nawe abaana babiri. Kabanza kwiga family planning ahirwajo eri barikweta Diane Medical Clinic. Bari kutusomesa uko kubaasa kubarira ruzaaro yawe. Okuza kurunza abaana ngeno mpora turebeka gwa abana bakora kurungi. Nagizire ndayo kubanza nagenda omwigwaro kuzaara batwegesa ako kubaasa kubarira ruzaaro konka agataho sinabiforowinga munonga hata handa ya kabiri nibwo nahezaga nkabiforowinga bakabitwegesaho kubareze kubitwegesaho nahura nanye nabikunda abo kugira ngo endayo kubanza nkazaara ngeno yanjye gange Danai yino wanganda kuharomereza bubonire nagendayo twakubareza kunshobora n'ingo yone kandi frangi natuzinga mata inkorana kuja kaba ikanga kizo muhagara kandi kuyanaka teka mutindane bono mbire ndenda muri nesa dia ekiro ndibonire notwaho ubwire buringwa kandi okuhereza sente bakakutwara ndetse singakundiye umuperiode sinoza mukaburizo ikindi yoneyo iriho kutungamo cyatumire natuzenga kuza family planning nkareba okubanza ko nazire abwo kuba nanshangaga buri ndakika ndi n'abana hataho kugira ngo ndi kuzaha ninga ndi hari onka ko natuzindire family planning nareba yambonerera namaye enda kujyetse nakora muri nisanga ntererire cyenda ya family planning bari ati antakagera family planning namburiraga abandi baraganga family planning n'indi ubundi ziragwara no kuba kumagana bagande byose tamaze nayitira abasawo benine bansobororera ndebe nagira yebwariro nibwo bansobororeraga kareba family planning etagire songa niyo ngagomeza mu ngagizaho kareba etagire songa no kwisubisha ubuherezo ubundi kugambira batakagera family planning ndabahabura kugira ngo bagende umwanya bareke kurikiza inama z'abandi abari kuba bakareba bakabisobanura bagenda mukanya ntabwayo bakadana n'ibindi kamucyeye sesentafo hamwe n'agandi magwara abayengereje kugira batungeje bakakuvuhereza bwa family planning habwokuba tufuna obuzibu bw'okubasasula kola amagara gaabo. Nsiima obuweereza bwa Multisectoral Uganda obwetuleetiire obwerikutuheereza okugira ngu buri omwe n'omuntu arikubaryoko omu kyaro takabaasa kubona esente nyingi z'okurya abuheereza kugira ngu abaasa kubonayo akasente karinganiire aize kugyenda abuheereza bamuheereza kandi abareera family ye kurungi.
That in this particular project, from this section, we have infrastructure, we have our community. Which have been modeled offer that quality service, the post-abortion care services, together with family planning, because most of these are young people, they come, they are cautious, they are bleeding, and then you have to give service. To be very unfortunate, young as they are, 14, 16, leave them out without contraceptive. Before you know it, they become back. It has been equipped. All these remodeled facilities, they have the beds, they have storage space, the equipment, and we have continued receiving some supplies.
The exciting thing is that IPAS diversify, and this have seen that we are really now in our scope.
This is Mukuju Health Center 4. I'm called Sister Isuka Jude. We have been with the IPAS for the last 3 years, and they have been supporting us in park services and a provider for park in Mukuju, and we have all the family planning commodities in our facility. So we keep encouraging them. Once they get pregnant, they should come to the facilities. They should not go to do them in a local way. So that is why you see this room is here, provided by IPAS, and they were able to renovate it. They supplied us some equipment for park and whatever we have. So they have equipped us and we are able to do our work comfortably without any challenges.
My name is Nnabagereka. I work with IPAS Africa Alliance, Uganda program, work and collaborate with the Ministry of Health. We appreciate the leadership and the stewardship of the Ministry of Health that has enabled us to put forward high impact interventions in 132 communities, and of these, about 48 of them have received infrastructural development and renovations that go a long way in ensuring that women and girls have access to treatment and also eliminate barriers after community.
Preterm Infant Parents Network is a network that supports parents that are giving birth to preterm babies. Preterm, we've been in existence for about 4 years, and we work closely with the Ministry of Health and County National Referral Hospital. Today, basically, I want to tell you about our program that we are running with County National Referral Hospital, where we are doing community follow-up of preterm babies that have been discharged. We started this program in April this year, and so far we've been in position to follow up about 2,000 mothers and within the communities. But before we go to the communities to follow up these mothers, we ensure that we give support to these mothers in collaboration with our international referral hospital. Where mothers, once a mother gives birth to a preterm baby in the NICU, we go in providing emotional support to the nurses, to these mothers, since we are experienced parents who have given birth to preterm babies. Then, once the baby leaves the NICU, then it's discharged to the Buganda unit. In the Buganda unit, this is where we educate the mother and then just to bridge their babies, how they're supposed to take care of their babies when they go back to the community. So, once these mothers are in the NICU, we educate them on infection prevention, hygiene, breastfeeding, educate them on immunization, what they're supposed to eat as parents of preterm babies so that they're in a position to get breast milk. For those that don't have breast milk, we work together with the breast milk community that supports us with donated breast milk, and they bring it directly here at the National Referral Hospital. So once the mother is being discharged from the Kangaroo unit, we ensure that they're trained how to Kangaroo. So then we connect them to the volunteers or the VHTs within their community.
Hello, I'm Nnabagereka, a volunteer from the Preterm Infant Parents Network Buganda. As a volunteer, once a mother is discharged from the hospital, I always get an invitation to go and check them out. Once I get the contact, I reach out to the mother, find out where exactly they are. I reach out to them in their respective homes. When I reach out to the mother, I ensure that the baby is feeding so well, that is every after 2 hours. I ensure that hygiene is maintained, proper good hygiene is maintained. I ensure that the baby is given enough Kangaroo because we are supposed to give a baby Kangaroo for up to 20 hours. And once I visit a mother in the community and I notice any danger sign, automatically the baby is always referred back to the hospital.
Good afternoon to you. My name is Dr. Nnabagereka. I'm a pediatrician and also the head of department pediatrics at the National Referral Hospital. I'm here to tell you about Preterm Parents Network, that is a community support group that is helping mothers and babies for the preterms that were previously admitted at the hospital and are discharged home. So this community support group does a lot of good things for the parents. They do support supervision, I should say, for the mothers. They have expert mothers that usually come to teach these mothers how to care for their newborns, how to look for danger signs, and then return to hospital in case of any emergency. They also remind, which is quite important, they also remind the parents to return for their hospital appointments. And this has been evidenced by our statistics. Usually, previously when we were just starting, we used to have about 15, 20 preterms coming in for review. But let's at any one appointment date or clinic date, we have about 16 preterms being brought back for reviews. So I think that is good. It is helping their survival, as they'll tell you from their statistics. With the follow-up they do. Because there are other things that they do beyond the supporting. They also after materials that they give these mothers that help them in identifying data signs, things like thermometers, and they also teach the mothers how to use them, but also supply kangaroo wraps, which the mothers need when they are doing the kangaroo mother care. So I think there is more. I may not be able to say it all, but the executive director of the association will throw more light as we will see later. Thank you.
So these PhDs, we developed an app with the support of Nnabagereka. We developed an app, and this app is in position to report to us real-time data. Which mother has been seen at what time? Which mother has got an issue and needs to be referred immediately to the hospital. So once the mother is assigned to the volunteer or the VHT within their community, the VHT will receive a notification that there is a mother coming into their village. So once the mother reaches, the VHT makes an appointment with the mother, goes visits the mother, educates them on various things which include kangaroo, hygiene, breastfeeding, but also encourage these mothers to come back for the follow-up, for the clinic follow-ups. In Kawempe, we've seen the numbers increasing from ever since we started the community follow-up to about 60 mothers plus per each visit they come to the hospital. So we also ensure that once these volunteers or the PhDs go to the community, they identify, they check out for the danger signs. Of course, the PhDs, we equip them with the thermometers, pulse oximeters, the weight scale, we give them wraps that they give to these mothers while they're in the communities. And as soon as the VHT or mother champion identifies that mother has an issue, they immediately refer them to the hospital, to the acute unit, where the mother is immediately given attention. And this we've seen a lot of babies that have been saved from dying from home, because once these volunteers get there, you find that there are a lot of danger signs that they identify, which some like violence, high temperatures, low temperatures, bad breathing, not feeding. So these are some of the danger signs that we look out, and the app will automatically flag once a baby has an issue. We also encourage these mothers to come back for ROP screening. We know very well that one of the leading causes of blindness among the newborn babies is ROP. So we encourage mothers to come back for RS training, and also we're moving into ear screening because we have identified that some mothers, some babies that go blind as a result of prematurity. We also follow up, we encourage volunteers to follow up on parents that have got permanent disabilities that have come as a result of prematurity. So that's what we do, and together with the National Referral Hospital, with the support of Nnabagereka, that provides us with a home care connect app that we use to follow up with babies.
Mama inali mubera genda takoowa kyonna kyayitamu kyakutima ekiseera kiggwe takoowa kubanga bba abaana bavuge Mukama yabatuwa nga tebatuse naye bw'oba tosinza mukono era nga bwe bakugamba okukola obikola nga bwe baba bikugambye n'okwagala okungi omwana agajja kukola kijja kukula bulungi.
Amazina ni Akankiza Elizabeth, nintora Ruto Maseru, kandi nyine umushinja ubu bari kweta Mr. Arinda Dennis, nzire nawe abana babiri, kabanza kwiga family planning, ahirwa iri bari kwetwa Diane Clinic, bari kutusomesa uko kubasha kubarera rubyaro yawe, ukuza kurunja abana, ngeno mpora kurebeka rw'abana bakora kurunja, nagize irenda yo kubanza nagenda umwigwaro kuzara, batwegesa ako kubasha kubarera rubyaro, wonka agataha sinabiforowinga munonga, atahanda ya kabiri nibwo nahezaga nkabiforowinga bakabitwegesaho, kubareze kubitwegesaho nahorananye nabikunda abo kugira ngo enda yo kubanza nkazara mbwenu speed byanteganiriza, ati kubangambire umurimbo gwa family planning, ibyo nazaga danayi yino wangambira guhara uguhereza bubonire, nagendayo atakubahiriza kunshobora imirimbo yona ya family planning, natuzenga maka imporanoni kuja kabari kukanga kugira mu magara ganje, kandi kuya nakatekamo singarebire bizibu byona bumbire ndije nkaburije mesade ya imporanoni ekiyo ndikundire no ubwire buringwa, kandi okuhereza sente bakakutekamo utarira ubwire buringwa utashoboye kushashura, kandi ikindi kingakundiye omu period zinoza munkavurize kine side effect yoneyo ehiho uri kutungamo, icyatumire natuzenga kuza family planning, nkareba ukubanza ko nazire byanteganiza, ahubwo kuba nanshangaga buri ndakika ndi n'abana hataho kugira ngo ndi kuzaha ninga ndi hari, wonka ko natuzingire family planning, nareba yambonerera nanaye enda uje kinakora muri nishanga ntererire, wonka kugenda wota ya family planning ati aha nicyo cyatumye natuzinga family planning kugira ngo ziteka ndebe koko nabaririra family yanjye mu bana kusoma umuturage byabakore bari ati amtakagira family planning, nampuriraga abandi baragamba family planning nimbi ngo bundi ziragwaza, onkanya yo kubagumaga nibagambe ibyo byone najya nkitambaze nayitira abasawo benyine bansobororere ndebe, nagira yirwariro nibyo bansobororeraga, kareba family planning itagiye shunga, nungagumiza mungagizaho kareba itagiye shunga no kuyisubiza.
Thank you very much. I wish to take this opportunity to welcome us back from the tea break. I hope we are re-energized. The timekeeping and also the ushering team, let's have all the members ushered back into the conference room. Welcome back from the tea break once again. And we are going straight into shortly we shall be going into the opening ceremony for the 5th Safe Motherhood Conference. I wish to welcome you back from the tea break. I hope we are re-energized. The timekeeping team, please, let's invite all the participants, because time is not our best ally. DJ, you can give us an interlude. Thank you.
With community health workers who are delivering life. In Uganda, it is heartbreaking that we are in 2025 and close to 76% of the population, especially those in rural areas and urban informal settlements, have challenges accessing basic health care. At Living Goods, our vision and mission is simple yet profound. We envision a world where every family can easily access the health care they need to survive and thrive. And we're doing this through digitally enabled community health workers who are delivering life-saving health care at the doorsteps of the communities. Since 2007, Living Goods has partnered with the Ugandan government to improve the reach and impact of community-based health care. Today, we support over 2,400 community health workers, reaching approximately 1.4 million Ugandans with essential healthcare services. Our approach is impactful and cost-effective. CHWs go door to door, educating their communities on the uptake of health promotion and preventive services. They tackle critical health issues like malaria, pneumonia, and diarrhea, and also offer additional maternal and child health support, like the uptake of family planning, support for access to antenatal care, and immunization. We believe that if community health workers are digitally enabled, equipped, adequately supervised, and compensated, they are able to deliver high-quality care to their communities. This was demonstrated through a randomized control trial in 2013 that showed that desk-enabled community health workers contributed to a 27% reduction in under-5 child mortality. We collaborate with the Ministry of Health and other partners to strengthen the community health system in Uganda. We supported the development of Uganda's first national community health strategy that was launched in 2023. This strategy emphasizes the importance of a community health workforce that is digitalized, well-equipped, adequately supervised, and compensated in promoting good health. At district level, we support with the operationalization of these policies, ensuring community health workers are supported and communities receive the care they deserve. Pioneers in digital health, Living Goods has over 15 years of experience deploying innovative solutions to improve health outcomes at scale. Today, we are proud to be a lead partner of the Ministry of Health in rolling out the electronic community health information system, which is bringing better healthcare access to even the most remote communities. Our work is guided by core values that drive us to put families first, prioritize scalable solutions, and innovate for sustainability. Collaboration is at the heart of what we do, working alongside governments, partners, and communities to achieve lasting health impacts. Together, we can close the healthcare gap and ensure no one is left behind. Join us in our mission to save lives at scale and transform communities across Uganda.
My name is Nnabagereka. I'm the founder and team leader at Preterm Infant Parents Network Uganda. Preterm Infant Parents Network is a network that supports parents that have given birth to preterm babies. Preterm, we've been in existence for 4 years, and we work closely with the Ministry of Health and National Referral Hospital. Today, basically, I want to hear about our program that we are running with National Referral Hospital, where we are doing community follow-up of preterm babies that have been discharged. We started this program in April this year, and so far we've been in position to follow up about 2,000 mothers and within the communities. But before we go to the communities to follow up these mothers, we ensure that we give support to these mothers in collaboration with the National Referral Hospital, where mothers, once a mother gets birth to a preterm baby in the NICU, we go in and provide emotional support with the nurses to these mothers, since we are experienced parents of giving birth to preterm babies. And then once the baby leaves the NICU, then it's discharged to the kangaroo unit. In the kangaroo unit, this is where we educate the mother on what they're supposed to do with their babies, on how they're supposed to take care of their babies when they go back to the community. So once these mothers are in the NICU, we educate them on infection prevention, hygiene, breastfeeding, educate them on immunization, what they are supposed to eat as parents of preterm babies so that they are in position to get breast milk. For those that don't have breast milk, we work together with that breast milk community that supports us with donated breast milk. They bring it directly here at the National Referral Hospital. So once the mother is being discharged from the kangaroo unit, we ensure that they're trained on how to do kangaroo. So then we connect them to the volunteers or the VHTs within their community.
Hello, I'm Nnabagereka, a volunteer from the Preterm Infant Health Network Uganda. As a volunteer, once the mother is discharged from the hospital, I always get a notification to go and check them out. Once I get the contact, I reach out to the mother, find out where exactly they are. I reach out to them in their respective homes. When I reach out to the mother, I ensure that the baby is feeding so well, that is every after 2 hours. I ensure that hygiene is maintained, proper good hygiene is maintained. I ensure that the baby is given enough kangaroo, because we are supposed to give a baby kangaroo for up to 20 hours. And once I visit a mother in and I notice any danger sign, automatically the baby is always referred back to the hospital.
Good afternoon to you. My name is Dr. Nnabagereka. I'm a pediatrician and also the head of department pediatrics at the National Referral Hospital. I'm here to tell you about preterm parents network. That is the community support group that is helping mothers and babies for the preterms that were previously admitted at our hospital and are discharged home. So this community support group does a lot of good things for the parents. They do support supervision and shift there for the mothers. They have expert mothers that usually come to teach these mothers how to care for their newborns, how to look for danger signs, and when to return to hospital in case of any emergency. They also remind, which is quite important, they also remind the parents to return for their hospital appointments. And this has been evidenced by our statistics. Usually, previously when we were just starting, we used to have about 15, 20 preterms coming in.
We have so far 16 active local maternity and neonatal systems. And I want to appreciate with an applause the local maternity and neonatal system coordinators who are here in the house. Wherever you are greatly recognized. You're doing an incredible job for this country. We want also in a special way to appreciate the chief administrative officers. They are part of the local maternity and neonatal system. The RDCs, the DHOs, they have not missed my phone calls because systems must improve. Everyone must be accountable if we are to save or to end preventable maternal and newborn death. But in a special way, The cow of Kayunga. I want to recognize the cow of Kayunga, who interdicted 4 doctors on a single sitting for failing to attend to duty for chronic absenteeism. That is accountability. I would have done the same. Please, for our health workers, if you don't attend to your duties, then there are people out there who are saying you must account. Similarly, the cow of Kakumiro, who recruited all the critical staff. I don't know where he got the money, but he recruited all the critical staff needed for his health facilities, and Kakumiro is one of the best performing facilities. I hope they will be recognized at the dinner. Cross-country exchanges, we've been able to impact beyond Uganda. We had a visiting team from Kenya late last year, and they learned how we are doing accountability for results. We told them that Kenya is a richer country than Uganda, but we had better results than them. Since then, Kenya has started 6 months ago, and right now they are doing very well in MPDSR. One of the regions called Homa Bay has gone 6 months without a maternal death. They are very impressed about their experience. We also hosted Ethiopia to come and learn from Uganda. We also hosted Zambia in the year under review. They are all learning about exemplary leadership and our structure. Service delivery, the reason why we're here. There has been remarkable gains in service delivery. We conducted an EMOC, Emergency Obstetric and Newborn Care Needs Assessment, that informed our targeted interventions, enabling 78% of the health center force to offer CMOC facilities. That's an incredible achievement. 27 health center tools, mostly in refugee hosting districts, were upgraded in the year under review to health center 3s, and 11 health center tools refurbished for readiness. Emergency call centers established and functionalized in those places. 9 high dependency units established at different regional referrals and health center force. High risk pregnancy clinics, the only country probably, I don't know, in Africa that's implementing this intervention without even WHO guidance, and it's moving us miles. We're identifying any lady, any pregnant mother with a risk, following them up, retaining them in care, and linking them to appropriate care through a birth response plan. A birth planning, and these mothers are being saved. I want to thank the primary service providers, the frontliners, the midwives. They are at the top of this. This is going to deliver us to 2030. Uganda will post a very good results if we implemented this to scale. Uganda Blood Transfusion Services has increased collection to 393,000 units, 68% growth since 2002, and we have not lost mothers because of lack of blood. Can we give that a hand clap? And still on blood transfusion, we believe in functional ecosystems. When you move a patient from one ecosystem to another ecosystem of care, you get a lot of delays. We have instituted an intervention where we move the blood, not the patient. And this is being piloted in the Elgon local maternity and neonatal system. Dr. Bumba, the head of the blood transfusion, is in this house. He's been very supportive. We move the blood, not the patient. That is the Ugandan-made solution. We have saved so many. Doctor, get to theater, ectopic pregnancy, we shall get you the blood there. I want in a special way also to thank National Medical Stores, Medicine Commodities and Supplies, DG and the team. Despite the funding disruptions, Uganda's emergency kit for drugs and supplies for the last 6 months has been very stable, very stable. We have all the critical supplies, and I've been asking the ADHOs, if you know you don't have, please get to us. But also in a special way, I want to say that we've introduced new commodities. There's a commodity in that is called heat-stable carpetocin. Heat-stable carpetocin is a magical drug where you don't have a functional cold chain. Some of our places are in hot areas, so we need such new molecules to help us. Heat-stable carpetocin does not need refrigeration. It can be kept under normal room temperature. We also introduced tranexamic acid, a drug that stops bleeding. And our dear health workers, this is a very strong message for TBS, mothers who still want to deliver under TBS, traditional birth attendants. They do not have these commodities. In this special way, I want to recognize UNFPA for supporting the purchase of the first 20,000 units of heat-stable carpetosin. I also got good news that UNICEF will support us with 2 million doses of heat-stable carpetosin next year. That covers the entire number of pregnant women. So heat-stable carpetosin is going to be for prevention of PPH, and oxytocin will be for management of PPH. 70 operating theaters supported with new equipment, and this was with money from the World Bank, UPREP, the coordinator is in the house, 40 of which received a complete set, and you'll see how we functionalized theaters over the last 1 year. Digital blood stock dashboard. If you've not seen it, someone will show it to you. Every day in Uganda, we have a stock status. There's a young man called Innocent Kananura who posts the stock status. Even today, I know how much blood is in Arua, which type, and that is available for every health worker through their local maternity and neonatal system. Kananura, if you're in the house, thank you so much, and the leadership of Uganda Blood Transfusion. Neonatal care equipment, caffeine citrate, was introduced in 20 NICUs. CPAP expanded more facilities, and family planning redistribution, commodity redistribution by Maristops. After the closure of the USID, we had a lot of stocks of family planning commodities at joint medical stores, and we want to appreciate Maristops and UNFPA for coming in and distributing them. We didn't have the money to distribute them to. Thank you so much, Maristops. Under human resources, I'm very impressed that the vote for midwives has gone through. We lack the numbers. That is a good club. Our partners here, we lack the numbers. We are doing everything possible to ensure that we move to the 2030 high table. But the numbers need. Over 1,200 health workers have been trained in ICD 11. This is medical certification of death. 90 in neonatal resuscitation with the help of ELMA and SEED Global Health. And we are going to train more, 200, I think, this month. NASA will make webinars every month to address gaps in management of PPH, PET, prematurity, and sepsis. Continuous mentorship in CIMOC, Safe Motherhood, KMC, and ITO have been conducted. Districts have recruited critical cadres. I got a very nice message last night from Tororo where they are lacking an anesthetic officer, and I got a confirmation of an appointment that we now have anesthetic officers in Tororo, Mulanda Health Center for. The Corporate Society of Safe Motherhood, my DG had mentioned about it. This is an innovative way of raising local financing. Local financing. At the beginning of this year, we had 81 million Uganda shillings. And I'm one of the signatories to that account, but it's managed by Stanbic Bank. Stanbic Bank is one of the signatories. We have some money to respond to emergencies. We have bought autoclaves for Busheji, Lalogi, Nomoro, and many other facilities on emergency request. So because the government procurement system is bureaucratic by design, so sometimes we need to address emergencies head on. So we've been able to procure this using our locally mobilized fund. My call here is support this initiative with the small amount you can. Stanbic is the one holding this fund, but also in a special way, we've been able to attract partners who have been with us for the last 5 years, like Bank of Uganda. I'm happy Susan is here and Sarah, and they are going to make a statement on how much they've invested. They will tell us what to do so that they add us more money. UNFPA has given us much financing. If government commits funding, they also commit funding. We are so proud of this initiative as a sustainable way of mobilizing domestic resources. Parliamentary engagement has also been at the top. Unfortunately, we don't have any, I don't know if there's any politician here, but today, all our ministers are being nominated today, but my friend and Elder Kenneth is the minister today, the non-political minister. So we have not been able to get members of parliament. They are fully behind this, and they really appreciate the strides that we are making collectively. Performance linked to new gift grants, strengthen facility level accountability and ownership. This is the RBF. It's a magic bullet. Hard work, more money. You work more, you get more money. I think this is a revolutionary financing intervention. It has led to improvements at facility level. It's one way of doing it. We continue to, next. Performance across MNCH. If the chief guest comes, you alert me, because I've got to stop. So performance across the key MNCH indicators. The data source is the UDHS. We preferred using the demographic, no, this is District Health Information System 2. My apologies, some of the figures might not look exactly similar to what we have in the survey, the UDHS, the Uganda Demographic Survey. The reason is I'm giving accountability for the year under review, 2024-25. The survey is done every 5 years. Can we move? I started with family planning. As I earlier mentioned, family planning is a critical pillar of safe motherhood. And I'm very happy that we have religious leaders in the house who have been very supportive to family planning, like our dear Reverend Amos Magezi, who is here in the house. Kindly stand up for recognition. And send our appreciation to the Most Reverend, the Archbishop of Uganda. He's a family planning champion. Family planning colleagues, we must repackage our messages. It's not about sterilizing women. It's about healthy child spacing. It's about getting babies by choice, not by chance. It's about giving a woman an opportunity to prepare for a pregnancy. It's about ending unmet need for family planning. Now, this is the science. With the 4 million, that figure, 4 million couple years of protection, we've been able to avert 1.2 million pregnancies. There is a calculation behind that. That the more couple years of protection you have, like you're protected, women can potentially get pregnant anytime. We all know that. So with 4 million couple years of protection, CYP's couple years of protection, you are able to avert 1.2 million pregnancies, unwanted pregnancies. And remember that 42% of the pregnancies in Uganda are still unintended. That is a pregnancy by chance, not planned. I don't want to call them unwanted because I may be part of that. It's a commercial. So I'll get some serious beatings. So this is family planning. We have had a steady supply of our commodities, and I can guarantee the country that we have the next supplies for the next 6 months. And thank you, UNFPA. You've been part of this journey. Thank you, UNFPA. You can see Daniel here. I know you will say we need more money, but money is coming. Next. Next. This is also the science that we have all the methods. We have all the methods. We have all the methods available in Uganda. No one should say that we love this, at service delivery points. But also in the footnotes that about 30% of our women are using long-acting reversible contraceptive methods, like the implants, long-acting but reversible. They are good because they give you more couple years of protection. The most utilized method is Cyanopress, the injection for 3 months. And we have enough stock. Actually, we recently donated to some country through Daniel. Next. The trends in uptake of immediate postpartum family planning, this is commendable. This is commendable, and thank you, our service providers. We are seeing a very healthy trend. We are moving upwards, and this is a very healthy trend. 44% increase in uptake over the financial year under review. There were regional gains in Ulango, Bugisu, Bukedia, Karamoja, and Kampala. Well done, teams. Next, move a little faster. This is an illustration of how the different regions performed. I told you under the local maternity and neonatal system, but important to note that post-abortion family planning, for any woman who loses a pregnancy, spontaneous or whatever, she needs family planning method as part of the package. Improved uptake, we noticed that. There's higher uptake in those regions. Adolescents contribute to 15% of the total post-abortion. For the religious leaders in this community, there are abortions under adolescents. I know we are burying our heads under the sand, but the young people are aborting. Young people are aborting, and that's something that we must tackle head on. Next. Antenatal care. Next. Oh, the PS doesn't like this. Let's go back a little. This stethoscope, you can see how it's pressing on that lady's tummy. We want to abolish them. We have procured 2,000. We have procured and distributed 2,000 fetal Dopplers. And our intention is next year, this one is going home. Next. It's going in the archives. We have seen a progressive increase. There are major changes in women attending NC1. Our aspiration is to have every pregnant woman attend antenatal in the first 3 months. At least the first antenatal visit should be in the first 3 months. We still struggle with this. I don't know if the reason is cultural. We have our cultural leaders, but we need to talk to the women. The package that defines whether you're going to have a healthy baby or not a healthy baby is in the first trimester. The test for the 3 diseases that we're targeting for elimination, and health workers kindly package this better. We need to eliminate HIV, we need to eliminate hepatitis, we need to eliminate syphilis. They are all tested in the first trimester. The development of a baby happens in the first trimester, that's the first 3 months. If we don't fix the problems that are in there, then we can get any potential problem on the baby after that. So I think we need to repackage. Women can listen to this message better, but we need women to come to the health facility in the first 3 months of getting pregnant. As you can see, the performance is not good. We have a national, this year we improved a little to 40, but compared to the 2 million women who come in the first time, all of them are untimely. I know there is no push in women coming faster, but this is critical. Next. This is just a description of the regional variations, and you can see red is Kampala. Kampala, someone will need to talk specifically about Kampala. The place with the most elite people, the place with the most number of health facilities, but we also noticed that Kampala has a big challenge of access. Financial barriers might prevent people from accessing. So more women in the regions of Lango. We need to learn from Lango and Bugisu. Bunyoro, Toro, and South Buganda, North Buganda remain the lowest with 35. NC8 attendance remains low across all regions. Next. These are teenage pregnancies. I earlier mentioned that we are battling with them, and the battle continues. So there is a special multisectoral approach involving the Ministry of Education, Gender, and Health that sit regularly through a platform of permanent secretaries and also the technical people. And we are estimating that probably 1,000 adolescents, this statistic is from the Division of Adolescent Health, are getting pregnant daily. After this, you'll see Irene. Thank you very much. Next. Trends in uptake of ANC interventions. During antenatal care, there is a very nice package that the healthcare workers provide to our mothers. So we are happy to have all the interventions in green. Where you find green is not DP, but that means we are doing well. Where you find yellow is not NRM, that means we are moderate. Red is not no. So, red, we are focusing on the red. I know we shall have breakaway sessions. We are focusing on the red. We have consistently had a poor screening for hemoglobin. We are not measuring women who are pregnant for their hemoglobin level. 28% for last year. It's an improvement from 22, but not good enough. We want that in green. The Ministry of Health has done something. We've procured hemoglobinometers, the machines that can do that. I was talking to the Commission of Laboratories. We shall probably have more 2,000 coming into circulation. Whoever doesn't have, through your LNMS, let us know. HB, hepatitis B screening is also in red, has changed from red to yellow. We still have work to do. Obstetric ultrasound scan. Every pregnant woman before 20 weeks of gestation should have a scan. We stand at 28%, only in Kampala probably. On average, a scan costs 20,000 in the village. The women cannot afford. We have a program that we launched yesterday, and I think we are going to be very intentional, Chief Guest and Minister, that we are going to be intentional in providing points of care ultrasound scans next year. I'm happy the project highlights that. So the rest of the details are in the report that we are going to launch, and each one of you will receive a copy. Next, we move a little faster. This is the geography, the distribution. We are using data optimally to see who is letting us down. So I think you can see the reds. I'm not even able to see very well, but I think you can see the reds. Or what I can see is fourth ANC has more reds and fewer greens, but the first, at least one antenatal visit. Women in Uganda are attending at least one antenatal visit. We've achieved universal health coverage by 97%. At least one health visit, 97%. 4, 68%. Next. Maternity. We got permission from those people there, so don't worry. So, the trends in health facility delivery. I wanted to put a disclaimer here. Whereas the survey gives us 86%, our annual review, this doesn't mean it's a drop, but there are some facilities that are not reporting on time. We see a progressive increase. As you can see now, we stand at 71% for the financial year 2024. We clap for the midwife. In terms of absolute numbers, these are 1.6 million babies. 71% is equal to 1.6 million babies conducted by our midwives in the last financial year. And the comment is there is a significant improvement towards achieving the national target, which is around 74%, but we are going to increase it today. 11% increase from the last 2 financial years. Progress everywhere. I'm so proud of you guys. We are reporting progress. Next. This is something that you'll find in the report, but majority of the deliveries have consistently happened at health center 3s. If we have any people from the health center 3s and the ADHOs, please we clap for them. By ownership, most of the women are delivering in government facilities, 83%, 13% in PNFPs, and 4% in the private care. 83% of the 1.6 deliveries are happening in government facilities. You are doing an incredible job. Deliveries in public health facilities has increased by 100. That's an absolute number. Next, you'll see the breakdown later. This is an interesting slide. One of the resolutions last year was to embark on functionalizing health center force and trying to bring those lines as close as possible. You see, last year, we had only 66% of our health facilities were providing blood transfusion, was providing cesarean section and blood transfusion. Incredible progress. Working with UPTS, now we have, those lines are getting closer. We have 78% of our CMOC facilities able to provide cesarean section and blood transfusion. And I'll show you the graph. Over 80% performing cesarean sections, nearly 80% providing both surgery and blood transfusion. Great progress. Increased capacity to provide cesarean section and blood services by 18% increase, overall 24% among the public health facilities. The gaps remain in blood supply. We need everyone. I know Charlotte is here. She's a champion for mobilizing for blood. And remain infrastructure and skilled staffing, limiting effective emergency obstetric care. Next. Postnatal. Next. This is a graphic illustration. We are able to granulate our performance per region. I want to encourage each of us, especially the DHOs and AGOs who are here, to get interested, especially in the red, that we must eliminate red and move to yellow and green. PNC coverage is high at 96% within 24 hours. That is the 6 hours. But drops 36% at 6 days and 55% at 6 weeks. Considering consistently South Buganda is where we have areas like Kalangala, Greater Masaka. I hope I got it right. South Buganda is Greater Masaka, and that's why our chief guest, I'll get a way of packaging this for her. We need to work with the cultural system to ensure that these indicators in South Buganda really improve, especially uptake. And Toro, since I'm also a minister, I'll take that one myself. West Nile, I think we shall give it to Baku, Chandia. Need to draw lessons from good performance from Acholi and Ankole at 6 weeks. Amazing performance. 6 weeks is a missed opportunity. 6 weeks is the health service milestones. It's the first time the baby is brought for immunization. We want that to be 100%. That means babies are brought for immunization, but they are missing out on, mothers are missing out on PNC. Our service providers, we can do more here. Next. Our trends in PNC missed opportunities. This is the slide where our service providers need to focus. We are really missing an opportunity where a mother comes with the baby and we're not attending to them. And that's what is bringing on. We are going to move down and ensure that there is proper integration. Next. The baby, the newborn, the voiceless, they are here. And as a preamble, this is one indicator that has not improved significantly for the last 20 years. But next year, the next 5 years, we are going to go massive on newborn care. We lose so many babies. Next. This is a show of the prevalence of low birth weight and initiation of KMC. Any baby born with less than 2.5 kilogram is considered low birth weight, and those who are less than 1.5, very low birth weight. The lower the age, the more the complications, the more the problems. The more the problems, the fewer the chances of survival. And we need a health system that is responsive. So the prevalence of low birth weight is still at 5.2 of the live birth, up from 50% babies with low birth weight are at term. 50% of the babies with low birth weight are actually 9 months. Are 9 months old, but this is a nutrition problem. And recently, DG went to Kabale. Kabale has the highest, despite being a food basket. They have the highest number of preterms, the highest number of low birth weights during the regional conference. So we need targeted interventions to address some of these. The proportion of live babies with birth asphyxia. Birth asphyxia is difficult in breathing at birth. This table illustrates that we are making progress, and there has been a deliberate intention to train health workers, and you can see successful resuscitation is at 92%. We appreciate you for picking these lessons very well. We need to prevent and manage obstructive labor, scale up CPAP, continuous positive pressure in labor wards, improve provider skills. All these are areas of investment, and they need some resources if we are to have everything set for the newborn. Our investment for the newborn has been suboptimal, but we need to have a focused attention for their survival. Next. This will be found in your report. You'll look at the regional distribution, but it highlights the proportion of babies with birth asphyxia. You realize that most of them are the higher centers of care. We are a bit happy of this, but we need to find out why. Is it because of the high numbers and the higher levels of care, the health center for the general hospital, and the highest being the national referral hospitals? It could be because of a functional referral system, but also because there are so many cases and there are delays within the institutions. The clinical services will work with us and we see how we can fix this. Notable decline in birth asphyxia rate. This is good news. General and regional referral hospitals have reduced about 5 to 6% in the last financial year. Babies born with birth asphyxia successfully resuscitated. Next. Child health. We have intentionally brought child health. This is the first time we are giving a state of the nation MHCH. Last year we gave only MPDSR, but we felt that there was need to expand and give the larger scope, and this is child health. Immunization is making good progress. Next. And we have introduced a couple of vaccines. Immunization coverage, you can see this is progress, and we shall avail this in your reports. The report is available. But in conclusion, immunization coverage continued to perform well, maintaining levels above 90% of the targeted key antigen. This is massive. I wish we can do the same for malaria vaccine that we've recently introduced so that we can protect our children. That would be the future of this country. Next. Fully immunized by 1 year, we will also find it in your reports. Immunization coverage continued to perform well, maintaining levels above 90% of the key antigens, as you can see. Next. The prevalence of the top 5 childhood diseases in OPD, the childhood morbidity remained concentrated among preventable conditions, with cough, malaria, and diarrhea accounting for the most outpatient visits. These are the conditions that are disturbing our children, and we think we can do a lot because they are preventable. Next. Mortality. Now, this is the MPDSR report that we've been having over the years. We are very intentional at counting the dead. Not that it's the best thing to do, but this year we've also been able to estimate the case fatality. And Professor Piers must be happy because we talked about this. And we've also started operational research on following up near misses, those who were almost dead, who survived a life-threatening complication. So institutional perinatal mortality. Our story of counting started in 2016-17. That's a beautiful graph that we need to clap for, and we stand at 15.4. As of today, we stand at 15.4 of our institutional mortality, institutional perinatal mortality. A very key indicator of how responsive our health services are. And we really want to appreciate the healthcare workers and all of us, the stakeholders, for this. The highest decline among was among the fresh stillbirth, 31%. As we all know, fresh stillbirth is the measure of quality of intrapartum care. We have deliberately invested, we have trained, and DG, we have improved intrapartum care. 31% decline of fresh stillbirth. We want to take that one to zero. We want to take that one to zero and indicating improvement in the quality of intrapartum care. Next. This you'll find it in your report book. It's available, but it shows the regional variations. But importantly, we need to flag off the red Bukedi. Bukedi, that's the Greater Elgon. I hope Kampala is still part of this. Kampala has problems. Kampala, Karamoja, the reds, you've seen the report. Next. Now, these are trends in the national perinatal death notifications. As I earlier mentioned, we have a very robust program, one that countries in the world are benchmarking of perinatal death review and maternal death review. Most of the notifiable deaths are being reviewed, and we are proud of this. But the graph shows where we've come from. We came from 1.5% reviews. We now stand at, I can't see, I think 56, thereabout. We now stand at from 1.5 probably 10 years ago to 56. Commendable work. Over 2/3 of the regions met the greater than 50% target. We thank you. Kampala, Busoga, South Buganda, Teso, and Toro still need support for improvement. Next. This you'll be finding in your report. It shows the perinatal death reviewed by type and birth weight. We are so detailed, but in summary, 54% of the perinatal death were greater than 2.5 kilograms. We don't expect a baby greater than 2.5 kilograms to die because those ones don't have a lot of complications. These ones, we must address the gaps. And next, causes of early neonatal death over the last 5 years. As we mentioned, we have had a decrease in birth asphyxia. We are registering decreases in everything, but we still have work to do. And that is really significant. So you read in your report. So the report is quite detailed, and for those who love reading, but those who don't love reading, next, it's a problem. But we shall put it on soft copy. Decision to incision interval. We have moved from measuring these things of pathograph use, dear health workers, because you feel them after birth. You feel them retrospectively. Some are religious, they feel them religiously, but some of you feel them after birth. We are going to measure, we are going to be intentional. DG, you alert me. Since you're my friend. Okay. We are going to be intentional in measuring the decision to incision time. Emma, that means I stop? Okay, continue. We are intentional in measuring the decision incision time. When the chief guest comes in, I will request that we stand up. I will also stop, and then we go into the protocol. I will come in and complete. The decision to incision interval, 2024. Commendable work. Thank you, the doctors. Thank you, the service providers. We are seeing a decrease in the time it takes for a mother to receive an intervention. Most outcomes of fresh stillbirth were operated within 30 to 60 minutes. We want to reduce that to less than 30 minutes. We need to make sure that the system is ready, our facilities are ready, the critical human resources are available, and I hope we have consensus on this and we shall be able to improve. Next. Pregnant women, mortality. My most favorite, and I want to be remembered as a champion for mothers, is, thank you. Mortality, institution, and maternal death. Next. Amazing journey, and I want us to clap for the healthcare workers. You see where we stand? There has been a sudden drop in institutional death from 83 per 100,000 to 69 per 100,000, and this is commendable. 25% reduction. It's a 25% reduction in 1 year across, 25% reduction across the 5 years. We started at 109, it was not 100, 109 per 100,000, and we have moved steadily. Where you see 90.3, that was the time of COVID, there was system disruption. But at this rate, I think with all of us energized, success has so many fathers and grandfathers, we shall be able to achieve. If we increase it, I've been told that we need to double, we need to reduce the mortality by 13.5. We are currently 13.5%. We are currently reducing at 7.9%. This will lead us to the SDG target of less than 70%. 16% reduction in IMR last 2 financial years, 23% reduction in IMNR in the last 3 years. You read this in the detailed report. Next. This is our regional show. And allow me on this case to single out Bunyoro. Bunyoro has been problematic for the last 5 years. Bunyoro, if we needed a standing ovation, I would stand for you. Look at Bunyoro. Dr. Bwaga and your team, Team Bunyoro, coming from 114 in 2021-22, and you are now at 67 per 100,000. This is the most market reduction. Thank you so much, Bunyoro. We have a project coming in Bunyoro. We think you will even do much, much better. The problems are still in Kampala. Kampala, you can see. We shall granulate Kampala and describe it very well. And we really want to thank you. 69.1 institutional mortality is unprecedented. Next. Who is dying? We've been very critical in knowing who exactly is dying. The mothers who are dying most, you can see the different years. We've reviewed 3 years. IMR declined across all age groups. Adolescents account for 1 in every 10 maternal deaths. 10% of those who are dying are young people. They are not supposed to be pregnant. They're supposed to be in school, but they are dying. So we need to do something about them. But also see that the age group that's dying most remains above 25 years, and the number 1 killer is postpartum hemorrhage. Next. Trends in maternal death notification. 15% increase in notification rate over the past 5 years. Very commendable work. And you can see we are rotating in the highest levels. And but there has been a slight decrease. Colleagues, let's get back to work. Tuko na kazi. 19.6 increase in reviews. Commendable work. Next. This is the distribution of institutional maternal mortalities. I want to report that 56% of all districts reviewed more than 95% of the reported maternal death. Every death in Uganda is audited, is reviewed, and we must know what killed the mother. 6 districts named below failed to review or capture any of their reported maternal death. Must wake up. Bokedia, Butebo, Isinjiro, Nakasongola. Please work on that. 23 districts did not report any maternal death. And I want to single out Adjumani. Adjumani had gone 4 years without a maternal death. Adjumani, I don't know the magic they do. Thank you, DHO Adjumani. I don't know the magic in Adjumani. I need to come and see. But Adjumani had gone 4 years. They recently got a maternal death. They all kept crying the whole day. I want to stop and we make a standing ovation for the grand entrance of our chief guest. And please feel free to stretch a little bit. It's part of our self-care. I can see Dr. Byarahanga. Self-care, take water and stretch a little bit as we welcome our chief guest. And immediately, my friend Emmanuel will guide us into the protocol of anthems and all the others that will follow. I think we can welcome her with a hand clap, our chief guest, Her Royal Highness, the Nnabagereka. Sylvia, you're most welcome. It's a privilege to host you at the 5th National Safe Motherhood Conference, as the mother, as the champion of the young people, as the appropriator. Thank you. After the drama, we shall have the anthems.
Thank you, thank you, thank you. Thank you. Let's take our seat. Let's take our seat. Let's handle this. Honor of our guest of honor. Thank you, thank you, thank you. The drama team, thank you. Thank you. A round of applause for the drama team. We may all rise for the anthems.
Thank you very much. We may be seated. Our chief guest, Your Royal Highness, the Nnabagereka of Buganda, you are once again welcome to the 5th National Safe Motherhood Conference. Allow me to hand over to our Director General Health Services, Dr. Charles Oraro, to moderate the opening ceremony. Doctor, you're welcome.
Thank you, Emmanuel. Let's put our hands together to officially welcome Her Excellency, Royal Highness, the Nnabagereka. Your Royal Highness, the Nnabagereka of Buganda, Your Excellency, the ambassadors and members of the diplomatic corps, the members of parliament, the chair of the Health Development Partners, the chair of the Health Service Commission, and the members of the commission, the members from the government ministries, departments, and agencies, our development partners, district leaders, DHOs, ADHOs, all health workers, cultural and religious leaders, the civil society of Safe Motherhood, and all the family of Safe Motherhood, distinguished guests, ladies and gentlemen. Allow me to welcome Your Excellency, Your Highness, my apologies, Your Royal Highness, to this 5th Safe Motherhood Conference. The theme for this 5th Safe Motherhood Conference is strengthening multisectoral collaboration and mutual accountability for safe motherhood. As a ministry, we believe that no mother should die while giving birth to another life. And we share the same principle, and so we want that we amplify all our efforts and we bring all people on the table. So, Your Excellency, in the House, we have members from participants from government, from cultural leaders, from religious leaders, and from other agencies other than the Ministry of Health, from the other ministries, Ministry of Finance, Agriculture, Gender, but also we have members from the civil society organizations. We have also members from the private sector, the corporate society of Safe Motherhood, and I want, now that we have members from Bank of Uganda, who are members of the corporate society of Safe Motherhood. Let's appreciate them. We also have Madame Charlotte Muosi, who is also one of our champions on helping us in ending deaths, maternal deaths due to hemorrhage, what we call postpartum hemorrhage. We want to appreciate her. We have also the representative from the Rotary family, and we have representative from the District 9214, the district governor present here, and the fellow Rotarians who are here. We run this short program. First of all, I want to thank you for coming. But we will run it quickly, and we'll already started on the national annual MNCH and MPDSR report, which we are not completed. And we saw that when you come, we'll give you some of the key highlights, and then we'll be able to continue with the program. So without wasting more time, allow me to invite our presenter for this, whom all of you know, the Commissioner, Reproductive and Child Health, Dr. Richard Mugai. He is the chief midwife. So Mugai, take us through this.
Apologies, DJ, I prayed for you. Thank you so much, DG, and our chief guest. We are happy to have you here. And thank you very much for allowing to be with us as our chief guest. And we appreciate all the work that you've done for Safe Motherhood. So we had started on giving the state of the nation maternal, newborn and child health presentation that had moved halfway. And importantly, about this conference, this is the 5th consecutive Safe Motherhood conference that we strongly believe you are part of this community, because we know the great work that you are doing in the Uganda Kingdom and internationally, especially your work around the Chisakati, especially, I think, deserve the club. Madam Chief Guest, that, Your Royal Highness, that is a model intervention that we feel we have seen, and we really think that it's very transformative for the young girls, especially in this era where Uganda still struggles with very high numbers of teenage pregnancies. We request that you extend the same message to the other kingdoms and the other queens in the other kingdoms, so that we can protect our young girls. 24%, one in every four pregnant women is a young girl. And also 25% of the maternal mortalities are happening in the age group 15 years to 25 years. Not very good statistics. And we think that the country loses a lot by having these young people have these difficulties. Madam, Her Royal Highness, the Chief Guest, allow me also to mention that yesterday we had a young people. You might be shocked there are not many young people here. Yesterday we had a pre-conference event for young people and the youth. We specifically have one special day for them because of their uniqueness in terms of their needs. They come here, we pick them from different parts of the country with the support of our partners. We bring them in a central place and we discuss their issues and how we can mitigate some of their issues. We have noticed outside teenage pregnancies, there's also an increasing number of substance abuse among young people. And this is for all of us in this house. They will be here on the final day. A representative of young people will be here on the final day to represent them and provide their resolutions from yesterday's meeting. This is the broader way. Your Royal Highness, the theme of this conference is to make Safe Motherhood everyone's business. It's a multisectoral business. Saving women and ensuring they are surviving and thriving is everyone's business. So with those remarks, I felt I should give that background, and we continuously move in this kind of way to ensure that Uganda has the very ambitious target of ending preventable maternal newborn death by the year 2030. We want to be at the high table where the UN target is 70 per 100,000 live births, but for us, we're at 189, and we think we can make it. And this is where I was with the presentation, and I will request that I complete it, then we go to the other agenda items. Can we just go a little bit on the mortality? Yes. Your Royal Highness, Uganda is a very fertile country. We have approximately 2 million pregnancies a year, though we deliver around 1.6 in health facilities, but the total number of pregnancies is around 2 million. We want, our aspiration as service providers is every woman in this country to give birth the number of children she or the couple wants, not by accident, but by choice, and also to be able to plan very well for their families so that we get a very productive population that will deliver the Uganda Vision 2040. Those were regional variations I had earlier mentioned, and we shall reach your office because we need your support, that we notice South Buganda and then North Buganda and Kampala have been having very poor indicators across the board for newborn, for maternal, and for child health. So we are going to work with your foundation to ensure that we carry a message that's very strong to ensure that we save mothers and the newborns. Antenatal care and also still challenges. Next. This slide was speaking to who is dying. We've been able to analyze our data, and we do this on an annual basis, but we also do this on a weekly basis so that at the end of the year, we granulate and present. So overall, we have noted a decline in IMMR, which is institutional maternal mortality across all age groups. Institutional death means that either the mothers are delaying in the community, they are delaying to reach the health facility, or they are delays within the facility. Those 3 Ds can cause a mother to die. A delay in the community, which is within the means of our other players outside the health system. The delay to reach the health facility, broken bridge, a poor road, lack of transport is delay number 2. And delay number 3 is the delay within the health facility, absent health worker, inadequate equipment, inadequate commodities. So we have done so well to improve on availability of commodities and equipment, and we still continue to do a lot. And that's why we are seeing a decline in institutional maternal mortality. We still have work to do. And this year we celebrate a 69 or close to 70 per 100,000 deliveries institutional maternal mortality. Next slide. We're intentional in knowing that every mother who dies, wherever they die from, we get a notification, and every mother who is notified is reviewed. The best case scenario would be to have both of those lines. If it's 100% notified, 100% is reviewed. So we also need to know 100% dead, because we have introduced a community system where the communities are going to report. If the healthcare workers are not reporting some of the maternal death, the communities will report them. We have community health extension workers, and my colleague, Dr. Richard Kavanda, who is one of the subjects in Buganda Kingdom, is here with us. Is spearheading the community health extension program that is very strong on reporting and enlightening our communities at that level. So the best case scenario here is both of them, same number notified, same number reviewed. We are moving those lines closer, and we did so well last financial year, despite the slight drop. Next. Our dear participants, we still have areas of pain. As you can see, institutional maternal mortality reported. You can see where we have red. Red is, those are districts that are really still have concerns, and we need to support them intentionally. Our team is going to support those districts. Is Sinjiro, Namusinwa, and the like as highlighted. The details of this are in the big report, and I beg to continue to the other one. Next slide, move a little faster. The leading cause of the maternal mortality over the last 5 years, the women who are dying, what is killing them? So through our audits, very comprehensive audits, and where the health workers don't do comprehensive audits, we actually conduct confidential inquiries. Confidential inquiries are constituted by a team from Ministry of Health, and the local maternity and neonatal system. We come in, if you don't audit yourself well, we come in and help you and audit you. So we do audits of these maternal deaths, and we have found that continuously bleeding from after childbirth, before and after childbirth, which we call obstetric hemorrhage, has remained the leading cause of maternal death with 40 to 46%. This is followed by hypertensive disorders that have risen from 15% to 20%. And we need to investigate that. I'm happy at the Ministry of Health, we have a NSMC committee in charge of PET or hypertensive disorders. They'll be able to investigate that. New risks such as anesthetic complications. For very long, we had neglected this area, and now it's coming up. And DG, I want to promise that we are going to address this. This is within our means to address. Anesthesia, the medicine that we give, are a challenge to our mothers at some points. Next. So when we did a deep dive, and this will be found in your report, those who want to understand the detail, because obstetric hemorrhage also is broken down. Bleeding can be before childbirth, can be after childbirth, and PPH is the one after childbirth. It's the most common one at 80%. The one at 20% is before childbirth. So PPH contributes 80%. We have the drugs, and we want to make our messaging very clear that we now have the drugs in our health facilities. We have newer commodities that are very effective, including heat-stable carbetocin that we've received with the support of our partners. The highest reduction in PPH was due to uterine atony. Because of the new commodities, we've been able to reduce PPH, and we continue to reduce that. Increase in PPH after C-sections is an area of concern that we shall address. Next. I wanted to mention that under PPH, we still have cultural practices where we have members of our community taking drugs that are uterotonic. Uterotonic means they cause the uterus to contract. When you contract the uterus, and this is for our Royal Highness, especially, I don't know what is in Mumba, but there are other uterotonics that mothers take. By the time they come to the hospitals, the uterus has ruptured. Because if you take some of these local medications without the opening of the uterus being open or adequately open, then it will appear like a blockage and the uterus will continue to contract, and that can cause the uterus rupture. When the uterus ruptures, the chances of survival are reducing. You can lose life in the next 2 hours because the bleeding is really massive. So this is what we are describing. Next. This will be in the report. I don't want to take you through the detail, but this is granulating per region and where we have issues. Please, if you're in red, kindly address that. But importantly, we notice a delay, a reduction in avoidable factors contributed by delay number 3. We still have challenges in delay number 1. We need to do a lot. Delay number 1 is happening at the community. My husband is not around and not going to the hospital. I need transport. I need passport through my Senga to give me permission. I cannot go. I delivered all my babies through Mama Tendo. So all these are delays at community. By the time everything has gone wrong, the health system doesn't do much. We notice an improvement in delay number 2. The roads are getting better. We still have problems of floods and water bodies, but the Ministry of Health has procured 300 ambulances and distributed them, including on water bodies, and we appreciate government for that. So we are also working so hard to reduce the delay at facility level by making sure everything is available. So everything about the delays is critical, especially delay number 1. Next. Key recommendations. I think I'm coming towards the end. Service delivery. We think and we recommend to implement and monitor a regional health center for functionalization. The health center which is soon transitioning to a community hospital, is our lowest level where we have a theater or a doctor at that point. In the structure for community hospitals, they will have 5 doctors, and I hope we shall have the funding to make sure that we have 5 doctors at health center 4. We want 24/7 attendance to emergencies. The mothers who die are not by accident. They all present as emergencies. You need the highly specialized people, the doctors at health center 4. Most of them are in the villages. and we need to have that. That is directly within our means. Health workforce, we are happy, Madam, Your Royal Highness, our employer, the Health Service Commission, the Health Service Commission chairperson is here with us, Dr. Henry Mwebesa, and we need to have more midwives so that we have better access at lower level health facilities. Of course, this goes with funding, and our partners, we are happy if you can support us in this. Commodities, we have been stable despite the financial disruptions, but because of the increasing numbers, 2 million deliveries a year is not a small number. We're always in need of more supplies, need of more commodities. We have newer commodities that are being studied and are going to be piloted in Uganda, like Celox PPH, for preventing bleeding amongst, I think there is a stall out there. You should be able to see a stall of Celox PPH. And one of the new commodities that stops hemostatic device that stops bleeding from uterine atony immediately, including tears. Information systems, we are very intentional in using data for evidence-based decision making. As you have seen, we are so detailed, we know almost what is happening at village level. And through the community health extension workers, we've developed an electronic community health information system that now picks information from the village level about health. Leadership and governance, this is the driving wheel for all this, and accountability. I can assure you, the Minister of Health, and we shall have the statement from the Minister, is more than ready to drive Uganda's agenda to make sure that women are not dying and babies are not dying and surviving. Next. I want to thank you all for listening and for this opportunity to share with you the State of the Nation address. Thank you very much.
Okay, thank you, Richard. Another applause for Richard. I have been informed our chief guest definitely has very short time, but we'll make this very fast. I want to invite the following people in front. The High Excellency Signa Winding, the Ambassador of Denmark to Uganda, who is our keynote speaker. I also want to invite the Ms. Susan Wasagala from Bank of Uganda, the chair of the development partners. He also join us in front. The development director, British High Commission, will also be making some statement. The chair of the Health Service Commission. His Excellency, I want to invite the representative of the Honorable Minister of Health and also the PS, Kenneth Akiri. Let's clap for him. He has big responsibility. Because all what we are going to say here, he will definitely. So since they are all here, I also want to invite the chair of the civil society organizations, Jackie Katana, representing civil society organizations. They will all make short remarks. Don't worry. It's only Richard whom I was worried because he was trying to behave like a politician. It was taking a lot of time, but was communicating very relevant information. So at this point, Your Excellency, I want to welcome you to make your keynote address. Let's put our hands together as it comes.
Thank you. The chief guest, Her Royal Highness, Nnabagereka Sylvia Nnabagereka, the Queen of Buganda Kingdom. It's an honor. The Undersecretary of Ministry of Health, Dr. Kenneth Akiri, representing the Minister, the Director General, Ministry of Health, Dr. Charles Olaro, the Chair of the Health Commission, Dr. Henry Mwebesa, fellow members of the Diplomatic Corps, the Deputy Country Representative of UNFPA, distinguished members of government, departments and agencies, esteemed health professionals and development partners, dedicated cultural leaders and religious leaders, ladies and gentlemen, good afternoon. And first and foremost, a big thank you to the Ministry of Health and all the partners for bringing us together today and for the next 2 days. It's a great honor for me to stand here before this esteemed gathering that very importantly unites government, development partners, civil society, and community leaders. We all share one powerful singular purpose: to ensure that no woman dies while giving life, and to ensure that no girl's potential is cut short before it blossoms. The conference theme, strengthening multisectoral collaboration and mutual accountability for safe motherhoods, is a strong call to action to all of us here in the room. I don't know what the men want. You okay? We're okay. What I was saying is, it's a strong call to all of us. That's why, of course, it's important that so many people have gathered here today. Safe motherhood is far more than an item of just the Ministry of Health checklist. We had a long report, we know they've done a lot, but it really concerns all of us. It's an economic, social, and political imperative that touches every sector in Uganda. When a mother thrives, her family is stable and the community flourishes. So safe motherhood is an engine of human capital development, which is the key driver of national economic growth. Therefore, it should be a concern to all of us. And safe motherhood is indeed a multisectoral imperative. Achieving safe motherhood requires contributions from every sector of government and society, as well as the private sector. A few examples for those of you who are already here today. For those from the education sector, safe motherhood begins by keeping the girl child in school, empowering her with knowledge and choices before she becomes a mother later on in life. We already heard from the Ministry of Health the much higher risks of maternal mortality for teenage mothers. But a World Bank study from 2011 also showed us the economic benefits of keeping girls in school and avoiding teenage pregnancies. It shows us that 1 extra year of primary school education boosts girls' future wages by 10 to 20%. And 1 extra year of secondary school adds another 15 to 25%. So education significantly boosts women's future income and thereby strengthens the entire economy. For those from the Ministry of Roads and Works and Transport, safe motherhood also depends on well-maintained roads that allows an ambulance or other transport means to reach a remote village, or as we have heard, a remote part of Kampala, in time for an emergency and transit back to a health center facility. And for the Ministry of Finance, safe motherhood is to be considered a critical investment. Every shilling spent on quality maternal and newborn care yields a return in productivity and social stability. So collaboration across ministries is essential because the survival of mothers is closely linked to the success of multiple sectors. When ministries work together, their combined efforts are far more impactful in improving maternal health outcomes. But we should also involve the private sector. The private sector should invest in digital health and local supply chain innovations, areas that offer a clear return on investments while also supporting ethical service delivery for pregnant mothers. Distinguished guests, Denmark and Uganda share belief in human dignity, equality, and sustainable growth. Right, empowerment, and equity issue. Prime example of this commitment is Denmark's support for the Strengthening Adolescent and Youth Empowerment and Rights Program, or as we call it, the SAY program. This program is a collaboration between UNFPA, Mary Stopes International, Care International, Naguri Teenage Center, and the Ministries of Health and Education. It empowers young people, both girls and boys, with sexual and reproductive health and rights, life skills, and community voice. And earlier this year, I had the privilege of meeting some of the young people we supported in West Nile and who are engaged with the SAY program. One, and I must say very young, mother in West Nile told me the story of how after her unwanted and very early pregnancy, with the program, she was supported to access the desired family planning services, to return to her studies, and she's now working towards completion of her Senior 4 exam. To me, that shows us that even if you do become a mother at a time in your life that you don't want to, and when you are still a child, with the right support, you can be given the opportunity to continue your education and become a productive member of your community. Another peer educator, or as we call them, our male role models, so our role model boys, was telling us how he and his peer role model boys now lead community dialogues on safe motherhood, dispelling myth and promoting antenatal protection. The importance of involving boys and young men in advocating for safe motherhood and the rights of girls cannot be underestimated. These stories from my trip to West Nile are not about abstract policies. They are about real lives, real futures, and real hope for Uganda. And they remind us that safe motherhood begins long before a pregnancy. By empowering young men and women, we are shaping informed choices, healthier pregnancies, and stronger communities. The stories also remind us that accountability begins early. Our investments in maternal health, youth programs, and community accountability are not separate silos. They are integrated strands in Denmark's partnership with Uganda. And for Denmark too, accountability means ensuring that every single shilling that we spend here is used transparently and reaches the mothers and the young people it was intended for. Let's not forget those at the front line. The midwives, the nurses, and the community health workers who embody the multisectoral collaboration every single day in their work, who bridge the gap between the policy, the financing, and the mother in the delivery room. They deserve our accountability, they deserve our investments, and they deserve our respect. Ladies and gentlemen, as we've heard, to reduce maternal mortality in this increasingly unpredictable and challenged financial environment also demands us to be bold and creative with our financing, moving beyond traditional aid models. This means, among other things, embracing local innovation. Look at the digital health solutions, the apps, and the local supply chain innovations that we know have been developed right here in Uganda. These are low-cost, high-impact digital solutions, and they're often the smartest investment when you have a tight financial landscape. Doing the leapfrogging, getting away with more expensive models, using technology to get to a point where we can use our financing smarter is not just the smart thing to do, it is also very necessary in the current environment. And Denmark supports the development of these vital digital tools, demonstrated through initiatives which empower midwives and save lives and money. Distinguished guests, to conclude, the most profound collaboration is not only between ministries or between ministries and development partners. It is between a health system and the community to which the family, the mothers belong. It demands accountability across all levels of leadership, from the parliament where policies and budgets are shaped, to ministries where priorities are set, to cultural and religious leaders who guide social and cultural norms, to development partners like ourselves who must be transparent and efficient in our support, and finally to the families and communities themselves. This is the true meaning of multisectoral collaboration and mutual accountability. Every sector, every leader, every partner, every household sharing the responsibility for one mother's survival. So let's leave this conference determined, collectively, not to let strengthening multisectoral collaboration and mutual accountability remain a tagline. Let it become a lived practice, investing wisely, demanding accountability fearlessly, and working tirelessly across all sectors and communities. May the moment of giving birth be marked by safety, dignity, and joy as a true celebration of human potential. I thank you and encourage us to tukolora wama. Thank you.
Another round of appreciation. Our next speaker will be the representative of the civil society organization, Jackie Katana.
Thank you so much. Allow me to stand on the protocol as observed. And our guest of honor, we are very honored to have you here. I'm Jackie Katana once again. I hail from an organization called Faith for Family Health Initiative. And my board chair is there, Bishop Amos Magesi. He might think I've changed jobs. I'm just a leader, but I'm still with Refecha. On behalf of civil society in the room, can you wave? Here we mean even implementing partners, not activists only and advocates. Thank you so much for coming. And as you can see, we make over 50% to 60% of the participants here. And we are here to affirm that this theme actually addresses our mandates because we are the ones that strengthen multisectoral approach engagement, but also mutual accountability. We are called the reproductive, maternal, newborn, adolescent health, plus nutrition and healthy aging platform. This platform is a global financing facility or World Bank mechanism that is charged to track implementation and the monitoring of the sharpened plan for RAMCA. That means that when we talk about mutual accountabilities embedded into the platform, we are members of over 180 organizations. Those are registered, but those who are working on RAMCA are more than that. So Safe Motherhood is under that platform. We are here to affirm that the results that were shared in the reports and the presentations this morning are very true, but we are very grateful that we are all working together to see the progress that we've seen. The drop in maternal child health, but as our commissioner affirmed, newborn we are doing badly, but also teenage pregnancy is really dwindling. For over 10 years we are stagnant. And we are here to combine our hands, to put our heads together through this multisectoral approach to ensure that we address it. To give a snapshot, with the support of WHO and Ministry of Health itself, through the UCREP World Bank project, they supported us to conduct a social accountability exercise, which has just ended. And most of the findings affirm the gaps that have been highlighted, especially in service delivery. And I'm very grateful to our moderator in the morning, who is a champion and advocate for midwives. It was confirmed that we have almost, I can't say nothing, but in some hospitals like Mukono General Hospital, we found one midwife assisted by interns serving 200 mothers per day. And Mukono is just here. What about other hospitals that are out of town, and even in terms of monitoring, the supervision is very minimal. So we are here to advocate. As we sit in this conference, can we find strategies? Can we work together as partners, find resources? The Service Commission, we are very, very happy that the chair is our own, the former Director General Health Services, who understands these problems. We are looking to you. When we're discussing and engaging, because we are trying to find a real gap with the commissioner midwifery, according to the statistics, the new structure, service structure, and the old one, we need around 10,000 midwives to be able to address the gap. So we need to work together. The gap is real and the challenges are real. If we can be able to address that, then we'll be able to move on. The other challenge we found out was whereas our commissioner affirmed that we have medicines and supplies for maternal and child health, we realized that the stocks are doing very well in joint medical stores and also the health facilities, but the last mile delivery, when it gets to the communities, we still have a gap. Most of these were funded by partners, and you know what has happened to our landscape. So we need to work on the distribution and redistribution so that the last mile deliveries are happening. But we are assured by Ministry of Health that that is being done. When it gets to innovative financing or domestic resource mobilization, we've been doing this for over years, and we are glad that there's a shift. In the new budget, we got 4.4 trillion on the healthy sector, but that's healthy sector. But also we are very happy that we have what we call Vote 116 that goes to reproductive health commodities and services. We are advocating for more, but there are other ways. And in this meeting or in this conference, we are calling upon you. We've advocated that we get what we call sin taxes. When you drink beer, eat sweets or anything sweet, you're taxed. And that money right now is sitting in URA. So how can we get that money since they are affecting our health? And part of it is even reproductive health. How can that money come back? So that they address the damage that they are causing, including our newborn. You know what happens. I'm not a medical doctor, but I'm a public health. The medical doctor can explain what happens with smoking and alcohol to mothers who are expecting. We are also here to talk about when it gets to governance. We realized or found out that there are a bit of functional structures in terms of the healthy, the DHTs and the HUMICs. Those are the government structures, and the healthy facility, the functionality, and the integration is still lacking. Now to our commissioner, Dr. Kabanda, our champion for community systems. We appreciate where we went, and we have already queues working alongside the VHTs. The integration is happening, and mothers are being followed and free referral. But we have now only 36. You're yet to confirm whether you've added more. But we have over 156, if not 60-something districts. How fast can we move to make sure that the referral system that has been affected by the cuts is addressed? Because we know that this cutting affected around 4 areas. One was community engagement and outreaches. It affected the redistribution. Now, if we don't get a strategy of addressing those gaps, we are going to get challenges. We applaud again the government of Uganda for coming up with other strategies. One of them is the integration agenda, where now we've addressed the silos, and we are looking forward for that strategy, but also developing the sustainability roadmap that is also being worked on. However, if we are to address some of these challenges, we need to get the systems work together. The integration speaking to sustainability, the community healthy systems, working for extension workers, but very, very important, we cannot stand here and we don't call for ensuring that we have a national health insurance. Because if we have a national health insurance, the integration system is working, a very clear roadmap. And then we have our queues or community health extension workers. The investment that we have will be able to be efficient. Once again, we commit that we are going to be with you throughout this conference to come up with strategies, and not until we reduce teenage pregnancies and we don't see any mother dying and the newborn challenges are addressed, we will not rest. We are foot soldiers and we are advocates who continue to serve with you. Thank you so much.
Thank you, Jackie. You know, the chair has got challenges moderating a high-level panel. Sometimes making them to stop is very difficult. Before I call the next speaker, allow me first to recognize the people who are accompanied. Her Royal Highness, Owek, Port Leader, Nakete, Kikemepo, who is the Minister of Health and Education in the Buganda Kingdom. We want to welcome you. On a special note, I also want to recognize she was my head teacher in Trikona. So, not that I attended Trikona, but I had a student. Miss, so Trikona is around. Say hi. This your head teacher is here. She's now the Minister of Education, a Minister of Health and Education in the Buganda Kingdom. Miss Judith Kamanji, who is also accompanying Her Excellency. Dr. Lydia Mpanga, Subira, many of you know her. Welcome. Our next speaker definitely will be a representative from the Bank of Uganda. She will speak to us.
Thank you very much, DG. I also have a DG back home, but mine is the Deputy Governor. Chief guest, Her Royal Highness, the Queen of Buganda, Nnabagereka Sylvia Agenda. Ladies and gentlemen, allow me to stand on the protocol that has already been recognized. And good afternoon. My name is Susan Kanyemibwa. I'm the Bank Secretary, Bank of Uganda. I bring you warm greetings from the Governor, Dr. Michael Tingego, who, due to other pressing central banking commitments, is unable to join you today. However, he sends his best wishes for a fruitful and inspiring conference, and I'm very honored to deliver his remarks on his behalf. It is a profound privilege to be part of this gathering, one that speaks to the very heart of our nation's future, the health, dignity, and well-being of Uganda's mothers and children. The theme of this year's conference, Strengthening Multisectoral Collaboration and Mutual Accountability for Safe Motherhood, reminds us that safe motherhood is not just a health issue. It is a human development issue. It affects our economy, productivity, and intergenerational well-being of our people. Allow me to commend the Ministry of Health and all the partners for bringing together such a diverse group of health professionals, educators, policymakers, civil society, and development partners, each playing a vital role in safeguarding life and nurturing hope. For decades, Uganda, like many other developing countries, has benefited immensely from donor support in sectors such as health, education, and governance. These contributions have saved lives, built systems, and strengthened our national capacities. However, the global financing landscape is changing. Donor priorities are evolving, and external support is becoming less predictable. This moment calls for a bold transition from dependence to self-reliance, anchored in sustainable domestic financing that reflects our national values and priorities. Domestic financing is not simply about finding new sources of money. It is about taking ownership of our development agenda. It is about ensuring that essential services like maternal and child health care continue uninterrupted, even when donor flows are fluctuating. This points to the heart of sustainable development, which is put in simple terms as development that meets the needs of the present without compromising the ability of future generations to meet their own needs. Now, at Bank of Uganda, we recognize that sustainable development thrives on strong, stable, and inclusive financial system. As the nation's financial steward, we play a key leadership role in fostering economic stability, prudent resource management, and sustainable health financing. By ensuring financial stability, by ensuring price stability, promoting financial discipline, and strengthening the financial sector, Bank of Uganda helps create an environment where government and partners can plan, invest, and deliver essential health services with confidence. At the bank, we also nurture an environment where financial inclusion is deepened, ensuring that women, especially in rural communities, can access and control financial resources to support their families and livelihood. This is how financial leadership and economic stewardship directly contributes to advancing safe motherhood and maternal health outcomes across the country. Now back home at the central bank, beyond our core mandate of ensuring price stability and a sound financial system, which I'm proud to say that we have done very well, Bank of Uganda believes that economic progress and human being can go hand in hand. Through the bank's corporate social responsibility initiative, I also stand here on behalf as the head of the corporate social responsibility initiative at the central bank. And our theme for the corporate social responsibility is maternal and child health care for a healthy society. And I think it resonates very well with the theme of today. Bank of Uganda has so far invested in healthcare infrastructure development and donated medical equipment in 13 health centers across the country. And we are still going strong. These 13 health centers include Wizwera Health Center 4 in Mbarara District, Ayivuni Health Center 3 in Arua District, Nakaloke Health Center 3 in Mbale, Omel Health Center 2 in Gulu, which has since transformed into and upgraded to a Health Center 3, Budondo Health Center 4 in Jinja District, Chanamkaka Health Center in Masaka District, Rutete Health Center 3 in Fort Portal District, which has now been upgraded to Health Center 4, Hamurwa Health Center 4 in Rwanda District, Rubaya Health Center 4 in Kabale District, Robulunga Health Center 3 in Mitoma District, Magoro Health Center 3 in Katakwi District, Tigorobia Health Center 4 in Hoima District, and more recently, Yago Health Center 3 in Lira City. At this juncture, allow me to introduce a colleague that I work with, Sarah Nwaka. She's a lawyer in the central bank. However, she's the one in charge of the projects, so she will move around, and she has worked very closely with the Ministry of Health at the expense of being called a doctor. The bank has also been in funding other several projects in support of maternal and child health care. We've supported organizations like Rotary clubs and other organizations that have projects that resonate with our theme. These interventions reflect our belief at the bank that investing in the health of mothers and children is an investment in Uganda's human capital, and therefore Uganda's future. To sustain the gains, but before I get to the gains, in addition to the health centers that we have supported, and we are still supporting this financial year, the Bank of Uganda is taking up yet again other 3 health centers, and with the support and recommendation of Ministry of Health, we are taking up a health center in Kasese District. We are also going to support a health center in Kitgum, and we are also going to support a health center in Moroto District. We are trying to traverse the entire country and see where we can help. And not only do we do construction, but of maternity health wards, but we also support in procurement of equipment. And this equipment is not determined by us, the central bank. It is determined by the districts and the health center. So they give us a list of the needs that they require, and then we approach the medical stores and we procure that equipment. So to sustain the gains in maternal and child health, we must all be committed.
Act on evidence to prevent avoidable deaths and early pregnancies. These achievements are a result of a strong partnership and collaboration between government, development partners, civil society, and communities, anchored in the RMNCH Sharpened Plan 3, the Adolescent Health Costed Implementation Plan, and the Family Planning Costed Implementation Plan 2. Your Royal Highness, distinguished guests, despite this progress, we are reminded that safe motherhood is still not a reality for all. Teenage pregnancy continues to be one of Uganda's biggest public health and development challenges. For more than a decade, the rate of teenage pregnancy has remained stubbornly high at 25%. Compounding this issue, both last year's and this year's maternal and perinatal death surveillance and response reports reveal that 1 in 10 institutional maternal deaths recorded were in the age group of 19 years and under. This represents not only an unfinished agenda, but also a development deficit, because every early pregnancy is a lost opportunity for education, health, and empowerment, and the country's overall development. Uganda's persistently high teenage pregnancy rates poses a significant threat to newborn survival. Pregnant adolescents are not only at increased risk of maternal complications and death, but their newborns face elevated risks of prematurity, low birth weight, and neonatal mortality, contributing to the country's newborn mortality rate of 22 per 1,000 live births. Addressing teenage pregnancy, therefore, is not merely a reproductive health priority, it is a strategic lever for improving newborn outcomes and accelerating Uganda's progress towards the Sustainable Development Goals. We cannot achieve safe motherhood without keeping girls in school, providing sexuality education, and ensuring that adolescents and youth have access to accurate information, contraceptives, and HIV prevention services that meets their unique needs. The modern contraceptive prevalence rate has risen to 33% among all women, yet the unmet need for family planning remains high at 20%, especially among adolescents. Every additional point gained in contraceptive use prevents thousands of unintended pregnancies and maternal deaths, like Dr. Mugahi also highlighted earlier. At the same time, HIV prevention must remain central to our efforts. Uganda has achieved remarkable progress in reducing mother-to-child transmission from 18% a decade ago to below 7%, but adolescent girls and young women still account for the majority of new infections. A truly safe motherhood agenda must therefore integrate sexual and reproductive health and rights, HIV prevention, and gender equality as one. Your Royal Highness, distinguished guests, the health development partners fully support the government's leadership and efforts to transition from fragmented plans to joint and pooled impact, to translate national strategies into measurable and equitable results. Through frameworks such as the Health Sector Development Plan, the Ministry of Health Strategic Plan, and the RMNCH Sharpened Plan 3, we are aligning our support for integration, efficiency, and sustainability. We are investing in digital innovations, community health systems, and midwifery leadership, the backbone of respectful, quality maternity care. We also commend the growing role of the private sector, from pharmacies and faith-based facilities to innovators and insurers, in complementing public systems, expanding access, and strengthening Uganda's health financing landscape. These collective efforts underscore the significant return on investment in maternal health, where $1 invested returns up to $11.9 in economic gains. As health development partners, we stand ready to accompany and support the Ministry of Health and all stakeholders in advancing a mutual accountability compact, one that measures not only resources spent, but lives saved, systems strengthened, and inequalities reduced under the one plan, one budget principle. This compact requires a multisectoral approach and interministerial coordination that includes mutual accountability towards the Office of the Prime Minister, the Ministry of Finance, Ministry of Education, local government, public service, Ministry of Gender, among others. Let us continue to be guided and informed through evidence-based approaches in designing high-impact interventions, including use of evidence from MPDSR, teenage pregnancy scorecards, and family planning dashboards to drive the needed collective action. Let us hold ourselves, government, partners, civil society, private sector, and communities mutually accountable for ensuring that no woman dies while giving life and no girl becomes a mother prematurely. As I conclude, now more than ever, with one death far too many, the insufficient progress made in saving mothers' lives and preventing unnecessary deaths should serve as a clarion call for urgent collective action by all of us. To the midwives, nurses, doctors, teachers, and community health workers represented here, you are the heartbeat of safe motherhood and our indispensable first line of defense in reducing maternal morbidity and mortality. To our political and cultural leaders, your continued leadership and voice are vital in turning evidence into action and leading to positive behavioral change. To the private sector and civil society, your innovations, investments, and reach are helping extend services up to the last mile. To our communities and parents, thank you for nurturing the change we all wish to see. You are not alone. And of course, to our development partners, a big thank you for the sustained support and commitment despite all the challenges. On behalf of all health development partners, I reaffirm our shared commitment to stronger systems, sustained financing, empowered communities, and the realization of every woman and girl's right to health, safety, and dignity. Thank you.
Thank you, Daniel. Without wasting time, I will invite the WHO representative, Kira Koch, who represented the World Health Organization representative, to make her speech.
Good afternoon. Good afternoon. That sounds better. Your Royal Highness, the Queen of Buganda Kingdom, the Under-Secretary of the Ministry of Health, Your Excellency, the Ambassador of Denmark to Uganda, the Director of Development, British High Commission, the Bank Secretary, Bank of Uganda, the Director, the Chairperson and Vice Deputy Chairperson of the Health Service Commission, the Director General of Health Services, representatives from government ministries, departments, agencies, health development and implementing partners, district leaders, health implementers, civil society and private sector representatives, health professionals. Ladies and gentlemen, good afternoon. First of all, let me send warm greetings from Dr. Kasonde Mwinger, the WHO representative to Uganda, who is unable to attend today, and I will be delivering her remarks. It is really an honor and a privilege for me. It is my first National Safe Motherhood Conference, and I'm looking forward to many more of these conferences. And to join you today here, the 5th National Motherhood Conference, it is really a vital platform for all of us to be united. Policymakers, practitioners, academics, communities, around a shared vision that no woman should die while giving life and no newborn should succumb to preventable causes. Uganda's impressive reduction in maternal mortality from 336 per 100,000 live births in 2016 to 189 per 1,000 in 2022 is a powerful testament to what is possible when leadership, partnership, and evidence-based actions are coming together. This progress contributed significantly as well to the 10% global improvement in maternal mortality during the same period, from 220 to 197 per 1,000 live births. On behalf of the World Health Organization, I would really like to congratulate the government of Uganda, the Ministry of Health, and all national and international partners whose unwavering commitment has made this achievement possible. Yet, even as we celebrate, we must remember every maternal or newborn death is a preventable strategy. Sustaining the momentum requires not only the health system to come together, but a multisectoral collaboration. Safe motherhood is not the responsibility of the health sector alone. It is shaped by education, by nutrition, by gender equality, by transport, by financing, and community engagement. Each sector holds a piece of the solution, and our collective accountability will determine the future of maternal and newborn survival in Uganda. And this is precisely the reason why this year's theme, strengthening multisectoral collaboration and mutual accountability for safe motherhood, is so timely and profound. To truly advance safe motherhood, we must move beyond silos and build systems of shared responsibility guided by data, equity, and most importantly, the voices of the women themselves. Mutual accountability means aligning our efforts around a common results framework, ensuring that commitments translate into measurable impact and that every mother, regardless of their location, can access quality, respectful, and life-saving care. WHO continues to emphasize that safe motherhood requires both a whole of government and a whole of society approach. And in order to support this, WHO has provided several guiding frameworks, including the health and health policies, integrating health across all areas of policy making, the Afro multisectoral strategy for health and well-being, urging governments to mainstream health impact assessment and build accountability strengthening, and certainly the Every Woman, Every Child strategy, promoting inclusive country-led platforms that align financing, technical support, and accountability. But how do we translate these strategies into measurable outcomes? And let me just highlight one concrete example. Over the past 5 years, WHO has been working hand in hand with the Ministry of Health and Quaker to implement a health system strengthening project in the Busoga region. This initiative focused on improving referral systems, upgrading 28 health facilities, providing equipment, building health workforce capacities, and strengthening district leadership and governance. While detailed results can be heard later during the session, and obviously I'm encouraging all to attend, allow me just to highlight 3 key achievements in the spirit of multisectoral collaboration. 1, health and education sector partnered hand in hand in order to improve access to sexual and reproductive health information in schools, helping prevent teenage pregnancies and reduce school dropout. 2, in collaboration with the water and environmental sector, water supply system and health facilities were enhanced, boosting infection prevention and control and overall quality of care. And lastly, working with local government, we strengthened health governance and data management, promoting local ownership and integration into routine health systems operation. This project has really shown the transformative impact of district-level leadership and cross-sectoral partnership in improving reproductive, maternal, child, and adolescent health outcomes. Ladies and gentlemen, esteemed delegates, WHO remains a steadfast partner to the government of Uganda and all stakeholders, providing technical assistance grounded in evidence and global best practices to advance our collective reproductive, maternal, child and adolescent health agenda. Our collaboration will continue to focus on strengthening not only access, but also the quality of care through the WHO Quality of Care Framework, enhancing emergency obstetric and newborn care capacity, supporting national policies, data systems, and performance assessment, as we have heard earlier by Dr. Mugahi, including the maternal and perinatal death surveillance and response system. And lastly, promoting innovation and community-based solutions to ensure no mother or newborn is left behind. At global, regional, and national level, WHO will continue to advocate for investment in primary health care to achieve the novel goal of universal health coverage, the key foundation for sustainable motherhood. As we open this very important conference, I invite all of us to use this platform not only to reflect, but also to recommit to action, accountability, and collaboration. Let us ensure that our discussion translates into concrete, coordinated steps that bring Uganda closer to a future where safe motherhood is guaranteed for every woman, everywhere, every time. Distinguished delegates, Uganda's success story gives us hope, but standing and sustaining and accelerating progress required continued leadership, innovation, and solidarity. WHO remains committed to walking this journey with all of you, because safe motherhood is not just a health goal, it is a human right, a moral duty, and a cornerstone for sustainable development. Thank you very much.
Let's appreciate WHO and the UN agency. As all of you recall, I've not been attempting to summarize because all of them are summaries. So I want now to invite the Development Director from the British High Commission, Mr. Philip Smith, who will speak to us. Please welcome. Put your hand.
Thank you, DG. Your Royal Highness, Excellencies, Permanent Undersecretary, Ministry of Health, senior officials from the Ministry of Health, let me, in the interest of time, stand on protocols already observed. Distinguished guests, good afternoon. Let me start, following Dr. Richard's very informative and enthusiastic presentation, let me begin, Permanent Secretary, by commending your team at the Ministry of Health and the health professionals across Uganda for your tireless efforts to save the lives of mothers and children every single day. Uganda's progress in reducing maternal mortality is a powerful testament to your dedication. The gains are even more remarkable when we consider the strides made in reducing HIV/AIDS-related deaths and expanding childhood immunization. Ladies and gentlemen, 2025 has been a turning point for global development. The development landscape has been shifting. External financing for health is declining, and the focus is rightly moving towards sustainable, locally led solutions. And I want to again applaud the government of Uganda for stepping up to fill the gaps left by reduced external financing. The recent increase in health sector budget allocations means that Uganda now dedicates a higher share of its national budget to health than most EAC member states, a clear signal of commitment to self-sustainability. Beyond resource mobilization, the government has championed service integration to improve efficiency and patient experience. The successful transition of HIV programs and the effective response to the Ebola outbreak earlier this year offer valuable models for broader health system improvements. Your Royal Highness, the UK is proud to be a long-standing partner in Uganda's health journey, but alongside other bilateral partners in health, our role is evolving. The UK government will continue to support global health platforms such as Gavi, the Global Fund, the World Bank, and the UN, and especially those that scale up life-saving technologies for mothers and newborns. However, with reductions in our global health budgets, we are recalibrating our approach. And for the UK, this means moving from being a donor to being an investor, from a focus on direct service delivery in health to health systems strengthening, from providing grants to providing technical assistance, and from large-scale international interventions to a focus on partnership and supporting locally led solutions. Let's be no doubt we remain committed to Uganda's journey towards better health outcomes, and we are moving from funding our own parallel programs to forging partnerships that empower Ugandan institutions and Ugandan health professionals to lead the way. This year, we've been working to strengthen governments at districts and health facility levels, improving technical and soft skills of health workers, including in obstetric care and family planning. And with UNFPA and the Ministry, we are working to strengthen the private sector to increase access to reproductive health services. Looking ahead, we're modernising the UK-Uganda health partnership. We want to promote deeper collaboration between Uganda and British institutions, including the UK's National Health Service, UK universities, and industry. We're very proud of these people-to-people connections in health. To date, these partnerships have delivered postgraduate medical training through the Tropical Health and Education Trust, a strong response to HIV/AIDS through decades of collaboration between the Medical Research Council, the London School of Hygiene and Tropical Medicine, UVRI here in Uganda, and Mildmay Hospital. We've improved cardiac diagnostics with the UK's Barts NHS Trust, working with the Ugandan Health Institute. And we supported kidney transplants conducted in Uganda through Manchester Royal Infirmary and Malago Hospital. And these initiatives, ladies and gentlemen, are a broad range of long-standing clinical exchanges with the National Health Service in the UK. These are investments in people, investments in knowledge, investments in innovation. They're not about aid. They're not about being a donor. They are about mutual growth, mutual and shared expertise, and a deep, long-standing partnership. They reflect our belief that linking Ugandan and UK innovation in health can deliver better health outcomes for the UK and for Uganda. Let me briefly reflect on today's agenda. The emphasis on integration, innovation, and community-led solutions is commendable. AI is changing our world and transforming healthcare globally, and the UK is keen to support Uganda's digital health revolution. The focus also on adolescent health and on teenage pregnancy is critical. Unintended pregnancies amongst adolescent girls threatens Uganda's progress in maternal health and its tenfold growth strategy writ large. And the UK is ready to partner in generating evidence of that to inform decision-making. Innovative financing, especially health insurance, as other speakers have highlighted, is essential to Uganda's health security. We welcome collaboration around the UK's experience of this and supporting Uganda to accelerate its domestic financing strategies. As the Bank Secretary has just mentioned, domestic revenue mobilisation is a national necessity. Her words, not mine, and I'd agree. And this is about domestic revenue mobilization, but it's also about accelerating domestic financing strategies. So as we begin this conference, I encourage us all to reflect on how we can deepen collaboration, close persistent equity gaps, and ensure accountability for results that truly change lives. And as I conclude, let me say that the UK remains a long-standing friend of Uganda. We continue to deepen the partnership and the enduring people-to-people relationships between our countries, not least in the health sector. Safer motherhood is everyone's responsibility, and indeed, it is our shared opportunity. Thank you very much.
A big hand clap. Slowly but surely, we are soon getting to the end of the line. Our next speaker is Dr. Henry Mwebesa, who is the chair of the Health Service Commission. He is also the Director General Emeritus. I am not trying to grow to fit into his shoes, but I'm trying to grow to his shoes. Thank you very much.
Thank you very much, DG. Our chief guest, Her Royal Highness, the Nnabagereka of Buganda. And protocol observed. I want to copy the Secretary of Bank of Uganda and the British High Commissioner representative by observing protocol. Madam, I don't want to take you through one page of protocol here, which may take me another 5 minutes. But I really want to, and I'll try to summarize. I have a 5-page speech and I'm not going to read word by word. But I'm happy to be here, to participate in this 5th Safe Motherhood Conference. And we all know that this conference always brings us together. I think this is the 5th, yes. We all meet here as stakeholders to discuss issues related to the safety and quality of our mothers and infants in this country. What is most exciting this year is the theme, strengthening multisectoral collaboration and mutual accountability. First, on multisectoral collaboration, because improving safe motherhood cannot be a role of Ministry of Health alone. It cannot be a role of government alone. All of us, like we are represented here, we are stakeholders in improving safe motherhood. Other ministries, development partners, even civil society, private sector, the community, we all play a role in this. But we are also excited about the issue of mutual accountability. As you are here, you ask yourself, what have I contributed to safe motherhood this year? I'm an IP, yes, but what have you done? We are Health Service Commission, yes. Have you recruited the midwives they want? You are a District Service Commission. Have you recruited the midwives they want without charging them? So those are issues that we also ask ourselves, mutual accountability. Guest of honor, Mugai made a very, very good presentation where he highlighted all the achievements, the reduction in maternal mortality, the improved safe deliveries in hospitals, reduction in infant mortality, and all the figures he presented there. And I really not bore you going through them. I have a whole page here, but I not go through them because you have them in your reports. But 2 things I want to request from that. 3. 1, Madam, there was the issue of teenage pregnancy. It came up strong. And you have been doing a lot of work in that area. We request that you continue to attach special interest in that problem. But not only you, mobilize your other colleagues, the queens in the different regions. Let them also take special interest, and we address that problem. 24% of teenage pregnancy is really a big problem. The other day, we were using excuses of COVID, that children were getting pregnant in COVID, but COVID ended. Why are they still getting pregnant? It's a problem we must address. 2, Charlotte, you are carrying a rubengo, and that rubengo is not small. The issue of bleeding, our mothers bleeding after delivery. We really thank you for coming in. Please join us and we address that problem. You saw in the presentation, they said 44% of our mothers who die. It is the cause. 44% is not small, really. 44% is a big problem. So if we address that problem, then we'd have cut off a lot of deaths to our mothers. So we request you, join us, work with us, and we address that problem. Even if it means mobilizing general, and say, General, I've been given assignment, you know what I mean. You know the general I mean. I've been given this rubengo, can we carry it together? He can even mobilize for us blood from UPDF, he can come in different ways. But tell him it is a big problem, and since we are talking multisectoral collaboration, we are all working together to address this problem. Number 3, you know, in Uganda, we are very good at shouting horse for the wrong things. What we have not done, the borders, the potholes, but we do not shout horse on the good things that this country has done, the government has done, and we ourselves have done. Because all these good things that Mugai presented here, they will end up here. You are preaching to the converted, everybody here knows them. But does the population outside there know the great work that has gone in to address this challenge? All these improvements. The delivery in health center 3s, those health center 3s didn't sprout out like mushrooms. Somebody built them. The health center 4s, the cesarean sections at health center 4s, somebody did them. The sector did them, government did them. So we should also try to tell the world of the good things we do in this country, and so that everybody knows that there is good work going on somewhere. I come from the Health Service Commission, so I would want to conclude by talking about something to do with health workforce. May I at this juncture request my colleagues from the Health Service Commission to stand up for recognition, the Deputy Chair and members, and may I also request our elder and the person who groomed us, Professor Pius Okong, to stand up for recognition, because we are following in his footsteps. Thank you very much. So I want to mention a few things to do with health workforce, especially in safe motherhood. When they were doing the tallying here, it came out clear that we need more midwives, we need doctors, we need health workers. That is very true. If we are going to improve safe motherhood, we need more midwives. So Health Service Commission, we need to recruit midwives. District Service Commission, we need to recruit midwives. We need to recruit doctors, and we need to recruit anesthetists. Because really for me, a health center 4, which is not doing operations, is not a health center 4. A health center 4 must do cesarean section, and therefore you must have a doctor there, and we have doctors. We have doctors there and do cesarean section on our mothers who have not been able to deliver normally. In fact, a health center 4 to me, we did it last year. Remember, we went in one district, we found a health center 4 with 2 doctors with receiving money, but they were not doing cesarean section. So we directed the good thing, we were with the PS. PS said, I've given you 2 months. If you do not start doing cesarean section, I'm going to cut your budget and take you back to a health center 3. Because a health center 4 not doing its cesarean section is a health center 3 to me. So let's actually analyze all those health center 4s who have doctors and anesthetists and are not doing cesarean section. And what is annoying, they get the same amount of money. Can you imagine a health center 4 like Wakiso doing about 120 mothers cesarean sections per month? Yes, the same amount of money with a health center 4, which is doing 0 cesarean section. What is this? What leadership is this? There's no way you can, I get the same amount of money, I do 120 cesarean sections, you do 0 cesarean section, and you get the same amount of money? Surely. I think that's unacceptable. Because we have seen health center force in Tusi, Sembabule, Chanamukaka, Pumi, doing very good number of cesarean sections. So you who are not doing cesarean sections, why are you getting that money? You two doctors there, what are you doing there? So DG, those are areas really we must address seriously. Then the next is adherence to schedules. We do duty rosters. If a mother has struggled and come all the way from down, including those in Kabale who come on visit, called Ngozi, and he reaches a health center and finds a staff not there, and yet the staff is on duty roster, showing that I'm supposed to be on duty, and I'm not on duty, and they lose that mother. Why should we tolerate that kind of behavior? So we must also emphasize those areas that doctors, staff, nurses must adhere to their duty rosters. We have an electronic medical records. Now, if I go for supervision, and you DHOs who are here, I go to Chanamukaka Health Center, for example, or even, let's say, Mpigi Health Center, and then find out, has Mwewesa been working this month? 22 days. Maybe it did 20 days. You can excuse me for the 2 days. But in places, you find somebody has worked 9 days out of 22 days, 8 days out of 22 days, and we are supervisors. Surely, that should not be accepted, because that's how we lose our mothers. Next, it's not a question that Mwewesa came, because we also know people come and clock in, and then go to their clinics and come and clock out in the evening. We should go further to find out when Mwewesa came in October, what did he do? You are a doctor, how many scissors did you do? How many ward rounds did you do? How many investigations did you do? Is that too much to ask? No. Even with this increased salary, and you are begging people. The other day we advertised for 16 jobs for doctors. We got 1,400. So why are you begging a doctor who doesn't want to work? We have so many doctors on the street. We have so many midwives. So let's really take it very serious. I have one or two more comments. The issue of the community health workers. And I am happy Kabanda is here. If we are going to improve services, we really need to start from the community level. And I'm happy about the program, about the community health extension workers. Those cues will help us to tell mothers, go for antenatal care, go for family planning. You have been pregnant, have been monitoring, you go and deliver in a health facility. So I beg the Ministry of Health to expand that program, but also donors to support that program of making sure that every district has got CHOOS. This is a sensitive issue, but I have to talk about it. Because it was presented by the IGG, so I'm not creating it. That we know that sometimes at the district service commissions have been charging staff for appointments. Now you recruit this nurse and she pays you 80 million to get that job. What do you expect her to do once she comes in service? The first thing is to recover my 80 million, because they could have borrowed it, they could have sold something by father's cows and the like. So this, now she'll, you know what she'll do? She'll start charging our patients, our mothers. Now most of our mothers don't have that money. So you'll have a mother comes there, is not attended to because she can't afford to pay. And therefore you have a mother rupture, you have a mother die in our facility. Actually what they do, if you don't have the money, then they push you up. You go to the hospital, go to Emmanuel there in Kawempe, they push you out, further up. But by the time she reaches Kawempe, she's ruptured and she's dead. So let's, government, we must find a way of solving this problem. Even if it means Even if I know the DGs are about just me, let me stop there. But we need to address that problem, because now if I recover my 80 million, when I start the process of recovering my 80 million, by the time I recover it, I have already developed a culture of extortion. I will not stop at 80 million, then I will continue charging mothers. So let's really address that. Finally, Dr. Pius Okong, before he left, he had started the process of developing standing orders for health workers. We are finalizing those standing orders. And those standing orders will outline how doctors must behave. Because, we are using standing orders, the general standing orders for public servants. If I call a vet that my cow is sick and he doesn't come, the worst that will happen, my cow will die and I will eat it. I will sell it at least, and we eat the money. Of course, I've lost my cow. But now, translate that to what? A mother. If the doctor doesn't come, a mother dies. So the rules governing a vet, the rules governing, let's say, an agricultural officer, cannot be the same as governing a doctor. So we are getting in place rules that health workers must comply professional ethics. In the past, you would take, let's say, a year to discipline a health worker. The new guidelines, within 3 months, you'll have either been dismissed or you'll have changed your way of work. So, otherwise, I really want to thank the health workers for the great work that you do. I'm not sounding as if we don't do well, but I just wanted to caution our colleagues who do not adhere to the profession.
Academia, the community, and all other stakeholders. As a ministry, and I know my honorable minister, if she was the one standing up, she would not live without emphasizing, strengthening structures at a community level. That's why I think most people have talked about community health extension workers, VHTs, and the digitalization process that is ongoing to ensure that we are able to collect data from communities, the ICHIS. Dr. Kabanda, who is a subject of your kingdom, is at the forefront of driving this agenda of ensuring that we strengthen our community systems to ensure that a lot of interventions are done at that level to be able to prevent, some of the issues that move upwards, cause challenges in the clinical care. To illustrate the above, the Ministry of Works, the Ministry of Works, for instance, is involved in construction of roads to ensure that our ambulances are able to move very fast. You heard about the delays. Delay 1 in a community. So if Mr. Kabanda intervenes and that delay is sorted at the community level, there is the delay 2. The delay 2 is transmission to the health facility, that movement. Once the roads are not worked on, then it becomes very difficult. There will be delays to transmit our patients or mothers to health facilities. So we acknowledge that, for instance, because of this collaboration, that different stakeholders have different roles, and we are noting that the Ministry of Works should work on the roads to ensure that our ambulances are able to refer our mothers quickly. Ministry of Education has the role to provide literacy for both boys and girls to ensure that the girls are kept in school. Ministry of Gender to empower women in life skilling and economic empowerment. Agriculture to ensure that families have adequate food and women and their children are not anemic and malnourished. The Ministry of Finance to provide resources for investment in human resources for health and health infrastructure. The private sector to provide collective investment for safe motherhood. Civil society to demand accountability. So all of us, and I'm just mentioning a few, there are many other players with the different roles and responsibilities that need to come in to ensure that this whole collaboration delivers the desired outcome. As we converge for 3 days to share knowledge and make commitments for our mothers and newborns who are not in this hall, the Ministry of Health commits to provide leadership, policy, direction, and guidance to ensure mothers and their babies survive. We are here to plan and strategize for people who may, at least one of the stakeholders is not here. Mothers are here, but the babies are not here.
So let's as we do that, let's be cognizant that we must plan well, and at the end of the day ensure that the mothers, the babies survive and they are healthy. We pledge as Ministry of Health to coordinate partners and all the other stakeholders better through a one plan, one budget, and one monitoring and evaluation framework. We pledge to spearhead the delivery of integrated and inclusive services for maternal, newborn, and child health services, and enforce mutual accountability to ensure that no one is left behind. I wish to sincerely acknowledge all our partners for your support in implementing maternal, newborn, and child health programs. Your contributions have been instrumental in the achievements we celebrate today. May I conclude by calling each one of us to join the Safe Motherhood movement and harness each other's effort to end preventable maternal and newborn deaths in Uganda by 2030. For God and my country. Thank you so much. So 2 assignments have been delivered. So the third one, and the most important and critical, is the one I'm now embarking on. And you will allow me, Your Royal Highness and all members, that I give a brief citation on our chief guest, so that everyone in the room, those who may not know, at least you get to understand the contribution that has come through, because of the effort of our chief guest. Her Royal Highness Sylvia Nnabagereka, the Nnabagereka of Buganda, is an icon who is highly regarded in society for her transformational leadership and for being a champion of empowering girls and boys, including those with disabilities, the youth, and the women. Through the Nnabagereka Development Foundation, which Her Royal Highness founded in 2000, she has been able to do charitable work for children, the youth, and the women in education, health care, community development, and support initiatives that advance good practices for sustainable green development. Her Royal Highness also founded the Nnabagereka Women's Fund in 2022, inspired by concerted cries for assistance from individuals and communities profoundly affected by the repercussions of the COVID-19 pandemic. She was moved by numerous requests for support to address diverse challenges. These requests comprised many urgent basic needs, including health care, wellness, in terms of mental health, then food security, education, and livelihoods. Her Royal Highness is renowned for advancing the integration of Ubuntu Bulamu in all foundation programs and projects, and that empower individuals to reclaim their cultural heritage and use cultural values in social development. She has also worked tirelessly to support the sensitization and mobilization of people on early childhood care and development, vocational training and employment targeting the youth, empowerment of women, particularly on sexual reproductive health, safe motherhood, child spacing, and gender rights. She works closely with line ministries like our ministry, Ministry of Health, the United Nations agencies such as UNAIDS, UNICEF, and WHO in Uganda, as well as civil society organizations on community health-related interventions. Her Royal Highness was a goodwill ambassador of the United Nations Population Fund in Uganda, a torchbearer for Millennium Development Goals, and an ambassador for Mama Club, an organization for mothers living with HIV/AIDS, and a champion for the campaign to end pediatric HIV/AIDS in Uganda. She's also a patron of Hospice Africa Uganda, Child Fund International Uganda, Female Sponsorship Foundation, Makerere University Uganda, Special Olympics Uganda, and the Program for Accessible Health, Communication and Education, and Conservation through Public Health, and the Buganda Kingdom Tourism Board. The Kabaka Foundation also that was recognized internationally because of its work in blood mobilization, is also part of the organization where she's a member. We want to appreciate and thank you, Your Royal Highness, for these very, very important interventions. May I now take this singular honor and opportunity, which doesn't come rarely, ordinarily, it is a rare opportunity. May you join me to invite, kindly stand up and receive our chief guest, deliver our remarks. You are most welcome, Your Royal Highness.
Please take your seat. Thank you very much. Religious leaders and all members of the clergy, our culture leaders, the representative of the Minister of Health, the chair and members of the Health Service Commission, Your Excellencies, the ambassadors, the chair, health development partners, and all partners, cultural and institutional leaders, health workers, all distinguished guests, ladies and gentlemen. Good afternoon. It is a pleasure to be part of this conference, which is dedicated to advancing safe motherhood and the health of our mothers and newborns. I wish to commend the Ministry of Health for convening this very important gathering and for its commitment to reducing maternal and neonatal mortality. Now, as a former Goodwill Ambassador for the United Nations Fund for Population Activities, I had the privilege of advocating for safe motherhood and maternal health in Uganda and beyond for over 15 years, from 2000. During that period, I led campaigns that championed adolescent sexual and reproductive health, maternal health, and gender rights, efforts that I continue to believe are essential in our journey to improve health outcomes for women and children across our nation. As you've heard from our speakers this afternoon and morning, Uganda has made significant progress. The maternal mortality rate has decreased in recent years. Newborn survival has improved, and more families are accessing health services than ever before. These achievements reflect the collective efforts of our government, partners, including cultural institutions and communities. However, the statistics remain deeply troubling because each year we continue to lose thousands of mothers and babies to preventable causes such as postpartum hemorrhage, complications from teenage pregnancy, prematurity, and delays in emergency care. The situation remains dire, especially considering Uganda's much larger population today. Many of the challenges affecting maternal health today are the same as those faced 25 years ago when I first became the Goodwill Ambassador of UNFPA. I have also observed that many of the strategies and tools used to address these issues are still largely the same. So I believe that it is time to reevaluate our approaches, because this critical situation calls for innovative, fresh strategies to effectively overcome the persistent challenges. As I present the sub-theme of harnessing culture values and ethics for improved maternal and newborn health, which I have been given to address this afternoon. Now, we must focus on approaches that actively engage our predominantly young, vibrant, and sexually active population, characterized by high fertility rates. These strategies should be culturally acceptable, accessible, and resonate with our people's realities, ensuring their effectiveness in driving sustainable and meaningful change. Why do culture and ethics matter? Because while health systems and skilled personnel are vital, they alone cannot achieve safe motherhood. The choices that influence maternal health, such as when to seek care, family size, and how mothers are treated during labor, are deeply rooted in our values, our beliefs, and community practices. Our forefathers' wisdom reminds us that motherhood and childhood survival are shared community responsibilities. Safe motherhood is not merely a medical issue, it is a moral and cultural imperative. Excuse me. Today, I want to emphasize that our culture, values, and ethics are not just symbols of tradition, they are powerful living forces. When harnessed appropriately, they can substantially improve maternal and newborn health, forming the moral foundation upon which trust, respect, and collective responsibility are built. Now, here are some ways which I think these culture pillars function. Culture values are pillars of health. Values like community support, the sanctity of life, and family unity can catalyze positive health behaviors, such as utilizing antenatal care, ensuring skilled birth attendance, and early postnatal care. Number two, respect and ethics are foundations for trust. Respect for elders, respect for women, compassion, and shared responsibility rooted in our culture practices are essential for building trust between health providers and communities. When service align with these values, women are more likely to seek care and adhere to medical advice. Number three, mobilizing culture leaders and traditional practices. Now, engaging cultural, religious, and community leaders is crucial. Their influence can be harnessed to dispel myths, promote birth preparedness, and normalize the use of skilled maternal health care. Properly trained traditional birth attendants can become vital partners rather than barriers when integrated into the formal health system. Number four is ethical storytelling and community dialogue. Childhood and maternal health messages can be effectively communicated through storytelling, an integral part of our culture. Community dialogues rooted in our shared principles of care and responsibilities foster accountability and collective action. At the beginning, I mentioned about using more innovative approaches. And just to share a few, the use of innovative approaches grounded in respecting and leveraging our culture, values, and ethics can foster an environment that is respectful, inclusive, and community-driven, ultimately leading to better maternal and newborn health outcomes. Innovative strategies to address the persistent challenges include the use of digital health technologies. I know some speakers here already mentioned that. Now, deploying mobile health platforms that deliver health education and prenatal tracking in local languages and cultural contexts, making information more accessible and relatable. Let us train and empower community health workers with digital tools to provide essential services and early detection of complications. Provide telemedicine services by developing telehealth platforms that connect pregnant women with specialists, nutritionists, and mental health professionals, reducing travel burdens and ensuring timely, personalized care. Integration of traditional and modern practices. Again, as part of another approach, and that is collaborating with traditional birth attendants, training them with modern knowledge to bridge cultural practices with quality healthcare services. Again, gender and socio-economic empowerment. Let's promote women's education and economic independence, reinforcing respect, dignity, and shared responsibility. Now, here are some practical efforts by the Nnabagereka Development Foundation, working within the Buganda Kingdom framework, to demonstrate how these principles translate into action. Community mobilization, leveraging our clan system, Ebikabi Abaganda, and counties, Masaza, Gabuganda, to spread messages on antenatal care, nutrition, and family planning, children and youth engagement, using the annual Echisakate camp. It's a program that we've been running for for over 18 years, to equip boys and girls with knowledge and values to prevent early pregnancies and nurture responsible citizenship. Health communication, we've been doing that as well, utilizing platforms like Kingdom stations, CBS, radio, BBS, television, and various digital channels to ensure messages are delivered in languages and idioms familiar to families and communities. Now, building on these efforts, we must confront harmful practices that still exist in some areas of our country, such as child marriage and early pregnancies. These are things that we've been fighting for so many years, but I think a lot of progress has been made, but I think we need it to be at 0%, because we still have child marriages that exist in our country in this day and age, and also obviously the speakers before me talked about early pregnancies. Now, these deprive girls of their future and challenge beliefs and customs that prevent mothers and newborns from accessing care. Now, maternal health is a shared responsibility that transcends sectors. It calls for partnerships among governments, health workers, community organizations, religious institutions, and families. Together, we must uphold the virtues of compassion, respect, and duty in support of women. Now, as culture leaders, our commitments are clear. We should strengthen partnerships with health systems by complementing government and health workers at every level. We should support our girls by protecting girls from early pregnancies, early marriages, and domestic abuse. We should guide our boys. We should mobilize men and fathers to become advocates of safe motherhood and protectors of women and girls. As I conclude, distinguished guests, I'd like to call on you that we renew our vow to harness the enduring strength of our culture, values, and ethics. These are not just relics of the past, they are living, dynamic forces that can strengthen our efforts to save lives. On behalf of the Kingdom of Buganda, I pledge our continued partnership with the government, development partners, and communities in this noble cause. May our collective efforts lead us toward a future where no woman dies giving life and no child is lost to preventable causes. As it is said in the book of Proverbs, a healthy mother is the foundation of a healthy nation. Let us work together with integrity, respect, and shared purpose to ensure safe motherhood for all women and a healthy future for all our children. I thank you all for listening, and may God bless you.
Thank you very much, our chief guest. And I request the team to bring the document that is going to be launched, that is symbolic of all the other documents. The team, please make the document available. And after that, we'll have a few photos with our chief guest, Her Royal Highness. And I will be inviting a few after the symbolic signature. And with me, I have a copy of her autobiography, Life, Passion, and Duty, the Nnabagereka Queen Sylvia Nagenda Uswata. It is available only at 100,000, and the proceeds go to the foundation. So copies are available. Everything about her work is contained in this book, her autobiography. So feel free to grab yourself a copy. Yes, so we are going to have a symbolic launch of all our guidelines by our chief guest. I hope there will be someone to hold it, to firm it up. Yes, so our chief guest, we kindly request you to that is symbolic of all the guidelines that we have, and thank you very much. The representative of the minister maybe will also append a signature, and also the PPH ambassador, Ms. Charlotte Kainerugaba, you need to really come and append your signature. Then we'll have a group photo thereafter with our chief guest. Okay, quickly. Then I request our VIPs to, in the meantime, step forward for a picture with our chief guest. Mainly this first table right in front where the Director General, the Chairperson, Health Service Commission, the Deputy, Your Excellencies, the ambassadors. Thank you. Thank you. Let our chief guest please be guided for this picture. The team, our chief guest. The religious leader, please represent the others. Thank you. Allow me invite the next picture, the entourage of the chief guest to join, and also the neighboring table to the chief guest, Dr. Byaruhanga to represent the health, Byarugaba to represent the health workers, please. Yes, we can. Okay. Okay, also the Ministry of Health commissioners, including Wechitibwa Kabanda Richard, who is a member of the Committee on Ethics. Thank you. Then the organizing committee. If I don't invite you, you will not be happy. The organizing committee that have invited more than 1,000 participants. Let the committee members make their way very fast. That is our last picture. And also the NSMC coordinators come along. This is our last photo. The organizing committee, please hurry.
And as we take this very wonderful photo, we did a symbolic signing, but we will request Director General, the Chair Health Service Commission, colleagues from Madam Charlotte, colleagues from the different embassies, that we could append signatures to the rest, because the previous one was basically symbolic. Thank you very much.
We can take our seats. The signing will happen after our chief guest has left the room. And I request that we have the anthems in reverse order. Thank you.
Just prepare.
Immediately after the anthems, we will have lunch. Thank you. Dr. Bagala will guide us on how we'll have lunch. The DJ, the anthems in reverse order. Thank you. Let's all rise.
Yes, sir. Thanks very much indeed, ladies and gentlemen. At this juncture, we shall be breaking off for lunch. But I really want to request the Chair Health Service Commission to lead that team to come and do the endorsement of this other document following the symbolic sign-off. I want to request part of our ushering team, Divine, let's support the table for the chief guests so that we guide them on the lunch. Please just try to guide the Chair Health Service Commission, the DG, so that we can do some signing and the Honorable Minister. Yes, so in terms of lunch, we will have a team of ushers lead the 2 tables on my right and 2 tables on my left. And please make sure you have, the rest of the team, make sure you have your tag, because it's very important for a number of issues. We're going to have our lunch from the restaurant on the first floor. And you will receive a coupon from there, but make sure you have either your tag or you have your e-tag or you have your passport on your phone. Any of those would enable you have the language. Yes, and at this point, I think we appreciate that some interactions are happening with the chief guest, which is quite very important. Commissioner Mugahi, we may need to have some endorsement of these documents, please. Please kindly support in that process. Let's get the colleagues from the British Embassy, the Netherlands Embassy, WHO, UNFPA, Dr. Nathan, Professor Biamutisha, Health Service Commission, we can sign off. Madame Charlotte, we can sign off these other documents following this symbolic signing. Thank you very much. Thank you very much indeed. The commissioners, please, the commissioners, Professor Pius, thank you very much indeed. Thank you. Commissioner Kabanda, thank you very much indeed.
Today we present to you a skit on preeclampsia, showing us what happens in the community before we end up losing these mothers when they reach the hospital. Thank you so much.
Mwami wakedde. Nakedde mukyala nakulesa mu buliri nga okyebakiriza nnyo. Omanyi wasize otya mwami? Bulungi mukyala wasize otya eyo? Sizaawo bwe ntyo mwami. Njagala kuntabulira na kacaayi, era osooka ontabulire kacaayi ngende nkole ku mirimu. Mwami kacaayi leero n'akafuna? Ng'ate lwaki? Siri bulungi, sawulira bulungi mwami. Ate kiki mukyala, obadde ki? Mwami nasuza omutwe gumbo. Omutwe nga gukuluma, mukyala leero otandise ebintu byebyo. Ebigere birabe. Omanyi naye ndi mu space zange, naluzinze omulimu naye leero otandise ku makya, otandika bintu byebyo. Kati ndoopera ani? Ate nze mmanyi gw'olina okuloopera. Mwami nanno okimanyi bukyanga afuna lubuto sigengako mu ddwaliro basawo kunkibula babiyita batya antinento. Sibimanyi ebyo by'abakyala naawe ate nze sirina ssente zakuwa ayagala nkolera eki mukyala naawe. Nze njagala kyakagenda mu ddwaliro. Ate nina ssente bangobye ku mulimu mukyala. Omwezi olubuto lwa myezi 7 kumpi sigendako mu ddwaliro. Gwe buli kaseera nga okompuleyininga mbu omutwe gukuluma ebigere bikuluma bizimbi mutokyalawa bulungi onfuukidde ekizibu myezi 7 bukyanga walufuna olubuto olwo. Weerowooze weerowooze mwami. Mukyalo oza sigenda kuwasa omukyalo mulala kubanga oli mukazi munaku abalala abakyala nga baguma. Njagala genda nakwekolera omanyi sirina ssente. Tokigeza naye okeera kugamba mbu ate omutwe gukuluma ate olubuto olukuluma tokyalaba bulungi mbu amagulu gakuzimbi abakyala banno nga bagumako. Nanno mwami tonkuulako wayano nno okitegedde? Ate lwaki mukyala? Wandizifunye. Wano oli mu maka gange nnyabo. Nkugambye ki wandizifunye? Nze nnyingidde kankuveeko. Gwamanyi. Kamukubira essimu. Anti twasize ne muwalawo akedde kumbuulirawo mbu omutwe guluma omusujja gumulumaaluma amaaso takyalaba bulungi amagulu gakyatambula bulungi. Kanze kuyite omukubire olabe ojje omulabirire. Nze ngenze.
Bambi kamama. Manyi
yobo wadde okyalina mwami.
Nada
Omwana agenda kutta busi. Mama tusa
kulaba.
Tulireko wano.
Osazeewo bw'ati?
Nsazeewo bw'enti.
Nyambe akono.
Onsonyiwe maama anti ebizibu byombi manyi ebitaggwa.
Otandika.
Munnange anti nabaddeyo nga nkulowooza nti nakulese toli bulungi.
Gamba walayi.
Weekugamba. Nga sinnagenda mu nnimiro. Kasooke nkebereko bw'oli. Nze nno ndi munno. Ndi munno nnyo.
Oli munnange ddala.
Ebigere wasuzza otya?
Faatu. Nasweza si bulungi nnyo.
Nabaddeyo mu nnyumba nno nga nkulowooza.
Omwami wange yakomyewo.
Nkiraba.
Naye we yagendedde leero twatabuseemu.
Ate lwaki?
Kwekumunnyonnyola ebigere amaaso okunnuma omutwe okunnuma nga tanfaako.
Saagala kunjogezaako naye omusajjawo kale yeetaaga kuntwala wa chairman. Kubanga omusajja ekigwe tukomplainingira buli kanaku naye nga talina kyakola ye nga talina ssente yandibanga alina banziwa.
The 5th National Safe Motherhood Conference awards and
I take this pleasure
happening from the 22nd to the 24th of October
the country was facing real challenges. In fact, infant mortality rates were high and mortality rates for children under 5 years old was even higher. The country also recorded depressing maternal mortality numbers. We have also already developed health facilities for thousands of safety workers. As our sole purpose is deeply rooted in the communities we serve. For over 35 years now, we have been implementing strategic plans to address the challenges. These strategies were implemented through 3 operational plans. The country-specific implementation
support for access to antenatal care and immunization. And Expo.
The National Safe Motherhood Conference is an annual scientific conference organized by the Ministry of Health and its partners. It was launched in 2021 and it has since been held annually.
Happening from the 22nd to the 24th of October 2025.
We've reduced the institutional maternal mortality by 6 points, from 90 to 83 per 100,000 institutional maternal mortality.
And who have really helped to grow the Save the Mothers program as an effective movement for strengthening community engagement.
At Speak Resort Convention Center, Munyonyo.
We have made progress in reducing maternal mortality ratio. Progress of 44% reduction in 5 years is remarkable. But we need more effort and investment to sustain our gains and also achieve new targets.
We've developed a curriculum around the Quality Newborn Maternal Health Framework,
The curriculum is to expand this around Uganda and help bring this model to anywhere and any community that wants it.
Under the theme Strengthening Multisectoral Collaboration and Mutual Accountability for Safe Motherhood.
We also need to embrace more of predictive analytics. Can we predict that this mother is likely to have a preterm birth?
So we have been working in 24 facilities, and we've seen women who are able to receive a complete risk assessment at ANC rise from about 50% and now being sustained in all these facilities.
Convened by the Ministry of Health together with its partners, don't miss this 3-day power-packed event full of great speakers, intriguing plenary sessions, scientific presentations, policy dialogues and interactive engagements, providing a space for learning, networking and collective
We are not
action.
doing enough, and I think family planning as a development issue will deliver Uganda to the middle income status.
We've also agreed that all our EMOC facilities must establish functional high-risk clinics.
Passion in this room, if translated into actual work, I want to believe we shall end unnecessary maternal death in our facilities.
The 5th National Safe Motherhood Conference Awards and Expo 2025.
About 4 years, and we work closely with the Ministry of Health and Kawempe National Referral Hospital. Today, basically, I want to tell you about our program that we are running with Kawempe National Referral Hospital, where we are doing community follow-up of preterm babies that have been discharged. We started this program in April this year, and so far we've been in position to follow up about 2,000 mothers and within the communities. But before we go to the communities to follow up these mothers, we ensure that we give support to these mothers in collaboration with Kawempe National Referral Hospital, where once a mother gives birth to a preterm baby in the NICU, we go in, provide emotional support with the nurses, these mothers, since we are experienced parents of giving birth to preterm babies. Then once the baby leaves the NICU, then it's discharged to the kangaroo unit. In the kangaroo unit, this is where we educate them what to do with their babies, on how they're supposed to take care of their babies when they go back to the community. So once these mothers are in the NICU, we educate them on infection prevention, hygiene, breastfeeding, educate them on immunization, what they are supposed to eat as parents of preterm babies so that they are in position to get breast milk. For those that don't have breast milk, we work together with the breast milk community that supports us with donated breast milk, and they bring it directly here at Kawempe National Referral Hospital. So once the mother is being discharged from the kangaroo unit, we ensure that they're trained on how to do kangaroo. So then we connect them to the volunteers or the VHTs within their community.
Hello, I'm Burunji Bridget, a volunteer from the Preterm Infant Birth Network Uganda. As a volunteer, once a mother is discharged from the hospital, I always get a notification to go and check them out. Once I get the contact, I reach out to the mother, find out where exactly they are. I reach out to them in their respective homes. When I reach out to the mother, I ensure that the baby is feeding so well, that is every after 2 hours. I ensure that hygiene is maintained, proper good hygiene is maintained. I ensure that the baby is given enough kangaroo, because we are supposed to give a baby kangaroo for up to 20 hours. And once I visit a mother in the community and I notice any danger sign, automatically the baby is always referred back to the hospital.
Good afternoon to you. My name is Dr. Mary Nyanzi. I'm a pediatrician and also the head of department pediatrics at Kawempe National Referral Hospital. I'm here to tell you about the preterm parents network. That is a community support group that is helping mothers and babies for the preterms that were previously admitted at our hospital and are discharged home. So this community support group does a lot of good things for the parents. They do support supervision, I should say, for the mothers. They have expert mothers that usually come to teach these mothers how to care for their newborns, how to look for danger signs, and when to return to hospital in case of any emergency. They also remind, which is quite important, they also remind the parents to return for their hospital appointments. And this has been evidenced by our statistics. Usually, previously when we were just starting, we used to have about 15, 20 preterms coming in for review. But of late, at any one appointment date or clinic date, we have about 60 preterms being brought back for reviews. So I think that is good. It is helping with their survival, as they'll tell you from their statistics, with the follow-up that they do. Of course, there are other things that they do beyond the supporting. They also have some materials that they give these mothers that help them in identifying danger signs, things like thermometers, and they also teach the mothers how to use them. But also supply kangaroo wraps, which the mothers need when they are doing the kangaroo mother care. So I think there is more. I may not be able to say it all, but the executive director of the association will throw more light, as you will see later on. Thank you.
So these PHTs, we developed an app with support of Dimagi. We developed an app, and this app is in position to report to us real-time data. Which mother has been seen at what time, which mother has got an issue and needs to be referred immediately back to the hospital. So once the mother is assigned to the volunteer or the VHT within their community, the VHT will receive a notification that there is a mother coming into their village. As the mother reaches, the VHT makes an appointment with the mother, goes visits the mother, educates them on various things, which include kangaroo, hygiene, breastfeeding, but also encourage these mothers to come back for the follow-up, for the clinic follow-ups in Kawempe. We've seen the numbers increasing from ever since we started the community follow-up to about 60 mothers plus per each visit they come to the hospital. So we also ensure that once these volunteers or the VHTs go to the community, they identify, they check out for the danger signs. Of course, the VHTs, we equip them with the thermometers, pulse oximeters, the weighing scale. We give them wraps that they give to these mothers while they're in the communities. And as soon as the VHT or mother champion identifies that a mother has an issue, they immediately refer them to the hospital, to the to the acute unit, where the mother is immediately given attention. And this, we've seen a lot of babies that have been saved from dying from home, because once these volunteers get there, you find that there are a lot of danger signs that they identify, which some like convulsions, high temperatures, low temperatures, bad breathing, not feeding. So these are some of the danger signs that we look out, and the app will automatically flag once a baby has an issue. We also encourage these mothers to come back for ROP screening. We know very well that one of the leading cause of blindness among the newborn babies is ROP. So we encourage mothers to come back for eye screening, and also we're moving into ear screening, because we have identified that there are some mothers, some babies that go blind as a result of prematurity. We also follow up, we encourage volunteers to follow up on parents that have got permanent disabilities that have come as a result of prematurity. So that's what we do, and together with Kawempe National Referral Hospital, with support of Dimaji, that provides us with a Home Care Connect app that we use to follow up on these babies.
Mama yenna ali mu mbeera gye nali nti takoowa kyonna kyayitamu kijja kutunga ekiseera kiggwe. Takoowa kubanga bba abaana baffe Mukama yabatuwa nga tebatuuse naye bw'oba tossizza mukono era nga bwe bakugamba okukola obikola nga bwe baba babikugambye n'okwagala okungi omwana bw'ajja okukola ajja kukula bulungi.
Living Goods has partnered with the Ugandan government to improve the reach and impact of community-based healthcare. Today, we support over 2,400 community health workers, reaching approximately 1.4 million Ugandans with essential healthcare services. Our approach is impactful and cost-effective. CSWs go door to door, educating their communities on the uptake of health promotion and preventive services. They tackle critical health issues like malaria, pneumonia, and diarrhea, and also offer additional maternal and child health support, like the active of family planning, support for access to antenatal care, and immunization. We believe that if community health units equipped, adequately supervised, and compensated, they are able to deliver high-quality care to their communities. This was demonstrated through a randomized control trial in 2013 that showed that desk-enabled community health workers contributed to a 27% reduction in under-5 child mortality. We collaborate with the Ministry of Health and other partners to strengthen the community health system in Uganda. We supported the development of Uganda's first national community health strategy that was launched in 2023. This strategy emphasizes the importance of a community health workforce that is digitalized, well-equipped, adequately supervised, and compensated in promoting good health. At district level, we support with operationalization of these policies, ensuring community health workers are supported and communities receive the care they deserve. As pioneers in digital health, Living Goods has over 15 years of experience deploying innovative solutions to improve health outcomes at scale. Today, we are proud to be a lead partner of the Ministry of Health in rolling out the Electronic Community Health Information System, ECHIS, bringing better healthcare access to even the most remote communities. Our work is guided by core values that drive us to put families first, prioritize scalable solutions, and innovate for sustainability. Collaboration is at the heart of what we do, working alongside governments, partners, and communities to achieve lasting health impacts. Together, we can close the healthcare gap and ensure no one is left behind. Join us in our mission to save lives at scale and transform communities across Uganda. In Uganda, it is heartbreaking that we are in 2025 and close to 76% of the population, especially those in rural areas and urban informal settlements, have challenges accessing basic health care. At Living Goods, our vision and mission is simple yet profound. We envision a world where every family can easily access the health care they need to survive and thrive.
In Uganda, it is heartbreaking that we are in 2025 and close to 76% of the population, especially those in rural areas and urban informal settlements, have challenges accessing basic health care. At Living Goods, our vision and mission is simple yet profound. We envision a world where every family can easily access the health care they
modeled offer that quality service, the post-abortion care services, and together with family planning, because most of these are young people, they come with their abortions, they are bleeding, and then you have to give service. To be very unfortunate, young as they are, 14, 16, you leave them walk out without at least a contraceptive. Before you know it, they'll be coming back. It has been equipped, all these modeled facilities.
To start with, to appreciate our long-term friends, IPAS. As you've heard from the DHO, the gaps affecting service delivery are quite significant, and as government, we cannot say that we can solve them alone. When we get people like you coming in to help us bridge some of these gaps, it makes us move forward. And with our limited resources, we ride on such partnerships. And for me, the exciting thing is that IPAS is diversified, and at least I'm seeing that we are really now broadening our scope.
This is Mukuju Health Center 4. I'm called Sister Isuka Jude. We have been with the IPAS for the last 3 years, and they have been supporting us in park services. I'm a provider for park in Mukuju, and we have all the family planning commodities in our facility. So we keep encouraging them, once they get pregnant, they should come to the facilities. They should not go to do them in a local way. So that is why you see this room is here, renovated by IPAS, and they were able to renovate it. They supplied us some equipment for park, and whatever we have here is under IPAS. So they have equipped us, and we are able to do our work comfortably without any challenges.
My name is Anna Kukundakwe. I work with IPAS Africa Alliance. Uganda program works and collaborates with the Ministry of Health in the promotion of safe motherhood. We appreciate the leadership and the stewardship of the Ministry of Health that has enabled us to put forward high impact interventions in 132 facilities, and of these, about 48 of them have received infrastructural development and renovations that go a long way in ensuring that women and girls have access to dignified care, but also we eliminate barriers by supporting community organizations to continue to mobilize communities, but also ensure that the myths and misconceptions are corrected within our communities. Thank you.
My name is Eric Okello. I lead an organization called TDIAN in Toro District. Now, in terms of the work we've been doing as TDIAN, IPAS, through the Embassy of Iceland, has been able to subgrant us, do amazing work in Toro District, looking at reduction of maternal or preventable death due to unsafe abortion, which has been affecting many of the girls and young women in Toro District. We have mapped community influencers, about 616 of them. We've supported cultural leaders to appreciate the life-saving impact of post-abortion care. We have used young people themselves as change agents. We've also dealt with stigma beyond just community leaders, beyond religious leaders. So in a nutshell, as TDIAN and IPAS, we've done so much in trying to normalize conversations around post-abortion care. Thank you so much.
Amazina ni Akankiza Elizabeth, nintura Ruto Maseru, kandi nyine omushaija ubu bari kweta Mr. Alinda Dennis. Nzire nawe abana babiri. Kabanza kurira family planning ahirwajo iri bari kweta Diane Medical Clinic. Bari kutushomesaho ko kubasa kubarira ruzaro yawe. Okuza kurunja abana ngeno mpora kurebeka gw'abana bakora kurungi kunagize irenda yo kubanza nagenda umwigwaro kuzara batwegesa ako kubasa kubarira ruzaro konka agataho tinabiforowinga munonga hata handa ya kabiri nibwo nahezaga kabiforowinga bakabitwegesaho kubareze kubitwegesaho nahurananye nabikunda abo kugira ngo enda yo kubanza nkazara mbwe no speed byanteganisa ati kubangambire murengo gwa family planning nibwo nazaga danayi hino wangambira guharo buhereza bubonire nagendayo ati akubahirize kunshoborera miringo yona ya family planning nacuzinga maka imporanoni kujya kabari kukanja kudiro mu kandi kuya nakatekamo tingarebire buzibu bwona bumbire ndije nkaburiza mesade ya imporanoni ekikunji kundire no twaraho bwire buringwa kandi ko kuhereza sente bakakutekamo otwariro bwire buringo tashuye kushashura kandi ekindi kinkakundire omuperiod zinoza munkaburizo tine side effect yoneyo eyi uri kutungamo ekyatumire nacuzinga kuza family planning nkareba okubanza kunazire byanteganisa ahabwo kuba nanshangaga buri ndakika ndi n'abana hatari kugira ngo ndi kuzaha ninga ndi hati konka ko nacuzingire family planning nareba yambonerera naye enda kuje kinakora mwe ninshanga ntererire konka okugenda wo tari ha family planning ati ni kutahamu nicyo cyatumye natunzinga family planning kugira ngo ziteke ndebe koko nabaririra family yanjye mu bana kushoma mu kukuraje kujya bakore barizi ati yantakagira family planning nampuriraga abandi baragamba ngo family planning nimbi ngo bundi ziragwaza konkanye yo kubagumagani bagambe bye byona najya ntikambaze nayikira abashawe benyine banshobororere ndebe kunagira yirwariro nibwe banshobororeraga kareba family planning etagire shonga niyo ngagumiza mu ngagizaho kareba etagira shonga no kuyisezisha ubuherezo ubundi kugambira batakagera family planning ndabahabura kugira ngo bagende mu marwariro bareke kurikiza ngambo z'abandi abari kwa batari bo bari kubishomesa bagenda umuganda amagwariro nkadana medical clinic kamukira RS center for hamwe n'agandi magwariro agabayengunurize kujya batunge job obuhereza bwa family planning ntabwo kwatibwine buzibu bwo nabwo kubasa kubakora amagara gabo insima obuhereza bwa Multisectoral Uganda obwe turetire obwe kutuhereza okugira ngo uburyomwe no muntu ari kubaryo ko mu cyaro atakabasa kubona sente nyinji zo kuzabuhereza kugira none abasa kubona yakasente karenganire ahita agenda abuhereza bamuhereza kandi abarira family ye kurungi.
Motherhood is important for obtaining the desired outcome for reducing maternal and neonatal mortality and morbidity, and generally for improving the welfare of the mother and the child. But we know that this all starts with family planning, because with family planning, we are able to ensure that individuals and couples have the adequate information and services regarding whether, when, or how often to have the next pregnancy. Family planning also aids the process of planning the timing, the number, and the spacing of the pregnancies. In this slide, I say something about some of the trends that we see in family planning in Uganda. For example, looking at fertility, we see our fertility rates going down over the years if we take the UDHS. But while we are seeing a reduction in fertility rates, our reduction is slower than it should be, as we shall see later in the subsequent slides. And so that means that there is still more work for us to do to achieve a faster reduction in fertility while meeting the needs of the families. Similarly, we see that the rate of use of family planning is going up while the unmet need is going down. But again, similar to fertility, the work remains to be done to ensure that these rates move at a rate that aligns to our socioeconomic development goals. As a government of Uganda, strategic interventions have been made that have impacted the state of family planning in Uganda. We all have heard of government commitments such as the FP 2020, the FP 2030, in which processes our government has stood up in global forums and committed to do certain things that will improve the welfare of women and families. And all the work that we are doing aligns to these global commitments that our government has made. Our government has supported policies. In the session just before lunch, we had a number of policies that were launched. Again, that shows government commitment to ensure that the needs of the community are met in this regard. The Family Planning Costed Implementation Plan, that is another strategic plan for us in the family planning space that again is guiding the work that we are doing. We have the RMNCH Sharpened Plan, which again aligns to the maternal and child health agenda that we are talking about over the next course of days. Leadership and governance, I will not say much about this. I think Dr. Mugahi in his keynote said quite a lot in terms of what government is doing in this space. We have several national surveys that tell us more about what we are doing. And all this leads to the results that we are seeing in the graphs that follow. So I'll delve a bit into adolescent health and teenage pregnancies and what some of the opportunities and challenges are. Teenage pregnancy. Taking a closer look at our statistics, recently, we noticed that the proportion of women aged 15 to 19 who have either given birth or are pregnant has stagnated between 24 and 25% over the last so many years. That remains an issue that we need to address as a country, as stakeholders feeding into family planning programming. If you look at teenage mothers, research shows that teenage women who were mothers during their teenage are 6 times less likely to complete secondary education and are 3 times less likely to have professional jobs. So it doesn't end at teenage pregnancy. The cycle goes on, and there are later effects in life that impact an individual and their family and their community. Teenage pregnancy is also responsible for a fifth of the annual births in Uganda, 7% of population growth. So we see that this has an effect. A number of pregnancies, close to 33.7%, are unintended. And all this tells us something as programmers. Further into family planning, we know that 20% of infant deaths and 28% of maternal deaths are among teenage people of the teenage age, of the teenagers. And if we speak economically, per capita reproductive health expenditure, if you look at mother and child, it's about $280. While when you look at the child alone and considering minor health care issues, we are spending about $8 on that minor health issue affecting the child. So this teenage pregnancy has an issue beyond just the health. It crosses to other sectors of life. So I'll say something about commodity security. Again, we shall hear more as we go into the presentations that will be given by the different panel members. We see in Uganda, our population continues to grow at 3% on average. And we have not been able to hit our targets in terms of reducing the unmet need for family planning and increasing the modern contraceptive prevalence rates. While we targeted in our FP 2030 commitment to hit 50% MCPR by 2025, we stand at 38%. While we hope to reduce the unmet need for family planning to 10% by 2025, we are at 22%. This means that there is a lot more work to do. And linking this to supply chain and commodity security, good commodity security systems will ensure that there's availability, there is affordability, and accessibility to contraception. That is the only way we will be able to meet our targets in terms of reducing the unmet need and increasing our modern contraceptive prevalence rates. So for us to achieve this security in terms of our commodities, we need to address the recurrent stockouts at facility level. We need to identify why those stockouts are prevalent and so put in place interventions to address them. We need to address things like inaccuracies in ordering and consumption reporting, because at the end of the day, they inform how much will be brought and therefore how much will be available. We need to address issues of donor reliance by focusing a lot more on domestic resource mobilization. And of course, we need to think about the rural and marginalized populations so that we are able to meet their need. When we go to human resources for health, again, because we are behind time, I'll not say this a lot on this slide, but I want to send us back to the first panel we had and the conversation around the midwife. I think that summarizes human resources for health in terms of improving maternal and child health. Something about family planning, monitoring, evaluation, and learning systems. How do we use our data? How do we use results from research to inform what we do? So we want to consider three things: the data systems, which help us to integrate the various data sources, triangulate data from all these, and then ensure that the systems collaboratively help us to address the needs for information relating to family planning. And then once we have our data collected through those different systems, how do we use it to inform programming, to inform policy, so that then the policies we have approved, developed and approved, align to the actual needs of the community. And then where we have research, how do we use the findings to inform programming, to inform shifts in ways of doing things, to define our high impact practices for more effective programming. Then about postpartum family planning, I didn't think I should leave before I touch on the low-hanging fruits. We know that there is a great opportunity for us to catch the mother immediately she has her baby. And definitely that should follow a successful pregnancy because the motivation to have a baby has been fulfilled. This graph, I hope you can see, says something about postpartum family planning. The blue line, the bottom blue line, is immediate postpartum family planning, and it ranges between 2 and 4%. This shows that while we are increasing our uptake of postpartum family planning in the immediate term, a lot more needs to be done for us to reduce missed opportunities. Looking at postpartum family planning at 6 weeks, we have more women having the opportunity to take up family planning. The graph too is going up, but a lot more needs to be done. So let me re-echo this as a high impact practice for family planning, that if we are able to get the mothers at that point when they are pregnant, we prepare them as they go through antenatal care, we prepare them for when they deliver to take up a method. That is a practice that will get us, the women, and reduce the missed opportunities. So as I close, I'll say something about a call to action. Here we have one of our high-ranking religious leaders talking about the importance of contraception in crisis. So they were referring to the lockdown. But in this slide, I want to re-echo what the religious leader is saying. It is our duty, all of us, whether we are the beneficiaries, whether we are decision makers in our respective capacities, let us work together to promote a multisectoral approach for family planning programming, looking at family planning as a social transformation and development issue rather than a health issue. Let us prioritize our young people. They have very many needs, and if we reach out to them and address their needs, we shall be able to tackle the teenage pregnancies and prevent them further. Let us embrace supply chain reforms to ensure that we are able to have a reliable supply of all the full method mix for family planning. Let us address issues of provider bias so that when somebody turns up for services, irrespective of their socioeconomic status, their age, they should be able to get an unbiased care. Let us garner our communities to support demand creation and take up these interventions that we have provided. Let us ensure that there is sustainable financing for family planning at national and sub-national levels. Our district local government, if we engage them, we have an opportunity for them to allocate resources for this important work. Let us enhance strategic information generation so that then we have adequate information to inform the approaches and the policies that we design for improving family planning. And as I close, let us increase family planning service readiness, quality, and scale up high impact practices, because these are the low-hanging fruits. They will help us to hit 2 birds with 1 stone. So I want to thank you so much for listening, and I welcome Ronald to take us through the next session. Thank you.
Please, another round of applause to Dr. Rita Wadimba. Thank you so much for that presentation. I think it is sensitive, national annual growth rate at 3%. You start wondering at what rate is the national health budget growing amidst the reducing donor aid. And then the conversations around domestic resource mobilization. At that point, you want to start asking yourself, after the reduction in donor aid, what are those new things we are doing to increase domestic resource mobilization for this growing 3% annual population growth and the adolescent pregnancies that have been presented everywhere? So very many questions. I can't say more. Our presentation was very rich. At this point, allow me, in the interest of time, we move straight to the introductions and presentation of the panel of the 5 experts that are meant to present before us today. And as I read them out, I'll request they take up their seats. To start with is Miss Rosette Nanyanzi. Please welcome her to the podium. Thank you, Ms. Rosette, for making it. She's a highly accomplished social development specialist with over 15 years of experience in advancing gender equality and inclusion. She currently serves as the Gender Technical Advisor to the Ministry of Education and Sports, multisectoral collaboration. We are getting there, where she has played a pivotal role in shaping gender-responsive policies and programs in the education sector. Ms. Rosette has been instrumental in spearheading key national initiatives, including development and implementation of one, the National Strategic Plan on Girls' Education 2014-2019, the Gender in Education Strategic Plan, the National Strategic Plan on Elimination of Violence Against Children, the Guidelines for Prevention and Management of Teenage Pregnancies in Schools, the Guidelines for Implementation of the Roles and Responsibilities of Senior Women and Teachers. These ones still need a lot of support. The Guidelines for the Formation and Management of School Clubs, the Guidelines for Management of Menstruation in School, development of several readers on GBV, violence against children, menstrual health, among others. Her expertise extends to policy, advocacy, and capacity building, ensuring that education systems are gender responsive, safe, and inclusive for all learners. Rosette holds a master's degree in development studies and multiple postgraduate qualifications, including sexual and reproductive health and rights, gender responsive education planning, health sector policy and planning. Her dedication to gender equality in education continues to inspire transformative change, making schools safer, more inclusive for learners across Uganda. Another round of applause. Thank you so much, and again, welcome Ms. Rosette. To our other panelists, please welcome with me again Dr. Rodney Tibaruka, who is in for a discussion on commodity security. Dr. Rodney is a principal pharmacist at the Ministry of Health Department of Pharmaceuticals and Natural Medicines, where he's also acting registrar for Ministry of Health Pharmacy Board. With over 15 years of experience in the Uganda health supply chain, he holds a Master's of Health Supply Chain Management. Dr. Rodney is a seasoned health supply chain specialist who has contributed to health commodity security at the national level and as a pharmacist at Mulago, Utavika National Referral Hospitals, and various regional referrals. Again, welcome Dr. Rodney Tibaru. Our other panelists, welcome with me Dr. Ronald Senyonga. Welcome, please. Let's welcome our experts. Who is a lecturer, biostatistician, and researcher in the Department of Public Health at Muni University, working closely with the Department of Epidemiology and Biostatistics at the School of Public Health at Makerere University. Dr. Ronald has worked on both experimental and observational research, from designing studies to implementation to close out and generating policy and evidence briefs. Dr. Ronald holds a postgraduate training in epidemiology and biostatistics. He has contributed over 20 clinical trials, great, 30 regional and national survey evaluations, and over 40 peer-reviewed publications. Wow. Among other responsibilities, he is currently part of the Empowering Women for Better Reproductive Health Outcomes Empower Investigators. You'll note that Empower has a monitoring and evaluation and learning component, which is headed by Makerere University, so he's among the investigators, bring experience of over 10 years from performance monitoring for action in Uganda. Please welcome with me again Dr. Ronald Senyonga. Allow me to pick my other. Thank you. Our fourth panelist, allow me to welcome Ms. Juliana Lunguzi Mudamvesa, sorry if I may pronounce your name wrongly, with such a beautiful name. Thank you. She's the Program Coordinator for Sexual Reproductive Health and Integration at UNFPA Uganda, a trained nurse and midwife. She has nearly 20 years of experience in sexual reproductive health rights programming. 20 years, please. Thank you. Also in health system strengthening, policy advocacy across humanitarian and development contexts, Juliana has worked globally and in Uganda to advance equitable sexual reproductive health and rights and strengthen community health systems. Thank you and welcome, Ms. Juliana Lunguzi. Our last panelist, who is also the moderator of this session that I introduced first, once again, welcome with me Dr. Rita Wadiba to take over the seat. Thank you so much. Let me get a simple whisper before I hand over. Thank you so much.
Okay. Let me start.
again, welcome with me Dr. Isavilier Frederick Daniel. Thank you so much. The City Health Officer of Ginger. He is a seasoned medical doctor and public health specialist with over 22 years of experience in clinical care, health system strengthening, and public health programming in Uganda. I'm talking about 22 years of experience. She currently serves as the Health City Officer for Ginger City and has previously held key roles at both national and district levels, including as District Health Officer in Buyende, Technical Advisor for the Global Health Fund Malaria Program. Dr. Isavilier holds a Master of Public Health and a Bachelor of Medicine and Surgery from Makerere University. He is a member of multinational technical working groups and has continued to design and implementation of strategic health initiatives, including National Malaria Strategic Plan and the rollout of integrated community case management. Dr. Isavilier is a recognized leader, you can agree with me, 22 years in the Uganda health sector, and combines strong technical knowledge with practical leadership, policy engagement, and a passion for capacity building in underserved community services. Thank you so much. Again, give me a full round of applause for all our panelists. At this time, you will allow me to hand over this podium to the bigger shoes of Dr. Rita to take over the moderation of this session. I want to thank you so much, Dr. Rita.
Thank you very much, Ronald, for ushering us into this panel discussion. Ladies and gentlemen, good afternoon. We are delighted to welcome you all to this session under the theme Collaborative Health Systems, Making Family Planning the Essential Core of Safe Motherhood. This theme is a recognition of the foundational truth that safe motherhood is indeed not possible without quality family planning. So by enabling individuals, couples, to choose when, if, or how many children they want to have, and how often even, this will reduce the risks that are associated with birth that are not well spaced. So achieving what we are here to do today and what our objective is as Uganda, achieving this requires more than just the clinical aspects. It demands a collaborative health system, multiple sectors coming into play, so that together, from policymakers to the community health worker, we work in synergy. So over the next hour, our panelists will delve into the mechanisms that are needed for us to make this collaboration a reality. So personally, I look forward to a really productive discussion. And without wasting much more time, allow me to invite our first speaker, Ms. Juliana. So Ms. Juliana, achieving sustainable family planning programs requires innovative financing and strong collaboration with the private sector. As donor funding dwindles, Uganda must explore alternative mechanisms to ensure access to family planning and maternal health services, and commodities continue uninterrupted. How can innovative financing mechanisms such as health insurance or social enterprises contribute to family planning sustainability.
Thank you very much, moderator. And good evening. It's now evening once again. From where you're sitting, you're calling family planning to be a call for safe motherhood. For some of us who work, just like you work in safe motherhood, we look at family planning as a vaccine for maternal deaths. We have seen the data this morning, what is happening because young people are getting pregnant, people are getting unwanted pregnancy and unplanned, there are abortions. So we didn't look at family planning to be core. So because of that, we truly feel that financing for family planning ought to be sustainable. And for us to do that, we ought to move away from donor dependency and enable family planning financing within the national health architecture. You agree with me, earlier this year, what happened to all of us when we saw USAID pulling out from the space of financing for family planning? We really struggled. Why? Because we have depended so much on the donors to do that. So one of the things that we need to look at when it comes to issues of national health insurance or community-based health insurance, we feel these are alternatives that we must explore, and not only explore, but we must provide opportunities to make sure that we achieve financing for family planning using these modalities. Because we can't continue doing that. So first of all, when you look at health insurance, and when we're talking about health insurance, we're looking both at public and private. I'm aware Uganda, just like many African countries, we are struggling to have health insurance cover on family planning. There is no guaranteed package for family planning. These are the advocacy issues that we need to look into. How can we make sure that we have a guaranteed package from the insurance, instead of making it as an add-on? People should make sure that when I have this package, family planning is one of them. And family planning must also be looked at as the rights-based entitlement, not just, as a project-based. Because the way we are financing family planning, it's like a project. Empower is here, the package includes family planning. Somebody stops, Empower project ends, that's the end of family planning. But if it's rights-based, we'll make sure that government put it as a priority, and even private insurance. When it comes to second social enterprise models, we are looking at providing that access and sustainability. We need to make sure that access and sustainability, they do coexist. So we need to support local pharmacies. We need to support clinics, youth-friendly health services, so that they are able to support family planning services. FCDO right now is with us and other partners like Marie Stopes. That's one of the things that we're doing, the total market approach. We want to take family planning to the clinics, to the pharmacies. There are so many pharmacies in this country, especially a country like Uganda, where almost 60% of your service, people get services using out of pocket. We want pharmacists to be able to provide those. If we do that, we'll be able to make sure that we have a viable business, and it's something that can be sustained. So we need to go to the pharmacies, to equip the pharmacists with the right information, even teach them how to do the implants. And most of all, we need to make sure that we provide subsidies to these clinics. Because some of the, especially when you look at the data, Kampala is not doing well, but it's urban. But when you go deep, you find that Kampala is not doing well, because everybody make assumption that whoever stays in Kampala has money. So you can hardly find those commodities that are for free, and people are struggling. As a result, we have people who are getting shortcuts on getting medications, and sometimes they go to the hospital when it's too late. So it's something that we need to do. And when all is said and done, we shouldn't only look at private or public. We need to focus on blended financing, linking the public funds with the donor funds and the public capital, so that we can have like the impact bonds or research-based financing to be some of the things that we can do as a country. So these approaches will make sure that every shilling that we invest can generate measurable outcomes. And some of the things that we need to do is to make sure that when we blend this, we can see multiplying impact on the activities that we are doing in the area of family planning. You can ensure that funding is predictable, the domestic is predictable, and everybody can access it anytime that they want it, and it's also sustainable. And one of the things that I want to highlight before I give up, in conclusion is, when we talk about family planning, make sure that when we're working with the private sector, we link them to the public, like to make sure that they also report to our DHS2 portal, DHIS2 portal. There's also quality assurance. When the government is monitoring, don't just go to the public facilities. Also go to the public facilities, to the private facilities, to see what's happening, see if things are happening right. And people will feel that we belong to a system and they could be accountable to something, because otherwise there can also be some shortcuts. So in a nutshell, let's blend the private and the public, and let's make sure that they also report in the same data system so that we can see what's happening on the ground.
Thank you, Juliana. This is interesting. Let me move to this side and maybe go to Dr. Sylvia. As we discuss making family planning the essential core of safe motherhood, it is important to recognize that no program will succeed without a strong, motivated, well-supported health workforce. From community health workers to midwives to other health workers within the facility. These are the champions who turn policies and commodities into real impact. So the question for you is, how can Uganda's health workforce planning and deployment be strengthened to ensure that family planning is well integrated into maternal and newborn care across all levels?
Thank you so much. Ladies and gentlemen, I want to say the following. The health workforce planning and deployment can be strengthened to ensure that family planning is well integrated in there by doing the following. One, we have to make integration and explicit workforce planning an objective. That is, whenever we are making plans regarding human resource for health, we must make it what? An objective that family planning is embedded in there. And this morning, we were talking and we even voted that midwives should be the priority cadre to recruit. But that does not happen without what? Planning at all levels. For example, at district level, when we are doing our recruitment plans, we must ensure that cadres like midwives, doctors, and all others that are involved in family planning are given priority. Ladies and gentlemen, we have to go for that low-hanging fruit by ensuring that all our human resource for health plans include cadres that are directly involved in what? Family planning. Very key. Secondly, update our scopes, policies, and pre-service curricula. When we are training our health workers, we should ensure that all the curricula include family planning. Yes, for the start, we can say midwives, doctors,
but we need everyone. Ladies and gentlemen, if you've heard about what we call demographic dividend, that can only be achieved after putting at the forefront the family planning agenda. And that's what I'm saying, that all health workers in their training, pre-service, should have a component of what? Family planning. And it's not only the pre-service trainings, but even our ongoing in-service, continuing professional development sessions. Let's have a session on family planning. That's when we shall be able to ensure that family planning is well integrated in all what we do and in all our activities. Number 3, let's formalize what we call task sharing. Formerly we used to call shifting, but shifting means you abandon and give the baton to the next person. But let's formalize what? Task sharing. That will enable our midwives, nurses, and even choose to provide counseling for family planning, to offer oral contraceptives, injectables, and even referrals for the long term. Ladies and gentlemen, we still have a challenge. We are actually at crossroads. Legally, currently they choose. There is no legality to enable them, to allow them to what? Provide these services. But it's very key, we know that they are really playing a very vital role. This morning we saw Sayana Press taking #1 position in the presentation which opened this conference. But who are the providers? Choose. So let's ensure that we formalize their work. Then, facility managers, DHOs, and other managers in health services. Let's ensure that we align our deployments to ensure continuity of service. You can visit a facility and you find that in the postnatal clinic, the person manning it is not a guru in what? Family planning. So at such key points, can we ensure that we have experts, people trained in family planning, such that we don't miss the opportunity? What happens in postnatal if they deployed somebody there who is not well conversant with methods? She will postpone, and we miss the what? That activity. So let's ensure well-trained midwives or nurses deployed on key points like maternity, postnatal, to ensure that even OPD, because this morning we were talking about more midwives, but they don't see everyone. There are many entry points in health facilities. The OPD taking the priority, but we don't deploy midwives where? So can we ensure that through our continuing professional development sessions, everyone gets knowledge on family planning, at least to refer. Every health education session in the OPD should have something on family planning. I've already alluded to it, that we can only achieve what we call the demographic dividend by putting family planning as #1. Actually, all developed countries, when you look at their birth rates, it is around 2-3. Isn't it the magic bullet to become economic power? So it should be at the forefront. Now, the next point I would talk about strengthening our workforces is to give them support. Support, supervision, and mentorships are very key to this. Very, very important. We should know that it encourages and it even boosts their morale when you visit them and correct them and applaud them on what they are doing. And of course, when you go with more materials, more information, which will enable them perform better. The other thing we can do is to ensure that we use our information. We now have a system called the Health Information Management System. It can clearly show us gaps in our staffing levels, and that can help us do what? Improve the staffing plan. In the next recruitment, you note that I have a health center for with only 2 midwives. They cannot run maternity, go to antenatal, and go in the postnatal, and all areas required to offer family planning. So, can we use our information system properly? Lastly, I will refer to my brother Rodney, ensuring that commodity and supply chain does its work very well. You know that workforce efforts fail if they are no what? If there are no supplies. It's not once, no twice that we go out in the field and mobilize for family planning only to be disappointed when they are no what? And when they come, we again start afresh by apologizing and again remobilizing already immobilized the community. So, ladies and gentlemen, that's how we can strengthen the integration of family planning in our workforce. Thank you so much.
A round of applause for Dr. Sylvia. Thank you very much for speaking passionately about our health worker. Involve them in the policies. When you deploy them, train them, give them support in their work. And I like the whole site approach. Don't think about the midwife and the labor ward only. Think about the other entry points for these women. So, is there a health worker, and are they skilled to pick out that woman, to address their needs, even when the woman came for something totally different? Thank you very much for that. Now, as you concluded, you talked about commodities. And because of that, I want to move to Dr. Rodney to say something about commodities. So, Dr. Rodney, ensuring that every woman, wherever she lives, has uninterrupted access to quality family planning commodities. This is a cornerstone of safe motherhood. Yet we know that there are challenges and they persist across the entire cascade of supply chain. What progress has Uganda made in ensuring that family planning commodity security is well sorted? What major bottlenecks exist and how can they be addressed?
Thank you very much. It is quite a loadful, but I'll unpack slowly by slowly. I'll start with where we are. Where we have been from, where we are going. I'll look at, first of all, the progress we have made in Uganda in securing family planning commodities. One, we have so far a clear national roadmap for Uganda's National Family Planning Costed Implementation Plan, that is 2020 to 2021. And this plan sets explicit objectives for commodity security, including governance, that is for family planning, reproductive and community security working groups, quantification, and last mile deliveries. Two, apart from having a plan. Two, we have had commitments made, the Family Planning 2030 commitment, whereby we have ring-fenced 50% of the family planning commodities to be purchased by the government of Uganda by 2025. In the year this was done it was first approached in the year 2023, whereby the government of Uganda contributed, quote, figures, 3 billion shillings. And as we speak, we are now in the year 2025, whereby the government of Uganda has committed 10 billion shillings for the financial year 2025, 2026 to FP commodities. So this ring fencing of the 50% of RH commodities budget, let's get back to that. Let me just draw you a little bit behind. How do we arrive at the family planning commodities budgets. We do national quantifications every year, both from the facilities and national at the Ministry of Health. The current financial year in which we're running at, the amount of money we need for family planning commodities is 113 billion Uganda shillings. We have something called a matching fund, whereby our partners commit government and say, for whatever dollar you commit, we shall commit the same amount of dollar. That is the 50% I'm talking about, the 56% commitment. In that, of the bill that you have, whatever you put in, we shall commit 50%. And unfortunately, we have managed, the government of Uganda this year has committed 39 billion Uganda shillings of head. And of that 39 billion, unfortunately 10 billion is going to FP commodities. The other money, 24 billion, is going to markets. We all know how political markets are. They can cause a collapse of the nation. So, for that reason, our partners have given us the equivalent of the 10 billion so far. They have released 7.1 billion. So, we are seeing that 50% ring fencing actually working for the commodities, for the family planning commodities. However, with this combination of the 39 and the 10 and the 7.1 billion, it comes to 42 billion of the 113 billion that is needed for family planning commodities, leaving a funding gap of, unfortunately, 63%, which is quite big. But that is where we are. Like I've told you, 2 years ago, we started at 3 billion. 2025, we are at 10 billion, and we are seeing this amount of money continue to grow. So the future is bright. We are going to continue closing this gap. 3, we have integrated national supply chain planning for family planning commodities, as included in the 10-year health supply chain journey to self-reliance. I don't know if most of you have heard it. We were part of the departments that were quite visionary. Around 4 years back, we drew a plan, a journey to self-reliance. And in that journey of self-reliance, we stated targets. And in those targets, we were very purposeful about an incremental approach to the funding of government of Uganda towards all programs, that is HIV, TB, family planning, and all nutritional items. We did not leave behind family planning. So the monies that have been allocated gradually to family planning, commodity security, have been highlighted under this 10-year health supply chain journey to road self-map, a very well-written document that is on the shelves and also the website of Ministry of Health. And we keep on monitoring how we are performing against our projected targets, saying that in 2027, where did we expect to be? Where did we expect government's contribution to reproductive health, to HIV, to TB, and all other programs to be? And we're monitoring this, so we have this, so there's progress. We're being very intentional. And this 10-year health supply chain journey, it prioritizes forecasting, quantification, pipeline visibility, and distribution performance. 4, we have institutionalized quantification and annually published integration reports for essential medicines, including family planning, which improves procurement planning nationally and at facility level. At facility level, there has been a problem whereby people usually forget to plan for family planning commodities, but using our teams on ground, we are now very intentional and reminding people to plan and make sure that they have ordered for family planning commodities and RH commodities. We are also leveraging on multiple distribution channels, that is for the public system. The people who were in this room earlier in the morning, you remember Dr. Mulgahi, Commissioner of Reproductive Health, he mentioned that 83% of our deliveries are in public facilities. Then 13% are in the PNFPs. That's 96, leaving 4% to the others. So we are leveraging on the two main distribution systems we have, that is national medical stores for the public facilities, joint medical stores for the PNFPs and the private for-profits. And with these two distribution mechanisms, highlighting joint medical stores as the alternative distribution system, we have increased availability of reproductive and family planning commodities, enhancing commodity security. We also, number 6, we also have ongoing partnership support. We are all aware that we lost some partnership, we lost some support when USAID folded, but we still have a few partners left. Case in point, UNFPA. And UNFPA has led the conversation with our matching fund and pushed through this compact agreement and pushed the government through soft advocacy skills. It has pushed the government to up its contribution. And so far, we're seeing that happening. We also have other partners like CHAI, which has provided multiple micronutrient supplements to improve maternal nutrition and birth outcomes. CHAI has also promoted the upscale of the emotive bundle to manage PPH. So we're working well with our partners to make sure that our family planning and commodity security is on point. I want to brief it up. Digitalization is important. Electronic medical systems. Rita, you mentioned this, you're talking to this. These EMRs, such as EFR, have increased accountability, visibility, and traceability of our items. We have been doing last mile leakage checks, and we are seeing an improvement in the leakage of our supplies into the private sector. All this ensures better availability and accessibility of our commodities to Ugandans. We also have a quantification analytic tool called QuantiMed, which is semi-automated. And this QuantiMed system can tell you when a shipment is expected on the sea. It monitors stocks in the pipeline, making sure that at no point should we have stockouts in the country, ensuring commodity security. We also have very beautiful policies as Uganda that ensure commodity security. For example, the National Annual MNSCH and MPDCA SRR report, which has been launched today. We also have endeavors like the 5th National Self-Motherhood Conference that we have here. We have the costed implemented work plan. We have so many good agendas, even the Ramkas Sharpen plan, among other things. These are things going good for us. Bottlenecks. What are the problems? Funding and donor dependence. Yes, like I alluded to, we lost USAID aid, but we have pushed on the government. In case people in this room did not know, I want to allude to this, that for the first time, the national allocation of the national cake to the health sector leapfrogged from 4% to 8.1% in this year. 2025-2026, we thank our minister for pushing for this. That is a big jump. 4 to 8.1 is really, really big, and we need to really upload ourselves. So if we continue going this way, maybe one day we shall reach the Abuja declaration of 15%, and we close all these gaps and we reach the promised land. Stockouts. Of course, we have had stockouts at different service delivery points, and these affect service delivery, of course. Recent assessments continue to document stockouts, especially for the short-acting methods, and of course, this constrained service delivery. We also have problems with data quality. People do not take family planning commodities seriously. They don't take them as life-saving, so they don't report on them. And with poor reporting, it affects our quantification. We quantify badly, and then these bad quantifications can affect the availability of commodities, because bad quantification equals what? Stockouts. Trash in, trash out. We also have procurement and import frictions for 3 commodities. Condoms. condoms, gloves, delivery sets. I'll talk into condoms especially. Condoms and gloves are double regulated by the National Drug Authority. They pay $350 per batch. Batch has 400,000 pieces. After paying that money, then you have to go to UNBS. Then UNBS charges you 0.25 to 0.5% of the FOB. For those who have imported cars, you have heard of FOB, that is free on board versus CIF. That is the cost you bought the consignment before it reaches the shores of Mombasa. So UNBS charges you up to 0.5% of the FOB value. Much as it's our partners paying for this, it's a lot of money. Just one batch of 400,000 is being costed, is facing levies of around $3,000 to $4,000. These are barriers to access. So another problem we have, of course, is we have had problems with our total market approach model. Of course, we need to target the free stroke subsidized stroke commercial supply in order to optimize choice, method choice and sustainability. Much as public and PNFP sectors are covered, we need to really strengthen the other social marketing arm so that accessibility in that arm is improved. So that is another bottleneck. Another bottleneck, which is actually one of the biggest, one of the most consumed reproductive health items, implant on NXT, has one international supplier, manufacturer. So imagine the whole world is waiting at its door. So you can imagine the traffic jam that is at that facility. So the lead times are bad and the demand is high. So that is another hindrance we're facing. So we are faced to make orders almost 2 years in advance of our own need because of the long lead times for implant on NXT. Yeah. Then also we tried pushing commodities to private sector, and unfortunately they did not abide by Government of Uganda accounting standards. So we scrapped that. We thought we had moved a step forward, and we had to move 2 backwards. Those have been the main challenges reported. Thank you, Rita.
A round of applause for Dr. Rodney. Thank you very much for walking us through the reforms, the innovations, the investments in the space of supply chain for maternal health and family planning. It is great to see that we are making progress. I'm particularly excited in the increase in domestic resource allocation to this area. And this really shows how our advocacy is paying off. And we shall continue to work together to make sure that we even get more next year. So as I sat here, I've really been thinking about our adolescents and young people. And I would like to turn to Ms. Rosette. And this is what I have to say. Adolescent health is a critical area in the space of safe motherhood. Early pregnancies continue to expose our young girls to preventable risks, complications, and death. We also know that these pregnancies actually are the ones that throw them out of school, and their life changes totally thereafter. And most often this is really due to limited information and services. So my question, how can the education and health sectors collaborate to address teenage pregnancy while promoting youth empowerment?
Thank you very much. I think for me, we need to appreciate that the National Development Plan has given us an opportunity to be able to work together. So that is the starting point. So that Ministry of Education, Ministry of Gender, Ministry of Health can actually be able to do a lot of things to support our adolescents. 2, we already have platforms that are giving us that opportunity. For instance, the National Teenage Pregnancy Surveillance Platform. I think for me, this is a very good opportunity for us to work together. And that platform does not only bring together these three ministries, but it is bringing even the local government, which is an advantage that instead of dealing with these issues at the national level, we can actually be able to deal with them up to the local government level. And for me, that is a very good platform that we can use. However, I note that much as we have all these platforms, we need to do more. For instance, when we are developing policies, are we sitting together? And there are opportunities. Already, as Minister of Education, we are leading on the review of formerly the Sexuality Education Framework, and we have the National Framework for Health and Well-being of Adolescents. So this framework, we are seeing the Minister of Health being part of this. How I wish when it comes to implementation, we can be able to move together. We also need to consider that as Minister of Education, there are certain services that we cannot provide. So we need to work on strengthening the referral and linkages to health services. Within our education setting, other than the sexual reproductive health challenges, we also have other emerging challenges. For instance, mental health is another issue. How do we deal with it as education? So we need to see that we strengthen these response and referral pathways. And I need to appreciate Minister of Health and Education. We had started on the referral and linkage guideline, but I think we stopped somewhere. We need to revive that so that we can be able to link our young people to such services. We should also be able to jointly look at issues that expose our young people to teenage pregnancy. And as Minister of Education, we've been leading on the work around menstrual health. We have seen in many of our districts that our girls are getting pregnant for as low as a pad. But we also find that we have norms and practices that actually promote sexual activity immediately after starting the periods. So as the two sectors, we really need to work together to see that in our programming, we take care of those issues that actually expose our young people to teenage pregnancy. Aware that resources are now becoming very thin, especially from our development plan, development partners, we should be able to do integrated planning and budgeting. We may not be able to get resources to specifically look at teenage pregnancy, but how do we ensure that teenage pregnancy is incorporated in all the other programs that we run as the two ministries? I think that is also an opportunity. The other thing that I need to talk about is the use of data. And during COVID, we had an experience. We saw some Ministry of Health providing very good statistics of girls appearing for the first antenatal services and the numbers we are learning. And when we shared these numbers with our ministries, we were saying, but how sure are we if these are in a school? So as the two sectors, I think we have an opportunity to be able to use our data from both ends to be able to inform what we do. And as we are doing that, then we should be able to build the capacity of our officers, both from education and health. If, for instance, at the health facility, the data that we get from those people maybe are seeking the first antenatal services or are seeking other sexual reproductive health services. What kind of stories come to our end? How do we use that data at that level to be able to inform what we do. So I think that is an opportunity that we can take advantage. We can build the capacity of our personnel at that lower level to be able to get stories out of this data that they collect. For instance, when you, in education, on a daily basis, we collect data on attendance, and we'll be able to see that the data is there. Maybe girls are missing, maybe they are absent. What kind of information do we try to pick from that data when we get it? And lastly, as I conclude, we have an opportunity as Minister of Education for a long time. We have not been promoting family planning, but we have an opportunity through the framework that we shall be able to give age-appropriate sexual reproductive health information and services. So I think for me that opportunity is there, and it will help us to work together to ensure that we reduce on the issues of teenage pregnancy that are affecting the education sector more. Thank you very much.
Thank you, Ms. Rosette, for shedding light on those synergies and opportunities for collaboration between the health and education sectors. I like the age-appropriate sexual reproductive health information and services. So for me, that is my highlight. So as Ms. Rosette was winding up, she said something or a lot about data. And I think this got Dr. Ronald Senyonga to smile. So that takes me to you, sir. Accurate data and research are critical for evidence-based decision-making and for resource allocation to family planning and maternal health programs. As Uganda continues to make strides towards data-driven health systems, it is important that we continue to examine how monitoring, evaluation, and learning can deepen accountability. So my question, research and evaluation, including national surveys, such as the UDHS, have been promoted. What has been their role in advancing family planning programming as a core component of safe motherhood?
Thank you. As we are talking about data, I must say, Chair, that I was observing the room and people were sending messages home to let them know that I'm about to finish. So I'm going to take a very short time. I think in terms of these national surveys and this data, we see a couple of pieces. When you talk of policy, you talk about the FP 2030, you talk about the costed implementation plan, figures that are in there that actually inform what we should be targeting or where we are come from these surveys. And so that really helps us. The other bit is when you, for example, review the national research agenda, you'll see that that also informs programming of the country. And maybe to just add an addendum to this, we had the Health Service Commission Chair speak about how do we quantify our effort. If we ask any of the partners here and we ask, what is your contribution to safe motherhood? Is it 20%? Is it 100%? For you to actually know that you're causing an effect in service provision, there is need for you to have this evidence. And this is not to downplay the routinely collected data through the health management system, because it also provides information. But the opportunity we have with these surveys is that in addition to giving us data that we are actively monitoring, it also adds certain layers. Sometimes we get information of the why. Why are people doing certain things that we might not necessarily get in the routinely collected data? We had a very interesting presentation by Dr. Mugahi speaking about how Sayana Press is up there. But when you look at the early times and how, for example, the UDHS surveys, the PMS surveys, the RISE surveys, and other national and regional surveys have done it, they try to go in and see what are the people using. Why aren't they using some of the commodities that we are providing? And that is rich in itself, because it gives us a continuum to work with, for us to know that this is where we are, this is where we want to go. Now we can comfortably talk about the percentage increase in FPUs or FP adoption, because we have some idea as to what the history has been. So we need, I think, to continue advocating and ensuring that we have opportunity to continue generating evidence, because without evidence we can't talk policy, or good policies, so to speak. Without evidence we can't talk about proper service provision as well as accurate programming. Thank you.
Thank you very much. Yes, it's always very refreshing to hear about the data side of things, because it always gets us back on track, whether what we are doing is really aligned and addressing the actual needs. So I want you, ladies and gentlemen, I would like to request you to join me to clap for our speakers this afternoon. And we would like to pause at this point for any questions, any points. So I see a QR code displayed here. Ronald, probably. Would you like to talk about this code?
So thank you, everyone. Code has already been shared, and the 3 questions are displayed on this side. I thought they would be here, but maybe I'll just read them through. Dr. Rita, I'll request that maybe you take over this microphone and read them from here. We've been unable to display them on this side. Thank you.
Oh. Okay, sorry, I was not seeing that. So we have some questions here. Many parents are still negative about family planning being given to their girls who are at school. How are we going to handle that? I would like to direct this to Ms. Rosette. And as she prepares her response, I'll go to the next question. What else can be done to address provider bias regarding providing contraceptives to adolescents? Mentorship has not addressed this. Provider bias. Ms. Juliana, is this something you'd like to talk about? I can read it again. What else can be done to address provider bias regarding providing contraceptives to adolescents? Mentorship has not addressed this. Next question. How many parents are still negative about family planning being given to their girls who are at school? How are we going to handle that? Ms. Rosette? How can we help girls that do not go to school to access family planning services? I'll ask Ms. Juliana, as we talk about provider bias, to also talk about those girls that are out of school, how they can access these essential services. Next question. When an adolescent below 18 years comes and chooses long-active and reversible contraceptives, how do we go about the consent procedure? I'll pause a bit for Ms. Rosette to respond to her second question.
Thank you very much. How do we deal with parents who have not yet appreciated family planning. The government of Uganda, through the Ministry of Gender, Labour and Social Development, we have a national strategy plan on ending child marriage and teenage pregnancy. Under that strategic plan, there is a lot of work that we need to do in terms of ensuring that we create awareness to the communities on the dangers of teenage pregnancy. And I think as a country, that is the starting point, because we cannot expect people to just buy into this. We need to create awareness so that people know the implications of early teenage pregnancy and how it costs that family, but also costs the whole country. That aside, there are so many myths and misconceptions about family planning. Again, it takes all of us in this room to be able to address those myths and misconceptions. Other than that, when we don't do that, we may take some time. So it's important that we embark on creating awareness and trying to address the different myths and misconceptions about family planning. Thank you.
Thank you very much. I'll give a minute to Ms. Juliana to say something.
Your question is about provider bias. Besides mentorship, I think one of the things that we must know is that when it comes to issues of family planning, it's beyond being mentored. You're looking at issues of attitudes, issues of there are systemic issues, there are values issues. That's why in the training these days, we are putting in the component of value clarification and attitude transformation. Because as a service provider, as a midwife, I ought to understand that, somebody is looking for the services because they need them. So I should check out whatever I feel. But that comes with being taught there's a whole 2-week training about value clarification. Very important when it comes to providing SRH issues. And, in midwifery, we talk about respect for maternity care. In respect to maternity care, you really need to look at the person as a whole and the needs of the person. And you need to check out your own beliefs to be something that needs to be in front. So this is something that you go through as somebody and to understand that there could be some consequences. So we ought to also think about accountability issues within our settings. We can't just let people go. They are accountable to somebody. You provide a service and you're accountable. And also think about performance incentives and supervision. Very important. Because it's not about just going to person one time. We need to go and use all that data. And also the feedback mechanism. We ought to give our providers feedback, how people perceive their care and where they need to change. If you just leave it and think that everything is okay, you find that it's very difficult for people to get that. And this is also where we need to think about the innovation tools so that people can get access to services aside from getting it from the service providers. So it's also very important to think about that. So let's think about values transformation, accountability, and using innovation. These days, there's all these AI chatbots that you can use to ask, apart from going to the service provider, if issues of attitudes persist. Yeah. And you also asked about out of school. For out of school, these days we have village health teams, we have community health workers, we have peer-to-peer provision of services. It's very important. And we need to make sure that we use different modalities. These days, you can go on market days, you have some other programs like Marie Stops, Naguru, who combine all these activities to make sure that they reach out to young people out of school. And I just want to talk about the issues of school. Yes, the issues of school remains a tricky issue, but for some of us who continue advocating for those things, because where you find most of the young people, it's at school. So you provide information appropriate to the age to make sure that they can get the right information. And you tell them where they can get information if they can't get the services in school. Otherwise, there are so many missed opportunities when you don't give information to young people, those that are in school. I know Minister of Education doesn't want it, and it's understandable. Yeah.
Thank you very much, Ms. Juliana. I will ask Dr. Isabelle to say something about male involvement, how we can get our male counterparts to support the women to take up family planning.
Thank you so much. We know that male involvement across all interventions is still lagging behind. But a lot can be done to involve men. When we talk about health education and sensitization programs, we normally target ladies, children in our outreaches, but we miss out key points. You know, many men have what we call informally evening lessons. Can we try to extend our hours when we take health education programs to the community to reach out to where men hang during the evenings? On weekends, they are in those community halls watching Man versus us. We can always, we've tried it out, get to the owners of such places to air clips before the games. They air out clips on family planning and other health health services. In cities, we can go to factories, liaise with the HR departments to have topics. Our health workers go and talk to men about issues of family planning. Then, the few who accompany their ladies for services, we should not lock them out. Actually, I'm happy the new design for maternity blocks Ministry of Health has rolled out. They have rooms for men who are waiting for their ladies, and the screen is there in, should air messages on family planning. And then we have agents like the VHTs and the CHUs. Can we have them with the packages, including IEC materials, to go do home visits on weekends when men are mainly at home and interact with men? Clearly targeting men. Thank you so much.
Thank you very much. We have another round of questions. Any expectations for funding, continuous mentorships, workshops, sponsorship from Pathfinder? So the answer is yes. I'll quickly say yes to that. Does the government have interest in and plans for advancing male contraception methods? What is the experience of health workers on male contraception? Dr. Rodney, is this something you can talk about? Does the government have interest in and plans for advancing male contraception methods?
Thank you. Thank you, Dr. Rita. So far, the main male contraception methods that we are advancing as a government is probably the condom, the male condoms that we have, that does both prevention of STIs, HIV/AIDS, and also is used for contraception. It's multi-purpose. A few individuals have also opted for vasectomies as a male contraception method, and it's encouraged by the government. So mainly we are pushing for condoms as a 3-in-1 so far. The vasectomy is choice-based. Thank you. And what's the experience of health workers on male contraception methods? I think most of the males here have used condoms. Not all of them have done vasectomies, so I cannot talk for those who have done vasectomies. Thank you.
Thank you very much. All service delivery points at facility must have family planning corners. I hope that's family planning corners with staff to offer the methods. Anyone wants to respond to that? Yes or no? Thank you. We need to have Depo, Sayana, and condoms in private market. I think this is something that UNFPA is working on.
Yes.
So the answer is yes. Thank you for that suggestion. So we will let these questions continue running, and I really encourage you to get one of the panel discussants or a colleague and continue the conversation to get questions and to get answers to the questions that have been put forward. I want to request you to join me to put your hands together for the panel members for such a rich and very informative session this afternoon. Thank you all for being very good listeners. And I must say, I'm different from when I came in. I have learned a lot from the different people's experience, and I hope you too have had a very informative session. Thank you.
Thank you. Join me in ushering them off the podium. Thank you so much, our experts. With your knowledge, we continue to build and do better. And again, thank you so much for your time. This session was supposed to end at 5. All of you now note that it is 6 p.m. Fortunately, I think we have done better than maybe other sessions. Clap for yourselves again. We arrived in time and we've been able to run and finish fast. But thank you so much. And at this time, allow me to say this is the end of this session. We will respond to all the questions that have been put before us. The panelists are going to provide answers, and they will be shared all to you so that everyone, including those who are not here, can benefit. But in the interest of time, we end here. Thank you so much. We love you.
So we finish. Saya kita apa? Yang nama kita sama selalu kita. Thank you.